Affairs. I'm Representative Teresa Peirce, and we're going to get started today after a few housekeeping announcements. You may recall that we had a snow day on Tuesday, so this morning we'll be hearing the testimony and the public hearing aspect that we had scheduled for Tuesday afternoon, the 16th this morning. So welcome to people who are coming for that part of our biennial public hearing. I'd like to remind everyone, if you can, to update your name on the screens in front of you on your Zoom screen to let us know who you are, either representative or senator, and what committee you're from. I think that really helps the public understand who's talking and who's listening and what we're doing here. I think everyone should know how to do that, but you just hover on your box. There's a little screen at the top with 3 buttons. Click on that, it'll say rename, and you can choose your name. We also today, in addition to having public testimony from Commissioner Lambrou, we'll definitely have, we have some attendees coming in to give us public testimony for this morning's session. So we look forward to that as well. Welcome to everyone again. I think I'll start with introductions of the AFA committee. If you could raise your hands, I want to make sure I don't miss anyone that's here. And I think we'll start with Representative Fay.
Good morning, everyone. I'm Jessica Fay. I represent House District 66, which is parts of the towns of Raymond, Poland, and Casco.
Thank you. Representative Cardone.
Hello, I'm Barbara Cardone. I represent House District 127, which is part of Bangor.
Representative Corey.
Thank you, Madam Chair. Good morning. I'm Patrick Quarry. I represent House District 25, which is part of Windham.
Representative Cloutier.
Thank you, Madam Chair. Good morning, friends. I am Kristen Cloutier. I represent House District 60, which is part of Lewiston.
Representative Fecteau.
Thank you, Madam Chair. I'm Justin Fecteau, and I proudly represent District 86, which is the western and northern portions of Augusta.
And Representative Hymanson.
Good morning, everyone. I'm Representative Patty Hymanson. I represent House District 4, which is parts of York, Wells, Sanford, and all of Ogunquit.
Thank you. Representative Millett.
Good morning. I'm Selwyn Millett. I represent House District 71, including the towns of Norway, Sweden, Waterford, and West Paris.
Senator Davis.
Good morning. My name is Paul Davis. I represent Senate District 4, which is all of Piscataquis County and parts of Somerset and Penobscot.
Senator Bailey.
Thank you, Madam Chair. Good morning, everyone. I'm Senator Donna Bailey. I proudly represent the residents of Senate District 31, which is Saco, Old Orchard Beach, Hollis, Leamington, and part of Buxton.
Thank you. Chair Breen.
Good morning. Thank you, Madam Chair. I'm Kathy Breen. I represent 6.5 communities in Cumberland County in the Maine Senate, and I serve as Senate Chair of Appropriations.
And once again, I'm Representative Teresa Peirce. I'm the House Chair of Appropriations. I represent District 44, which is the majority of Falmouth. I'd like to, at this time, have the HHS committee members raise their hand. And if you're an AFA-er with your hand still up, maybe you can put your hand down. And then I might turn to Senator Claxton to help us introduce his committee.
Thank you, Madam Chair. I'll start with Representative Griffin.
Good morning. My name is Abigail Griffin, and I represent House District 102, which is Glenburn, Levant, and Kenduskeag.
Representative Craven.
Good morning. Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good morning. My name is Colleen Madigan. I represent House District 110, which is parts of Waterville and a part of Oakland.
Representative Zager.
Good morning, Mr. Chair. Good morning, everyone. Sam Zager. I represent District 41, part of Portland.
Representative Lemelin.
Good morning. My name is Michael Lemlin. I represent District 88, which is Chelsea, Jefferson, Whitefield, and half of Noblesboro.
I think I saw Representative Stover out there.
Yes, good morning. Thank you. My name is Holly Stover. I represent House District 89, including the 6 coastal towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Thank you. Senator Baldacci.
Good morning. I'm Joe Baldacci. I represent District 9, which is the city of Bangor and the town of Herman. I thank you, Mr. Chairman. I was not able to be here yesterday because of state and local government, so excuse my absence there, but I appreciate, I'm looking forward to this hearing. Thank you.
Representative Javner.
Thank you, Senator Claxton. I am Representative Kathy Javner, and I represent House District 141, which is located in Penobscot in Washington County.
Senator Moore.
Good morning. Thank you, Senator Claxton. My name is Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Good morning, and thank you, Mr. Chair. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott and parts of South Berwick and Kittery.
And I'm Ned Claxton. I'm proud to represent Senate District 20 and the folks who live there. That includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. Thank you, Madam Chair.
Thank you, Senator. Welcome to everyone from the HHS committee. We're delighted to have you here on day 2 of our HHS public hearings for the biennial. Representative Martin, are you online with us to introduce yourself? I'm not seeing you. Representative Martin? I'm sure he'll be joining us shortly. I also want to recognize that we are ably assisted by Maureen Dawson and Mandy Shore from our OFPR offices, in addition to all the IT people behind the scenes that are doing such an amazing job helping us weather the storm, so to speak, and be online. So thank you to everyone. So as I stated at the beginning, we're on day 2 of our public hearing of the biennial. We are hearing the DHHS part of the budget. We are joined today by Commissioner Lambrou and a number of her staff members, which I'll let her introduce at the appropriate moment. We'll be hearing public testimony from the commissioner. We'll take some questions, and then we also have public testimony from people out in the world, so to speak. So without further ado, Commissioner Lambrou, thank you so much for joining us today. We look forward to hearing your testimony.
Morning. Senator Breen, Representative Peirce, Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Appropriations and Financial Affairs, and members of the Joint Standing Committee on Health and Human Services. My name is Jean Lambrou. I am the Commissioner of the Department of Health and Human Services, or DHHS. I am here today to speak in support of LD 221, the Governor's biennial budget proposal for state fiscal year 2022 and 2023. As Governor Mills has said, at a time when Maine people are hurting, when small businesses are struggling to keep their doors open, when the ranks of the unemployed have swelled, and when we are fighting a deadly virus all around us, we are proposing balanced budgets as required by the Constitution that continue efficiencies, good fiscal management, and curtailments to cover projected revenue shortfalls for all 3 fiscal years. They focus on combating the COVID-19 pandemic by continuing to rebuild the state's public health infrastructure and protecting healthcare, education, and life-saving services. They do not change Maine tax rates, and they maintain the Budget Stabilization Fund. With a future made unpredictable due to the ongoing pandemic, these budgets make good on the promise of government, which is to protect and support the well-being of our people and institutions. Governor Mills' DHHS budget proposal for the fiscal year 2022 and 2023 biennium continues policy efforts initiated at the outset of her administration, rebuilding critical parts of state government, such as services for Maine's most vulnerable residents and public health infrastructure. It strengthens healthcare to better serve and protect Maine families. Considering the acute and unprecedented demand on Maine's health and human services infrastructure, these investments continue to be timely, important, and responsible. Amid the difficult fiscal environment of the COVID-19 pandemic, the biennial budget balances targeted increases in necessary spending while reducing expenditures through efficiencies and maximizing federal funding, while avoiding layoffs and preserving vital services. I am going to turn to Deputy Commissioner Benjamin Mann to continue to walk committees through the initiatives. The Deputy Commissioner is our leader and expert on these initiatives, having worked with each office and division in the department, staffs, and the Governor's office on these policies. Even if we weren't in a state of emergency, with much of my time spent on COVID-19 response, the Deputy Commissioner would be presenting the budget proposal to ensure that your questions can be answered as accurately and as completely as possible. I will turn this over to the Deputy Commissioner in 1 second, but as you all know, Molly Boker, our Director of Governmental Affairs, is a resource for all the committees for the legislature and is also happy to answer questions. So with that, I'll turn it over to Deputy Commissioner Mann.
Thank you, Commissioner.
Thank you, Commissioner. Good morning, everyone. We'll walk through the initiatives as outlined on the committee's website in that order. I believe you have my testimony going that I'll be reading off of today as well. The first section is departmental administration. The first program is on page A222, is data research and vital statistics. This program administers Maine's vital statistics system and provides quantitative information for surveillance, planning, policy development, program management, and evaluation, producing detailed population estimates and compiling data on health systems and health resources. This program has one initiative. The initiative is on page A222, and it reduces funding on a one-time basis for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $216 in state fiscal years 22 and 23. The next program is on page A223, is Department of Health and Human Services Central Operations. This program provides general administrative support services for the Department of Health and Human Services. This program has 4 initiatives. The first initiative on page A223 continues one limited period public service coordinator 2 position previously continued by financial order 001110F1, funded 60% general fund and 40% other special revenue funds in the central operations program, and provides funding for all other costs. This program ends on June 17th, 2023. This initiative provides general fund personnel services funding of $83,737 in state fiscal year 22 and $86,631 in state fiscal year 2023. General fund all other funds of $3,813 in state fiscal year 22 and 23, and increases allocation in the other special revenue funds, personal services by $55,824 in state fiscal year 22 and $57,752 in state fiscal year 2023. And other special revenue funds, all other funding by $3,884 in state fiscal year 2022 and $3,937 in state fiscal year 2023. Second initiative in this section is on page 223, reduces funding on a one-time basis for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic based on prior year expenditures. This initiative reduces general fund all other funding by $49,702 in state fiscal years 22 and 23. The next initiative is on page A224, reduces funding on a one-time in the Department of Health and Human Services Central Operations Program due to savings achieved by office space consolidation. This initiative reduces general fund all other funding by $173,760 in state fiscal years 22 and 23, and reduces allocation in other special revenue funds, all other, by $99,989 in state fiscal years 22 and 23. The next initiative and the final one in this section is on page 224 and establishes one senior legal advisor position subject to appointment by the Commissioner of the Department of Health and Human Services and and provides all related all other costs. This initiative provides general fund personal services funding of $94,741 in state fiscal year 22 and $99,459 in state fiscal year 2023. General fund all other funds of $3,813 in state fiscal year 22 and 23, and increases allocation in other special revenue funds, personal services by $63,160 in state fiscal year 22 and $66,306 in state fiscal year 23, and other special revenue funds, all other by $5,082 in state fiscal year 22 and 23. The next program on page A225 is department-wide. This program serves as a placeholder to record funding adjustments that are subsequently reallocated to the appropriate programs. This program has one initiative. The initiative is on page A225 and reduces funding one time from the identification of an efficient professional agreement. This initiative reduces general fund all other funding by $2.25 million in state fiscal year 22 and 23. The next program on page A233 is Division of Licensing and Certification. This
Madam
program,
Chair.
Deputy Director, could you hold just for a second? I think we have a question from Representative Cloutier.
Yes, thank you. So you were cutting out in the description for page 225 under department wide. Could you just go back and say that again?
certainly, sorry about that.
Thank you.
225, this program serves as a placeholder to record funding adjustments that are subsequently reallocated to the appropriate programs. This program has one initiative. Do you want me to read the initiative again? The initiative on page A225 reduces funding one time from the identification of efficiencies and underutilized professional services agreements. This initiative reduces general fund all other funding by $2,250,000 in state fiscal years 22 and 23. The next program on A233 is Division of Licensing and Certification. This program licenses medical and long-term care facilities, assisted living, residential care, private non-medical institutions, mental health service providers, substance use disorder agencies, and programs and services to children. Registration of CNAs and direct care workers and the operation of the main background check center are also part of the responsibilities of this program. The program also regulates healthcare facilities and providers under the Certificate of Need Act, Health Safety Act, Health Maintenance Organizations, the Hospital Cooperation Act, and laws pertaining to continuing care retirement communities and main care approval for capital expenditures by long-term care facilities. This program has four initiatives. The first initiative is on page A233, transfers and reallocates one senior health care financial analyst position from 35% general fund and 65% other special revenue funds to 100% other special revenue funds within the same program, and transfers funding for related all other costs. This initiative reduces general fund personal services funding by $44,061 in state fiscal year 2022 and $44,359 in state fiscal year 2023, and general fund all other funds by $2,224 in state fiscal years 2022 and 2023, and increases allocation in other special revenue funds personal services by $44,061 in state fiscal year 22 and $44,359 in state fiscal year 2023, and other special revenue funds all other by $3,289 in state fiscal year 22 and $3,296 in state fiscal year 23. The next initiative is on page A233, reduces funding as a result of ongoing efficiencies in the Division of Licensing and Certification Program. This initiative reduces general fund all other funding by $300,000 in state fiscal year 22 and 23. The third initiative on page A234 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $36,051 in state fiscal years 2022, and 2023. The next and final initiative in this section is on page A234 and adjusts funding to align with existing resources. This initiative increases allocation in other special revenue funds, all other, by $319,865 in state fiscal years 2022 and 2023. The next initiative is on page A264, medical care payments to providers. This program funds Medicaid services administered by the Office of Main Care Services. This program has 29 initiatives that will be seen throughout all 3 sessions of public hearings rather than under one program heading. The first initiative on page A265 adjusts funding as a result of the increase in federal medical assistance percentage, otherwise known as FMAP, for federal fiscal years 2021, 22, and 23. This initiative reduces general fund all other funding by $927,466 in state fiscal year 2022 and by $2,298,863 in state fiscal year 2023, and increases allocation in federal expenditures fund all other by $3,265,741 in state fiscal year 2022 and $5,442,901 in state fiscal year 2023. Reduces allocation in federal block grant fund all other by $1,152,872 in state fiscal year 22 and $1,168,392 in state fiscal year 2023. And reduces funding in Fund for Healthy Maine all other by $102,885 in state fiscal year 22 and by $171,475 in state fiscal year 2023. The next initiative on page A269 adjusts funding in the Medicaid dedicated tax accounts and the corresponding general fund accounts to bring baseline resources in line with the December 2020 Revenue Forecasting Committee recommendations. This initiative provides general fund all other funding of $2,038,111 in state fiscal year 2022 and state fiscal year 2023, and reduces allocation in other special revenue funds by that same amount in the same fiscal years. The next initiative on page A269 increases funding in medical care payment to providers program and decreases funding in low-cost drugs to Maine's elderly program, the Mental Health Services Community Medicaid program, and the Office of Substance and Mental Health Services Medicaid Seed program to consolidate the
Deputy Director, I don't know if it's me, but you're going in and out. Or is that happening for other people? Yeah, I don't know if it's where you are in relation to your mic, but there's a definite issue there. And it just got a little bit worse. So thank you. I appreciate the speed at which you're reading. I know it's a little slower than yesterday. I think people are able to follow along and turn to the appropriate pages. Great. So now it's just your mic. Let's go from there. Thank you.
Certainly. I'll start that section over. Can you hear me better now?
Yes, thank you.
The first initiative on page A265 adjusts funding as a result of the increase in, I'm sorry. We covered that. I will go to page 269. I believe we are on low-cost drugs to Maine's elderly program.
Correct.
This third initiative on page A269 increases funding in the medical care payments to providers program and decreases funding in the low-cost drugs to Maine's elderly program, Mental Health Services Community Medicaid program, and the Office of Substance Abuse and Mental Health Services Medicaid Seed program to consolidate the 4 Medicaid assistance programs into one program as part of the consolidation of Maine care-related programs from 13 appropriations to 4 appropriations. This initiative provides general fund all other of $47,718,638 in state fiscal years 22 and 23. The next initiative on page A271 increases funding in the medical care payments to providers program and decreases funding in the Mental Health Services Community Medicaid program, the Office of Substance Abuse and Mental Health Services Medicaid Seed, and Medicaid Services Developmental Services program to consolidate 4 programs into one program as part of the consolidation of Maine care-related programs and accounts. This initiative increases allocation in other special revenue funds, all other, by $4,580,000 in state fiscal year 22 and 23. The next program on page A286 is the Office of Advocacy. This contracted advocacy service for developmental services as set forth in 34B MSRA, Chapter 5005-A. This program has one initiative. This initiative on page A286 transfers funding for an advocacy contract from the Developmental Services Community Program, Office of Advocacy, BDS program, and the Brain Injury Program, General Fund, to the Office of Main Care Services Program, Federal Expenditures Fund. This initiative reduces General Fund all other by $163,088 in state fiscal year 22 and 23. The next program on page A295 is the Office of Main Care Services. This program administers the Medicaid program. This program has 8 initiatives. The first initiative is on page A295 and it reallocates 3 mental health disability, developmental disability caseworker positions, 2 human services caseworker supervisor positions, 6 human services caseworker positions, and 1 regional supervisor position from 100% general fund in the developmental services community program to various splits between the general fund and the developmental services community program and federal expenditures fund in the Office of Main Care Services program to align with duties and adjust all other. This initiative increases allocation in the federal expenditures fund personal services by $294,012 in state fiscal year 22 and $298,066 in state fiscal year 2023. And federal expenditures fund all other by $26,124 in state fiscal year 22 and $26,232 in state fiscal year 2023. The next initiative on page A295 provides funding to contract with a provider to implement and provide technical support for the use of a standardized developmental disability needs assessment. This initiative increases allocation in the federal expenditures fund all other by $843,983 in state fiscal years 22 and 23. The next initiative on page A296 reduces funding in the Office of Main Care Services program by recognizing ongoing savings achieved through general efficiencies and reestablishing priorities. This initiative reduces general fund all other funding by $500,000 in state fiscal years 22 and 23. The next initiative on page A296 establishes 1 public health nurse consultant position funded 25% general fund with Maine Center for Disease Control and Prevention program and 75% other special revenue funds in the Office of Main Care Services program to oversee a mortality review committee for the home and community-based services waiver programs to ensure federal compliance, and provides funding for related all other costs. This initiative increases allocation in federal expenditures fund personal services by $87,673 in state fiscal year 22, $91,461 in state fiscal year 2023, and federal expenditure funds all other by $6,893 in state fiscal year 2022 and $6,910 in state fiscal year 2023. The next initiative on page 296 transfers funds for an advocacy contract from Developmental Services Community Program, Office of Advocacy, BDS program, and the Brain Injury Program General Fund to the main Office of Main Care Services program, Federal Expenditures Fund. This initiative increases allocation of federal expenditure funds, all other, by $233,001 in state fiscal years 22 and 23. The next initiative on page A296 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $3,767 in state fiscal years 22 and 23. The next initiative on page A296 reallocates 1 human services caseworker supervisor position from 100% general fund in the Office of Aging and Disability Services, Adult Protective Services program to 83% general fund in the Office of Aging and Disability Services Adult Protective Services Program, and 17% federal expenditures fund in the Office of Main Care Services Program, and adjusts all other. This initiative increases allocation in federal expenditures fund personal services by $18,700 in state fiscal year 22 and $18,850 in state fiscal year 2023. And federal expenditures funds all other by $2,178 in state fiscal year 22 and $2,186 in state fiscal year 2023. The next initiative on page A296, adjust funding to align with existing resources. This initiative increases allocation in federal expenditures fund all other by $1.4 million in state fiscal years 22 and 23. That completes the initiative pieces in this section. There we'll move on to the language pieces that are associated with them. The first piece of language for the department is on page 33 and 34L, part MM. This part accomplishes the following. It changes the representative.
I'm sorry, Madam Chair, can we just have a second to get to that language page?
Certainly, we're going to page 33 of language.
Thanks.
In the
It
back
just
of-
takes me a couple minutes to flip the pages in my book.
Not a problem.
Appreciate it. I'm all set now.
If you don't mind, thank you. You can continue. I appreciate your stopping.
First piece of language for the department is on page 33 and 34L, part MM. This part accomplishes the following. It changes the representatives that inspect establishments for the Office of Main Care Services to the Division of Licensing and Certification. Secondly, it removes the requirement that the department conduct a single coordinated inspection of a facility duly licensed as a nursing facility, nursing home, and an assisted housing facility. This requirement is not feasible as nursing facilities are inspected based on their federal certification requirements, which varies year to year between 9 and 15 months, and assisted housing licensure inspections are done every 2 years to coincide with the term of licensure. The next submitted language is on page 37 and 38L, part QQ. This part changes the frequency of life safety inspections from annual to prior to the issuance of the license, which is every 2 years. The next submitted language is on page 38L, part RR. This part establishes a senior legal advisor in the Department of Health and Human Services that is appointed by the commissioner and serves at the pleasure of the commissioner. The next submitted language is on page 38 and 39L, part SS. This part contains transition provisions for the consolidation of general fund programs from 13 appropriations to 4 appropriations in the Department of Health and Human Services, Office of Main Care Services. Additionally, all existing contracts, agreements, and compacts currently in effect in the Department of Health and Human Services continue in effect. The next submitted language is on page 40 and 41L, part WW. This part authorizes the Department of Health and Human Services to adopt emergency rules to implement any provisions of this act over which it has specific authority that has not been addressed by some other part of the act without the necessity of demonstrating that immediate adoption is necessary to avoid a threat to public health, safety, or welfare. The next submitted language is on page 41L, part XX. This part authorizes the transfer of all other balances from any account within the Department of Health and Human Services, excluding balances of the 4E foster care adoption assistance and state-funded foster care adoption assistance programs for the purpose of the Information Systems Modernization Project in the Office of Aging and Disability Services. The next submitted language is on page 42L, part ZZ. This part authorizes the Department of Health and Human Services to transfer available balances of appropriations between main care general fund accounts for the 22 and 23 biennium. The next and final piece of language in this section is on page 44L, part EE. This part lapses $60 million of the unencumbered balance forward of the Department of Health and Human Services Medical Care Services General Fund account to the general fund in fiscal year 21-22.
Deputy Commissioner. I thought we might take a break as we change sections to social services so people can get back to the page within A222, 218 that we're going to, and give you a moment to rest your voice. It's a long testimony. So we're moving back to the sections of A. We'll be on page A218 under the social services part of this budget. And looks like people are organized. So whenever you're ready, please begin.
Thank you, Representative. We'll move along to the social services section. The next program on A218 is Community Services Block Grant Program. This program provides local services to low-income families to reduce malnutrition, provides safe and stable housing, and assist families in reaching their maximum self-sufficiency. This program has no initiatives. The next program on page A280 is Multicultural Services. This program improves the quality, integrity, and responsiveness of services and supports that are provided to consumers and family members and service providers and staff. This program has one initiative. The initiative on page A280 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic based on prior year expenditures. This initiative reduces general fund all other funding by $170 in state fiscal year 22 and 23. The next program can be found on page A306 and Purchase Social Services. This program purchases community-based social services such as home-based services, employment services, childcare, family violence, sexual assault, and transportation services for families with low income. This program has two initiatives. The first initiative is on page A306, reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. The initiative reduces general fund all other funding by $495 in state fiscal year 22 and 23. The next initiative on the same page, A306, adjusts funding to align with existing resources. This initiative increases allocation in federal expenditures fund, all other, by $2.1 million in state fiscal years 22 and 23. We're going back to an earlier section in the budget. You can find that starting on page 213, and this is the public health section. The next program on page A213 is AIDS Lodging House. This program supports AIDS Lodging House, which provides housing for people with HIV/AIDS who are able to live independently. The AIDS Lodging House no longer exists, and these funds are dispersed through a local community-based organization. This program has no initiatives. The next program on page A215 is Breast Cancer Special Program Fund. This fund was established from the sale of the Maine Breast Cancer Support Services license plates and must be used for breast cancer support services. The Maine Breast Cancer and Cervical Health Program utilizes 1/3 of this fund's distribution to provide for early detection of breast cancer for low-income women enrolled in this program. This program has no initiatives. The next program can be found on page A237, is the Drinking Water Enforcement Program. This program assesses fees on public drinking water supplies and retains primary enforcement authority and regulatory control of the federal drinking water law. This program has one initiative. The initiative on page 2 of A237 adjusts funding to align with existing resources. This initiative increases allocation in other special revenue funds, all other, by $275,000 in state fiscal years 22 and 23. The next program on page A249 is the Maine Center for the Disease Control and Prevention. This program is responsible for public health, including the surveillance of disease and health status, the development of health policy, and ensuring quality services. This program has 19 initiatives. The first initiative is on page A249, transfers 1 Public Service Manager 3 from the Office of Substance Abuse and Mental Health Services program to the Maine Center for Disease Control and Prevention program within the same fund and transfers funding for all other costs. This initiative provides general fund personal services funding of $153,912 in state fiscal year 22, and $155,169 in state fiscal year 23, and general fund all other funding of $6,354 in state fiscal years 22 and 23. The next initiative on page 250 establishes 8 public health inspector 1 positions to reduce the health inspection program backlog and to improve capacity to assure meeting the statutorily required inspection frequency rate, and provides funding for all other costs. This initiative provides general fund personal services funding of $662,552 in state fiscal year 22 and $693,288 in state fiscal year 23, and general fund all other funding of $50,832 in state fiscal years 22 and 23. The next initiative on page A250 provides allocation to align with available resources. This initiative increases allocation in other special revenue funds, all other, by $1,227,612 in state fiscal year 22 and 23. The next initiative on page 250 establishes 3 comprehensive health planner 2 positions funded 100% general fund in the Maine Center for Disease Control and Prevention program. It also provides funding for related all other costs and transfers general fund all other to personal services to fund a portion of these positions. This initiative provides general fund personal services of $282,717 in state fiscal year 22 and $296,754 in state fiscal year 23, and reduces general fund all other by $55,568 in state fiscal years 22 and 23. The next initiative on page A250 transfers and reallocates 1 public service coordinator 3 position from 25% general fund and 75% federal expenditures fund to 100% general fund within the same program, and adjusts funding for all other, related all other. This initiative provides general fund personal services funding of $222,060 in state fiscal year 22 and $222,775 in state fiscal year 23, and provides general fund all other funding of $4,766 in state fiscal years 22 and 23, and reduces allocation in federal expenditures fund personal services by $222,060 in state fiscal years 22 and $222,775 in state fiscal year 23, and reduces allocation in federal expenditures fund all other by $9,985 in state fiscal year 22 and $10,000 too in state fiscal year 23. The next initiative on page A251 provides funding for the proposed reclassification of 1 office assistant 2 position to an accounting technical position funded 93% other special revenue funds and 7% general fund in the Maine Center for Disease Control and Prevention program to increase staffing levels to be able to perform the required duties. This initiative provides general fund personal services funding of $4,016 in state fiscal year 22 and $3,939 in state fiscal year 23, and general fund all other funding of $445 in state fiscal year 22 and 23, and increases allocation in the other special revenue funds personal services by $2,462 in state fiscal year 22 and $2,412 in state fiscal year 23, and other special revenue funds all other by $492 in state fiscal year 22 and $484 in state fiscal year 2023. The next initiative on the same page, page A251, continues 1 limited period Chemist 2 position and 1 limited period Chemist 3 position previously continued by Public Law 19, Chapter 343, and 1 limited period business manager 2 position previously continued by Financial Order 001131F1, and provides funding for related all other costs. These positions will end on June 17th, 2023. This initiative provides general fund personal services funding of $330,449 in state fiscal year 2022 $335,139 in state fiscal year 2023, and general fund all other funding of $19,062 in state fiscal years 22 and 23. The next initiative on page A251 establishes 1 microbiologist 3 position, 1 microbiologist 2 position, and 1 public service manager 2 position, and provides funding for all other related costs. The initiative provides general fund personal services funding of $314,349 in state fiscal year 2022 and $329,666 in state fiscal years 23, and provides general fund all other of $19,062 in state fiscal years 22 and 23. The next initiative on page A251 establishes 1 epidemiologist position to strengthen internal epidemiology expertise to assist with chronic disease prevention. Also provides funding for all other costs related to all other, and transfers all other to personal services to partially fund the position. The initiative increases allocation in federal expenditures fund personal services by $94,239 in state fiscal year 2022 and $98,918 in state fiscal year 2023, and reduces allocation in federal expenditures funds all other by $53,379 in state fiscal year 22 and $53,271 in state fiscal year 2023. The next initiative on page A251 establishes 1 public health nurse consultant position funded 25% general fund within the Maine Center for Disease Control and Prevention, and 75% other special revenue funds in the Office of Maine Care Services program to oversee a mortality review committee for all home and community-based services waiver programs to ensure federal compliance, and provides funding for related all other costs. This initiative provides general fund personal services funding of $29,223 in state fiscal year 22 and $30,485,000 in state fiscal year 23, and provides general fund all other of $1,589 in state fiscal years 22 and 23. The next initiative on page A252 provides funding to support development of a strategy and one-time investments in public health infrastructure to reduce disparities in outcomes for Maine residents in minority groups. This initiative provides Fund for Healthy Maine all other funds of $1 million in state fiscal years 22 and 23. The next initiative on page A252 continues 5 limited period environmental specialist 3 positions previously continued in Public Law 2019, Chapter 343, and 3 limited period environmental specialist 3 positions previously established in Public Law 2019, Chapter 343, and provides funding for related all other costs. Also provides all other funding for the continuation of lead inspection services and associated laboratory costs. These positions will end on June 17th, 2023. This initiative provides general fund personal services funding of $700,008 in state fiscal year 2022 and $722,454 in state fiscal year 2023. It provides general fund all other funding of $50,832 in state fiscal years 22 and 23. The next initiative on page A252 provides funding for the proposed reclassification of 2 public health inspector 2 positions to Public Health Inspector 2 supervisory positions, and proposed reclassification of 1 Office Assistant 2 position to an Office Associate 2 position. This initiative increases allocation in other special revenue funds, personal services by $12,548 in state fiscal year 2022 and $19,564 in state fiscal year 2023. The next initiative on page A252 establishes 2 comprehensive health planner 2 positions in the Maine Center for Disease Control and Prevention program general fund to assist to the building infrastructure with public health emergency preparedness services program. This initiative provides general fund personal services funding of $188,478 in state fiscal year 22 and $197,836 in state fiscal year 2023, and provides general fund all other funding of $12,708 in state fiscal year 22 and 23. The next initiative on page 252 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic based on prior year expenditures. This initiative reduces general fund all other funding by $6,447 in state fiscal years 22 and 23. The next initiative on page A252 establishes one limited period systems analyst position and one limited period inventory property associate 1 position through June 2023. This initiative provides general fund personal services funding of $178,480 in state fiscal year 2022 and $185,955 in state fiscal year 2023, and provides general fund all other funding of $12,708 in state fiscal years 22 and 23. The next initiative on page A253 reallocates the cost of 43 positions currently funded in the Federal Expenditures Fund and all other special revenue funds to charge all positions within the Health and Environmental Testing Laboratory to the Federal Expenditures Fund, other special revenues funds, and general fund. Position and allocation detail is on file with the Bureau of the Budget. This initiative provides general fund personal services funding of $1,960,596 in state fiscal year 2022 and $2,014,244 in state fiscal year 2023, and increases allocation in federal expenditures fund personal services by $10 in state fiscal year 22, and reduces the allocation in the federal expenditures fund personal services by $572 in state fiscal year 2022, and reduces allocation in other special revenue personal services by $1,960,606 in state fiscal year 22, and $2,013,672 in state fiscal year 2023. The next initiative on page A253 provides funding in the Maine Center for Disease Control and Prevention Health and Environmental Testing Lab for maintenance agreements for laboratory equipment and laboratory supplies. This initiative provides general fund all other funding of $535,847 in state fiscal year 2022 and $432,927 in state fiscal year 2023. The final initiative in the public health section is on page A253, and it reallocates the costs of 16 various positions within the health inspection program. Position detail is on file with the Bureau of the Budget. This initiative provides general fund personal services funding of $547,014 in state fiscal year 2022 and $557,166 in state fiscal year 2023. Reduces allocation to other special revenue funds, personal services by $547,014 in state fiscal year 22 and $557,166 in state fiscal year 2023. The next initiative is from the medical care payment to providers. We're moving to page 266. The initiative on page A266 adjusts funding for changes instituted in the Maine Integrated Health Management Solution System to require providers to follow certain billing procedures necessary to correctly identify family planning claims. This initiative reduces general fund all other by $1,204,165 in state fiscal year 2022 and $1,200,471 in state fiscal year 2023. And increases allocation in federal expenditures, all other, by $1,204,165 in state fiscal year 2022, and $1,200,471 in state fiscal year 2023. The next program is on page A255. And that's the Maine Health Insurance Marketplace Trust Fund. The Maine Health Insurance Marketplace supports Maine consumers in purchasing individual health insurance by providing marketing and outreach, individual assistance, and a platform for shopping and enrollment. The funding in this program is derived from a user fee charge on insurance companies offering plans in the marketplace. This program has no initiatives. The next program is on page A256. It's the Maine School Oral Health Fund. This program promotes health through education, motivation, surveillance, and implementing public health policies. This program has no initiatives. The next program on page A257 is the Maine Water Well Drilling Program. This program licenses and regulates well drilling contractors, drillers, and pump installers to ensure protection of groundwater supply. This program has no initiatives. The next program is on page A258. It's the Maternal and Child Health Program. This program supports the salary and fringe benefits for employees that provide direct services and preventative health education programs that provide the health status of Maine women of reproductive age, infants, children, and families statewide. This program has two initiatives. The first initiative is on page A258 and transfers one public health nurse supervisor position, two public health nurse 2 positions, and one public health nurse 1 position from the Maternal and Child Health Program Federal Block Grant Fund to the Maternal and Child Health Block Grant Match Program General Fund in order to maintain the compliance with the required ratio of targeted populations according to the current Maternal Child Health Block Grant Work Plan. This will also provide greater flexibility with nursing resources to respond to public health needs. Transfers, this initiative transfers general fund all other to personnel services to fund the positions. This initiative reduces allocation of the federal block grant personal services by $433,964 in state fiscal year 2022 and $448,027 in state fiscal year 2023. And federal block grant all other by $9,986 in state fiscal year 22 and 23. The second initiative in this section is also on page A258 and adjusts funding to align with existing resources. This initiative increases allocation of the federal block grant, all other, by $92,071 in state fiscal years 22 and 23. The next program is on page A259 is the Maternal and Child Health Block Grant Match, This program supports a portion of the salary and fringe benefits of the Maine Center for Disease Control and Public Health District Liaisons. These funds purchase direct services and preventative health programs aimed at improving the health status of Maine women of reproductive age, infants, children, including children with special needs and their families. This program has two initiatives. The first initiative is on page A259 and transfers one public health nurse supervisor position, two public health nurse 2 positions, and one public health nurse 1 position from the Maternal and Child Health Program Federal Block Grant Fund to the Maternal and Child Health Block Grant Match Program General Fund in order to remain in compliance with the required ratio of targeted populations according to the current Maternal Child Health Block Grant Work Plan. This will also provide greater flexibility with nursing resources to respond to the public health needs. The initiative transfers general fund all other to personal services to fund the positions. This initiative provides general fund personal services of $433,964 in state fiscal year 22 and $448,027 in state fiscal year 2023. Reduces general fund all other by $433,964 in state fiscal years 22 and $448,027 in state fiscal year 2023. The next initiative is on page A259, reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $5,169 in state fiscal year 22 and 23. The next program is on page 303. That program is Plumbing Control Over. This program establishes the state plumbing and subsurface wastewater disposal system codes and licenses state evaluators to review plans and projects for the general public while representing a number of state agencies. This program has no initiatives. The next program is on page 305. It's the Prescription Drug Academic Detailing. Established by public law in 2007, Chapter 327, This program is intended to enhance the health of residents of the state, to improve the quality of decisions regarding drug prescribing, to encourage better communication between the department and healthcare practitioners participating in the publicly funded health programs, and to reduce the health complications and unnecessary costs associated with inappropriate drug prescribing. This program has no initiatives. The next program on page A305 is Private Well Safe Drinking Water Fund. Established by Public Law 2017, Chapter 230, as a carrying account. Funding is derived from all fees collected under Title 22, Section 2660-U, and from other funds accepted by the Commissioner or allocated or appropriated by the Legislature. Expenditures from the fund may be made only for the following purposes: to improve the rate of testing in residential private drinking water wells for contaminants, for educational outreach and programs, and to defray the department's costs in administering this subchapter and in waiving fees under Title 22, Section 2602-A, subsection 2. This program has no initiatives. The next program is on page A307, is the Rape Crisis Control. This program provides direct services available 24 hours a day to individual victims of rape and sexual assault while supporting community awareness and prevention. This program has no initiatives. The next program on page A316 is the Universal Childhood Immunization Program. The Childhood Immunization Fund is established for the sole purpose of providing the program, including any costs of vaccines provided under the program to children, and to any costs the Maine Vaccine Board may incur for staff, a service agent, administrative support services, legal representation, or contracted services. No portion of the fund may be used to subsidize other programs or budgets. This program has no initiatives. There's one piece of language associated with this section. We're switching over to the language.
You could just give everyone a minute to turn pages. That'd be great. Thank you. Well done on the 19 initiatives. That's a long section. So we're moving to page 35 in the language on this section of the budget. Great. Whenever you'd like to begin. Thank you.
The next submitted language item for this section is on page 35L, Part NN. This part removes the language which does not allow the transfer or otherwise repurpose of any funds appropriated or allocated for public health nurses and for services they provide. We're moving, that's the only piece of language in that section. We're moving back to the Part A of the budget and the public assistance section, which will begin on page 213.
So give us 1 sec to flip the pages. And whenever you'd like to begin, thank you.
Great. I'll begin on page A213 with the program Additional Support for People in Retraining and Employment. This program funds employment and training programs for people receiving temporary assistance for needy families, TANF. There are no initiatives in this program. The next program on A230 is disability determination. This program provides a timely and accurate and fair disability determination to Maine citizens filing under the Title II coverage-based or Title 16 low-income-based sections of the Social Security Act. This program has one initiative. The initiative is on page A230 and establishes one limited period disability claims supervisor position, and 10 limited period disability claims adjudicator positions, and 1 limited period office associate 2 position funded 100% federal funds within the disability determinations division, and provides funding for related all other costs. This initiative increases allocation in the Federal Expenditures Fund Personal Services by $988,712 in state fiscal years 2022 and $1,028,197 in state fiscal years 2023, and increases allocation in Federal Expenditures Fund All Other by $100,753 in state fiscal year 22 and $101,795 in state fiscal year 2023. This program is on page, the next program is on page 240. It's the Food Supplement Administration. This program administers the Supplemental Nutrition Assistance Program, or SNAP Ed program, and the Food Supplement Employment and Training Program. This program has one initiative. The initiative is on page 240 and reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $201 in state fiscal years 22 and 23. Next program is on page A242. It's a general assistance reimbursement to cities and towns program. This program provides assistance for basic necessities for those persons who do not have the income or resources to provide for themselves or their families. The program provides for a percentage of general fund expenditures within each municipality and administers a general assistance program in the unorganized territories. This program has no initiatives. The next program on page A284 is the Office of Family Independence. On page 284, this program assists individuals and families in achieving their maximum potential, independence, employability, safety, and health, working with them to become self-supporting, utilizing mandated federal programs and rules. This program has one initiative. The initiative on page A284 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic based on prior year expenditures. This initiative reduces general fund all other funding by $1,421 in state fiscal year 22 and 23. The next program is on page A285. It's the Office of Family Independence, the district account. This program determines eligibility and delivers direct services, including Supplemental Nutrition Assistance Program, or SNAP, Temporary Assistance to Needy Families, or TANF, Medicaid Emergency Assistance, State Supplement for Social Security, Alternative Aid, Transitional Transportation, Transitional Childcare, Transitional Medicaid Services, and regional offices. This program has three initiatives. The first initiative is on page A285 and continues 3 limited period family independence unit supervisor positions and continues 45 limited period customer representative associate 2 human services positions previously continued by Public Law 2019, Chapter 616, Part A, Section 7 through June 17th, 2023. Funded 37.9% general fund and 62.1% other special revenue funds within the Office of Family Independence District program, and provides funding for related all other costs. These positions will end on June 17th, 2023. This initiative provides general fund personal services funding of $1,184,695 in state fiscal year 22 and $1,235,775 in state fiscal year 2023. General fund all other funding of $115,592 in state fiscal year 22 and 23, and increases allocation in other special revenue funds personal services by $1,940,991 in state fiscal year 2022 and $2,224,918 in state fiscal year 2023, and other special revenue funds all other by $242,380 in state fiscal year 22 and $244,760 in state fiscal year 2023. The next initiative on page A285 provides allocation to align with available resources. This initiative increases allocation in other special revenue funds all other by $432,837 in state fiscal years 2022 and 2023. The next initiative on page A285 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $9,379 in state fiscal years 22 and 23. The next program is on page 311. It's the state supplement to the federal supplemental security supplemental security income. This program pays benefit. I'll give you a moment to get to page 311. This program pays beneficiaries of the Supplemental Security Income Program and is mandated to maintain federal Medicaid funding, and also supports the legislatively directed cash program for non-citizens who are eligible for federal SSI. This program has one initiative. The initiative is on page 311 and provides funding in the state supplement to the federal Supplemental Security Income Program to bring appropriations in line with projected expenditures. This initiative increases general fund all other funding by $689,907 in state fiscal year 22 and $920,688 in state fiscal year 2023. The next program is on page 314, is temporary assistance for needy families. The TANF program provides cash assistance to low-income families with children. Eligibility is determined through a comparison of family income and resources to a standard of need for food, clothing, utilities, and shelter. Special payment of up to $300 per month is provided to families whose selected shelter costs exceed 50% of their income. The TANF account also provides the cash assistance for the Parents as Scholars program for low-income families with children where one or both of the parents are attending as approved post-secondary education program. Alternative aid is a program for families needing resources to obtain or to continue employment and may only be received once. This benefit is equal to up to 3 months of TANF benefits. Emergency assistance is a once-a-year program for families to eliminate an emergency that stops them from moving forward towards self-support. This program has no initiatives. We're switching back over to the language section of the budget.
Thank you for giving us a second to get there. It's page 36 through 37. At your pleasure.
The next submitted language is on page 36 and 37L, Part PP. This part accomplishes the following. It changes eligibility for the transitional transportation to include families who are employed and have income less than 200% of the non-farm income poverty official poverty line. It allows the department to use federal TANF block grant to support employed families who have transportation costs and have income less than 200% of the non-farm income official poverty line. The department may use up to $1.4 million annually in the TANF block grant expenditures for these funds, for these families. The next submitted language is on page 39L, Part TT. This part authorizes any unexpended balance of the Office of Family Independence District Program General Fund account within the Department of Health and Human Services for the purpose of upgrades to the Public Assistance web portal be carried forward for use in the next fiscal year. The next submitted language is on page 42 and 43L, Part AAA. This part authorizes the Department of Health and Human Services to transfer available balances of personal services appropriations to all other in the Office of Family Independence Program and the Office of Family Independence District Program for the 22 and 23 biennium. The next submitted language is on page 43L, Part BBB. This part lapses $3 million of the unencumbered balance forward of the Department of Health and Human Services General Assistance, reimbursement to cities and towns, general fund account to the general fund in fiscal year 2022. The next submitted language is on page 43L, Part CCC. This part lapses $5 million of the unencumbered balance forward of the Health and Human Services, Department of Health and Human Services Temporary Assistance to Needy Families General Fund account to the general fund in fiscal year 2022. The next and final piece of language is on page 44L, Part DDD. This part lapses $10 million of the unencumbered balance forward, the Department of Health and Human Services, additional support for people in retraining and employment, otherwise known as the ASPIRE program, general fund account to the general fund in fiscal year 2022. That concludes the initiatives. Thank you for the opportunity for presenting this part of the governor's budget for 2022 and 2023.
Thank you, Deputy Commissioner Mann. I appreciate the cadence with which you read it today, which was very helpful, I think, to the committee members. So I appreciate it. I'm not seeing Commissioner Lambrou still on our call, but I know that Deputy Commissioner Mann is here and other members of the DHHS department. So I'll open it up to questions by either committee members. Please just raise your hands and we'll get going. Representative Heimlinson.
Thank you. A lot to chew over. I'm not finished chewing. And I really look forward to HHS committee reviewing the policy parts. I'm used to that position. And so I have a million questions related to that, which are not my part of the sausage machine anymore. But I'm interested in hearing more eventually about the carryover positions or the limited positions that we work so hard to get, like the lead positions in the first initiative. But I'm sure you'll go over those carefully with a fine-tooth comb. So I'm so the submitted language in Part WW authorizing the department to adopt emergency rules. That's a blanket statement that's carried over into everything by my understanding and our usage before, but it had to be put in this section because this is a new, can you explain why this language, which is current language and other things, had to be put here? In WW.
Yeah, so the WW is, we don't necessarily have the authority to pursue emergency rulemaking for any policy changes that would be required with rulemaking to main care for any rate changes, either increasing or decreasing. This gives us the authority to pursue emergency rulemaking related to those particular proposals.
Okay, because it is language that shows up in a lot of other different places, but it doesn't show up here, so you had to put it in. It is not new language. Is that, am I remembering that right?
We don't, I can pull more information for you, but how I think of this is that to implement all of the proposals that we are putting forward in the biennial budget in a timely manner, we don't have that authority to do emergency rulemaking for all of it. I don't have the list in front of me on which ones we don't have authority for, but this would allow us to pursue emergency rulemaking around that.
Okay. Could you get me the list of ones where we do have emergency rulemaking and ones that we don't, if that's a list that can be made?
Certainly.
That'd be great. Thanks.
Do you have any other questions, Representative Hymanson?
Of course. In 17 on page 11 of your testimony, there is a move of these funds to the general fund for a HEDL. And I wondered why that move was made. Because they were originally paid for by federal expenditure funds and other special revenue funds, but now there's going to be a piece that goes to the general fund.
Yep. Happy to talk about that. That's one account there, just so you know, federal expenditures fund, other special revenue funds that both the health and environmental testing laboratory, as well as the health inspection program, but we can cover that later. But HEDL is 100% paid for fees that it generates from the services it provides. For many years, those fees have been insufficient to cover the costs of the lab. So there's various reasons for that. But just one example is the lab is required by statute to provide public good testing free to the public. And those public good tests increase over the years. But that longstanding structural gap, instead of raising fees, we are seeking general fund to partially pay and cover the positions that work at the lab, which would provide more stability to the lab overall and to the CDC. Obviously, the lab has been a critical piece of our COVID-19 response as well with COVID testing. But this resolves a long-standing structural gap due to insufficient fees.
Thank
based
you.
on how it's
In my policy role, I would now ask you why can you tell me more about increasing the fees? But I'm not there, so I'll go on.
And we do have a number of people with their hands up. So
Yeah, I'm sorry. So
do you want?
There's so much here. I'll stop.
You don't need to stop, but I was just, maybe we'll come back and give other people a shot, and maybe some of your questions will be answered. Will that be okay, Representative? Thank you. So I have Representative Cloutier and then Representative Craven in the queue, in addition to some others.
Thank you, Madam Chair. So I have a few questions. Number one, on A225, when we're talking about I think it's a $2 million cut due to professional services. I'm wondering if you can give any insight on what those professional services are, because that's a big chunk of money.
Certainly. I think just by those, the professional services, I would put this into the program efficiency bucket of cuts. This is internal. When we assembled the biennial budget, we looked to protect services and that we're providing to clients across all of our array of services that we deliver here at the department. And these are internal consulting contracts that the department relies on. We did it across the board for all offices in the department, and arrived at that $2.25 million. So this won't have any direct client impact to services that we deliver here at the department.
Okay, thank you. And then just sort of a general comment that when we're talking about the reduction from the 13 programs to the 4 programs, it would be really helpful for me and probably others, I think, if we could get like a 1-pager, and maybe that was requested yesterday, but just on what that kind of looks like, because it shows up in so many different places. That would be super helpful. And then I would just echo Representative Hymanson's concern around the limited period language, most especially in the part where we're talking about the lead inspection program. And I'm wondering, in my time in municipal government, I spent a lot of time working on lead prevention, and we have a serious problem with lead poisoning here in my district. And I'm just wondering if you can provide any insight on why those positions were created with the limited period time frame, and what the kind of logic is for the end date.
Certainly, we are looking. The positions were originally created in limited period, and we look to continue the positions, whether they were lead inspection positions or other limited period positions, in the same manner that they were created. So we are just continuing those positions as they were originally created. We do anticipate that the work of these positions will taper off eventually. That work has not tapered off to date. However, these limited period positions also look and feel like state lines, except with an end date. That end date is established statutorily for all limited period positions. It's 2 years from creation. And then we can continue them like we're doing in this instance.
Okay. And then lastly, under the language part, N, we worked so hard to get those public health nurses positions. for such a long time. I just want to express concern about us removing that language.
Yeah, I understand. Just to respond to that briefly, this language would make this account look more similar to accounts across the CDC and the department. There are restrictions in place on this account. 2 years ago, there were 28 public health nurses. Today, there's 37. Vacancies have been following. We've been prioritizing, and the public health nurse program has been instrumental in COVID response, and will return to other essential duties post-COVID. But this language does restrict the ability for CDC to have just general flexibilities that are typically afforded across accounts that would be able to just manage their funds. So in no means does this suggest any deprioritization or lack of import that we place on this program. And we just are looking to align the budget mechanics, if you will, the appropriated flexibilities that are afforded other programs to this program as well.
Thank you.
Thank you. Next, Representative Craven, and then Senator Claxton and Senator Moore.
Thank you, Madam Chair. Thank you, Mr. Mann, as well. So this is on page 252. And will you explain the structure for the allocations for the $1 million that's going to be going to address the disparities in racial disparities?
Certainly. So this program reestablishes an Office of Health Equity at the CDC, and it provides funding in all other of $1 million in 22 and another $1 million in 2023 for to address those disparities. We've this program or this office exists, although we are reestablishing it and staffing it, and this would provide funding once we have folks hired into the positions to do a needs assessment to determine where exactly and how these funds would be allocated. So we want to be able to seed the program with funding so that they can undertake where they undertake programs, whether those are contracts or otherwise, on where the needs lie for health disparities across the state. This has become very evident during COVID-19, and we've started some of that work with community-based organizations, with testing and social support outreach, and this would sort of codify and structurally create supports in place for those demographics and minority groups.
Thank you very much.
Next, I have Senator Claxton, then Senator Moore, and then Representative Zager.
Thank you, Madam Chair. I just wanted to flag that Representative Perry has joined us.
Oh, excellent. Welcome, Representative Perry.
Thank you. Do I need to introduce myself?
Please do.
Okay. I'm Representative Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Thank you. Good to see you. And Representative Martin, I know that you've joined us. Would you like to introduce yourself? You're on mute. Nope. Close. You're still on mute now. All set. Representative Martin has joined us as well. So Senator Moore, and then Representative Zager, and then Senator Breen.
Am I on?
Thank you, Madam Chair. Go
yes,
ahead.
John, go ahead and introduce yourself,
Okay,
please.
I'd like you to turn to
Oh, wait, you're not up for a question yet. I'll call on you for a question. I thought you were going to introduce
Oh,
yourself.
okay.
I'll get back to you.
Yep.
So right now we're with Senator Moore. Thank you.
Thank you, Madam Chair. I appreciate that. I have just a couple of questions. And thank you, Mr. Mann, for slowing it down today. That was a little bit easier to try to find everything. Throughout the entire documentation, you have used the adjust funding to align with existing resources. Is that the FMAP increase that we received?
No, that generally, that it's a cleanup item basically. So over the course of the year or prior or in the past, we'll do financial orders if we need to increase the allocation due to increase in federal resources being available. And that alignment is now codified in the budget, so we don't have to do financial orders, and it's transparent to you all on how resources are being used.
A lot of money. That's why I was wondering throughout the budget itself. One of the things I would like, and I'm not asking you to provide this today, maybe for the work sessions, how many additional personnel are being proposed for the CDC? I think that would be a good number for us to understand. And then how many of them are being continued? Because it's like melted all through the budget itself. So that would be a good factual information to have. And then just one other thing to piggyback on Representative Craven's question about the public health infrastructure to reduce the disparities. With it coming out of the Fund for Healthy Maine, I don't have my documentation with me, but there's certain items that could fall and come out of the Fund for Healthy Maine. Is this one of the topics that can be used for that?
The allowability of the Fund for Healthy Maine for that purpose, I don't see any issue with. It aligns with the statutory intent and requirements related to Fund for Healthy Maine. It is one, you are right in that we are prioritizing this use as one of the top ways to use Fund for Healthy Maine dollars, with those dollars being more constrained than they have in the past.
Okay. Yes, because that's one that's kind of near and dear to my heart. I always keep an eye on that. And then just one last comment. In our language portion of Part PP, I know that in the supplemental budget, the conversation is to change that from the non-farm income official poverty line, because that doesn't exist anymore, that should be the federal poverty line. Just to point that out as something that we may want to make sure we correct that if we go forward with that language. Thank you. That's all I had.
Thank you, Senator. Next, Representative Zager, then Senator Breen, and then Representative Javner.
Thank you, Madam Chair. And Deputy Commissioner Mann, thank you very much for walking us through that again, and also the tremendous work that underlies the presentation. I guess Representative Cloutier asked the question that I primarily had about Part NN regarding the language for public health nurses. I appreciate the department's commitment to continuing to restore that important infrastructure. It seems very important but certainly in a pandemic time, but also for maternal child health and other things in non-pandemic times. So I appreciate that, and we'll be would appreciate any advisement of how that would be invoked in the future. So more of a flagging of what was already discussed with Representative Cloutier's question. Thank you.
Thank you. I have Senator Breen and then Representative Javner, and then Representative Millett. I believe you had your hand up too. So Senator Breen, Chair Breen.
Thank you, Madam Chair. I appreciate it. Mr. Mann, this is a sort of a global question, and I think it's familiar probably to the HHS committee as well. In language part EEE, you're proposing to move $60 million of balances in the medical care payments to providers account into the general fund. That was also part of what the supplemental budget included. There are a number of places where you have extra money, substantial extra money in some of the main care funds, and you're proposing to move them into the general fund. At the same time, people in my position, and I'm sure members of the HHS committee, we're hearing from providers in the community who provide services to folks with intellectual disabilities, folks with mental illness, folks with substance use disorder, many of whom were not eligible structurally to get any sort of federal relief because they were either nonprofit and they weren't, didn't qualify as a small business. Some of them were too large, had more than the threshold number of employees. And throughout the course of the pandemic, have reported to me and others that really the only kind of bump or assistance they got to manage pandemic related challenges was a temporary rate increase that happened for about 3 months, I think March, April, and June, or maybe it was, somewhere in there. So I think, first of all, was there any conversation in the department about trying to do some sort of grant program similar to grant programs that were done for small businesses? Were there any conversations in the department about trying to do some grant programs to these providers who have really had to make substantial cuts to staff, closing residential programs for children, other sorts of really significant cutbacks in what they provide to our most vulnerable people? Do you understand the question?
Certainly. Thanks for that. I think off the top, I would say that COVID has unquestionably been difficult for industries across the state and the country and the world, obviously, particularly in the healthcare and human services realm. I do think within that, COVID has uniquely affected facilities in a very case by case, facility by facility, business by business way. So not all effects are I don't think we can paint with a broad brush across industries, whether those are any kind of particular policy area. Some were more negatively affected. Some services were able to ramp up with telehealth, for example, and some have been hurting throughout the duration much more to a much greater extent. I think just related to the federal resources, we can only support those Medicaid providers, obviously, in the state, and I presume those are the ones you're referring to. The federal funds that were made available through the Provider Relief Fund and primarily with the CARES Act, and it was reauthorized with additional funds through the Appropriations Act that was passed at the end of last year. Those were available to all Medicaid providers. It was 2% of annual revenues, irrespective of how they were incorporated, whether it was a nonprofit or a private organization. So that was an application process that they had to apply for that we promoted. But all Medicaid providers could avail themselves of that if they chose to do so, irrespective of the size of the organization or how they were. The eligibility was that they were a certified main care or a Medicaid provider. In coordination with you asked about a grant program, we did establish a grant program in partnership with the Department of Economic and Community Development. That grant program pushed out $240 million to main businesses. That includes, that includes businesses across the state. The first round of it was for small businesses under 50 employees. The second round was under 250 employees. We established a third round that was just for healthcare for Medicaid providers over 250, and then also all hospitals and nursing facilities were eligible to apply for that. So that program was made eligible. That would have captured all main care providers in the state, since we did offer that third round that was above 250, and anyone below 250 had the opportunity to apply through the DECD run program. Overall, when I checked the HHS website, the provider relief funds don't come through the department. They come through, they go straight from the federal government to providers themselves. Last time I saw, it was main Medicaid providers have received $518 million from the federal government. That's primarily hospitals and nursing facilities, but also includes that 2% of their annual revenue. That does not include the Paycheck Protection Program, either the first version or the reauthorized version, which is currently open right now to providers as well. That one is capped. The PPP, as I think you know, was capped on a certain employee level, 500 the first round. I believe it's 300 this round of total employees. And we did establish temporary rate increases during the beginning of the pandemic that have since expired. We do have ongoing support for several providers. We have we call them colloquially outbreak rates. So if residential facilities are experiencing an outbreak, which would be 3 or more COVID cases, they're eligible for the add-on rate, which is facility specific, but it doesn't provide a temporary rate increase for the duration of their outbreak and 14 days after the outbreak is concluded, which is aligned with the CDC guidance on how to treat outbreaks. We've also, just for example, we've done the facilities are available to use the health and environmental testing lab, which we talked about previously, and they've done nearly 300,000 tests since the beginning of the pandemic to make sure. So those costs are at no cost to the facility to use that if they're experiencing an outbreak. So I think. I hope I answered your question. I think I'll stop there.
Madam Chair, if I could just pursue, just to follow up. You said that some of these providers would have been eligible for the small business program that the state did with CRF money towards the end of 2020. Could you find out, could we get a list of which providers in Maine were able to access those funds and receive those grants and what amounts? I think that would be important. And then last, I guess, the folks I hear from, I'm familiar with one organization that has literally closed a children's residential program, and most of those children are being placed out of state. They have huge amounts of staff vacancies because they can't afford to pay folks. And of course that affects their productivity and revenue stream and that sort of thing. And so they're saying, what I'm hearing is they're having these huge staffing challenges, and they've had to absorb a lot of COVID related expenses and changes. And yet there's this extra money in DHHS that's being moved over to the general fund. So I'm trying to figure out, and you see some of this reflected in what the HHS committee reported back to appropriations for the supplemental budget. There were a couple of new initiatives in the committee's report back to us. And I'm anticipating there might be something like that for the biennial. So I'm just trying to figure out kind of, there just feels like a disconnect to me in terms of like what I'm hearing from providers in the community what I'm seeing on the books, which is fair amount, tens and millions of dollars being moved around inside state government. And I'm trying to figure out how to explain that to those people, and I wonder if you can help.
Yeah, we can, I think unquestionably the FMAP increase of the 6.2% is helping solve the state budget shortfall. The state budget financial outlook is also imperiled due to COVID and tax revenues. Originally, the Revenue Forecast Committee projected a $1.4 billion shortfall for the 3 years. That was revised downward to $600 million in the December forecast. However, that is still a $600 million change from what we expected tax revenues from the FMAP changes, and how we're moving that money around due to the FMAP bump is unquestionably going to helping solve state budget shortfalls. If we did not move that money over to DAFs to repair that, we would likely be, as other states are, cutting Medicaid services or rates to a much, and we are largely preserving that overall. So I think those monies are required to resolve some of those state budget shortfalls that are due to COVID. Providers and the state are in a similar situation when it comes to that to some degree. I realize that like I said off the top, I think there are particular facilities that are more, COVID doesn't affect everyone or institutions or facilities equally. Some are affected more, some are affected less. I'd also note that the children's residential, those PNMI programs, we have a $4.5 million general fund request to increase those rates pursuant to a rate study included in the budget as well. And something I didn't mention before, but for any nonprofit, FEMA has the public assistance program set up for private nonprofits. So under the prior presidential administration, folks or those nonprofits could submit for FEMA reimbursement at 75% of all COVID-related costs. The current administration has changed that to 100% reimbursement. So all COVID costs for private nonprofits, if they submit an application, which requires submitting an application and assembling that, are eligible for reimbursement.
All set, Senator Breen, for now. Thank you. So Representative Jabner, and then Representative Millett, and then Representative Corey.
Thank you very much, Madam Chair. Thank you, Deputy Commissioner Mann. I appreciate your courage in coming before us today. I know that I have a couple questions. I appreciate very much Senator Breen bringing up the issue with the IDD. And I know that in the 129th, in the biennial, we worked very hard for those. And I actually, not right now even, but just for our work session. And that's how I'm going to kind of group my questions, is I have a few questions that I would like just information for the work session. I know that there are people out there listening that are going to be able to provide that. And also I just have a couple of that maybe you could answer now. So with the 129th, with the biennial, with the IDD program, with those providers for the future for the work session, I would really appreciate the history of or just a flow chart even of the accounting, because I know that the rates were stopped after 3 months. I'd like to see exactly what that history is, what was provided in the 129th, what really happened, and we want to see these taken care of, obviously. And if there are funds out there that are available for that, I would really appreciate to see that historical view just from that. So you don't need to address that right now, but I appreciate that being brought up because it is very important. One question that maybe you could answer just off the top of your head right now, Deputy Commissioner, is simply, we see throughout the whole budget, this 15% for transportation. I'm just very curious, where did the 15% number come from?
Sure. So this is similar to the professional services cut that the department is taking. I put the employee mileage reimbursement in that same bucket that we looked internally first, trying to protect direct client services and making sure that we are doing our own belt tightening here within the department. That the COVID pandemic, this current fiscal year and likely for 22 as well, certainly has reduced some of the need for that reimbursement, but we also partially align that to prior year expenditures, so that if mileage reimbursement was underutilized in prior years, we try to align it generally so that we obviously need to travel, whether for whatever purposes that mileage reimbursement is going for, but that's generally aligned to what was underutilized in prior years.
Okay.
We weren't using the full budget.
Okay, great. Thank you. And then my next questions will be information that can be provided for the work sessions. Okay. So I am curious just to the definition, even throughout the budget. Again, we see these lines of general efficiencies and reestablishing priorities in different initiatives and in savings. And I would like to know what some of those examples are. I think you alluded to it previously, but you don't need to answer now. And then also on page A250 in the CDC section, there is a quote that's the statutorily required inspection frequency rate. I would like to know what that rate is. And then also Representative Craven broached this topic too with the 1 million on page A252. And you said it reestablishes the health equity program. And I would just appreciate a little bit more information if there was a precedent, if there was already one of those programs set. I mean, where is the 1 million number coming from? Do we know previously what was spent? Or I would like information on that. And then also on page A253, it spoke about 16 positions that are on file with the Bureau of the Budget. For the details on those, I would like those details. And then on A285, just briefly, it's talked about 3 positions and then 45 positions. I would like to know if those were the new positions provided in the 129th budget. Thank you.
Certainly.
Thank you, Representative. Next, we have Representative Millett, and then Representative Corey, then Representative Martin. Representative Millett.
Thank you, Madam Chair. Deputy Mann, I think many of my questions have been already asked, but so I'd like to focus on 2 particular broad areas. One is the 19 initiatives within the Maine Center for Disease Control and Prevention. And the staffing picture, I kind of think of it visually as a profile of what Dr. Shaw had in his area prior to the pandemic, how that changed in terms of limited period temporary positions once the pandemic hit, how the CARES money was used to fund some of those positions, and now the 17 new ones that are reflected at the end of the 19 initiatives on page A253, which show almost a doubling of the general fund personal services for the entire unit. And I'm assuming that what we see in 20 and 21 probably reflects some of the CARES money being used to backfill or pay for the personal services costs. But I'm wondering if you might be able to do something visually or in summary form for both committees that describes the before and after, and maybe the before, during, and after challenges that Dr. Shaw faced in his overall staffing, so that we could see the picture in terms of how that staffing, that increase in staffing and the increase in challenges were addressed during fiscals 20 and 21, and maybe a comment or 2 on, do the assumptions for 22 and 23 assume the pandemic is no longer a central focus of the challenge that these people deal with on an ongoing basis? So that's the broader question. Both Representative Hymanson and Senator Moore referred to it, but I think it probably deserves some overview that you and Molly and others could prepare for both committees. And lastly, I think I would just like to reemphasize everything that Chair Breen said about the balance forwards and the issues facing many of the provider entities that deal with the intellectually and developmentally disabled populations, nursing facilities, and other providers of services, both mental health, substance abuse, and children, that really were adversely affected by their challenges in dealing with COVID in both fiscal 20 and 21. And I know that Chair Breen referred to the language that the policy committee discussed and put forth in their report back in the supplemental. It seems to me we've got an area they have to work on in both the supplemental and the biennial. And it partially refers to the rate issue question I posed yesterday. But it does seem like we've got some work to do to address the fact that even above and beyond the CARES money and the grants that you referred to, there are populations out there, both clients and providers, who have endured challenges well beyond their ability to address them both in program services and in financial support. So those are my two areas. The big question about the staffing profile before, during, and after COVID within Maine CDC, and the overall issue of the populations that have been underserved and had difficulty that we perhaps haven't addressed as well as we might during the pandemic. Well, thank you, and I know you've got plenty on your plate, and we'll look forward to the conversation we have in the report backs. Thank you.
Thank you, Representative. So we have Representative Corey, then Representative Martin, and then Representative Fay.
Thank you, Madam Chair. Thank you for being here, Mr. Mann. I had a question about the initiative on A213, and it's with regard to the AIDS lodging house. And it says that the house no longer exists, but these funds are dispersed through a local community-based organization. Do we know if that local community-based organization is helping or currently helping people with HIV and AIDS live independently? Do you know what that organization is, Mr. Mann?
I'm afraid I don't off the top of my head. I'm happy to get that information for you and report back during a work session or otherwise, though.
Do you know if that's how the money is being spent, though, or?
I'd have to get back to you on the exact mechanics of how that program works.
Okay, thank you.
All set, Representative Corey?
All set.
Representative Martin. You need to take yourself off mute. You're still on mute, Representative Martin.
Move your cursor down to the bottom of your Zoom screen.
You can hit the unmute. You want me to unmute you? Maybe I can do that.
Okay, I'm back.
Oh, good. There we go. Excellent.
Yeah, on page 41, part YY, these transfers are not considered adjustments and appropriations. Why is that?
I don't, I have not flipped, the roles have reversed here. I've not flipped my pages to the correct place in the budget, but typically when we adjust appropriations via financial order, they are considered adjustments to appropriations, and that need no longer exists. However, I think that language is just spelling out that these transfers are allowed and would not be considered permanent adjustments to the baseline.
Okay, yeah, I have no problem with that, your language. Okay, I want to go back to another one, and that's on page 38. It looks like the beginning of another legal team in the Department of Human Services. It took us 4 to 5 years to abolish the legal team in the Department of Human Services that were in a constant fight with the Attorney General's office. Has there been any discussion with the Attorney General about this and whether or not he's refusing to appoint advisors that can actually sit in the department?
Yeah, thanks for that question. That I'm vaguely aware of those issues, although they predate my tenure here at the department. We coordinated closely with the Attorney General's shop on this initiative, and they are supportive of this initiative for an appointed position. I think this will help us facilitate and coordinate better with the Attorney General's shop in terms of legal services for the department. And in fact, several other departments across the state do have appointed attorney legal services positions. HHS is not one of them now, so this would just create one position to that effect.
Yeah, I'm curious because the Attorney General now was a member of the Appropriations Committee when we led the fight to abolish what was going on in the Department of Human Services. So I'll be curious to see what his reaction is. Thank you.
Yep. Just again, we worked with them and him on this and sought their approval to include this proposal in the budget.
And just for clarifications, you're talking about RR in the language on page 38, Representative Martin.
Yeah, that was RR.
Thank you.
Yes.
I just wanted to make sure we were all on the same page.
Yeah, that's RR.
Great. Representative Fay.
Well, thank you very much. And I'm pleased to report that Representative Martin actually asked one of the two questions that I had. So I guess my question would be about on page A303, plumbing control over. In the past, we've heard from the drinking water program around septic inspections that part of the reason why we can't increase the requirements around septic inspections is because that there isn't enough manpower in the department to handle capacity. So I was wondering if there was any conversation about that around this. I guess that's my question.
I'm sorry, conversation around increasing the headcount in this program, or?
Yes. Yep.
I can look into that issue of capacity that you mentioned with that on that topic. I think we took we were very mindful of increasing headcount in the biennial budget. Certainly, the department lost a lot of headcount under the prior administration, and we have rebuilt some of that. However, with COVID and positions are long-term costs for the state, prioritize the top positions for headcount, whether those are limited period positions or permanent state lines, and put forward the proposal that you see here, and we can certainly get the overall CDC numbers that were requested before. But I can look into and report back on capacity issues within that plumbing appropriation.
I appreciate that. I was just thinking that with the increase in real estate transactions, that there could be some issues with the speed with which some of those inspections might happen if we don't have enough people to manage that. So I really appreciate you looking into that. I know it's a little bit of a different topic than we've been talking about today. So thanks for that.
Happy to.
And Representative Lemelin.
Yes, thank you. Good morning. Mr. Mann, I just have one question. What is your definition of ongoing efficiencies and underutilized professional services?
I think I explained this a little. I think just stepping back to understand the types of savings proposals we put forward, can help answer that question. We went over this a little bit in the supplemental, but I think it's worth revisiting it. I think about the savings that are included in the supplemental and the biennial budget in 3 different buckets. One is maximizing federal and other revenue sources, which are, basically like FMAP, that would generate general fund savings to help with the state budget shortfalls. The second would be program efficiencies. Those would be, contract savings, which would be in that case for professional services like IT contracts. We can potentially handle certain contracted services with state lines. We looked internally. We're basically looking internally to solve some of the savings requirements for assembling this budget, and protecting health coverage and direct client services. And I think that those professional services cuts, whether those are IT contracts or contracts, staff augmentation contracts, we are look to make some reductions in that area. And the third bucket, just to finish off that sort of framework for the savings overall, would be compliance issues and other rate parity. If there are similar services, they should receive similar rates. The compliance issues like we talked about with the 340B program yesterday, for example.
Okay, thank you.
Senator Breen?
Thank you, Madam Chair. Mr. Mann, is there anything in federal law that prevents using that FMAP money to do a grant program for main care providers?
I would defer to the lawyers for just interpretation of that, but just off the top of my head, I think the FMAP replaces, increases what we're able to cover with federal dollars. So we're freeing up general funds. So those are actually state resources that are available. So I think the answer is no to your question, but we can run that down as well.
Okay, thank you. I appreciate that.
So I just had one follow-up to what Chair Breen had discussed around the grant program that went through the CRF money. I know you're going to get us a list of people who actually applied and maybe received funding, but I'd also like to understand maybe the percentage of this community that applied and if there was criteria within the grant application process that might have bumped people out or not made them eligible in a way to receive that, especially as we look forward to trying to meet some of those needs, if that's possible, for the work session.
Sure.
Thank you.
Those grants were up to $100,000, and we used the DECD criteria that pushed out the I believe it was $238 million to, don't quote me on this, but I believe it was 4,700 businesses across the state that received funding through that, which would include some of the healthcare providers that we're talking about today.
Absolutely. I'm familiar with it. It also had a threshold of 20%, profit. And so it had a lot of criteria to it. And also there are certainly groups around the state that are adept at applying for things like that. And then other groups that maybe needed more help in understanding their ability to apply for that. So I just want to have a better understanding as we move forward, if possible. Thank you. So we have 3 people, I believe, I thought there were 4, but 3 of the public testimony that we would like to hear from. If I don't see any more questions from anyone on either committee at this juncture. Fantastic. So I would like to invite over Hillary Schneider. And I'm promoting her to a panelist. So when you arrive, Hillary, please unmute yourself and share your video. Are you with us?
Can you hear me?
Oh, now I can. Yes, thank you. Good to see you.
Okay. Good morning, Senators Breen and Claxton, Representatives Person Meyer, and members of the Appropriations and Health and Human Services Committees. My name is Hillary Schneider, and I'm the Main Director of Government Relations for the American Cancer Society Cancer Action Network. On behalf of ACS CAN, I'd like to thank you for this opportunity to testify in the governor's biennial budget proposal. This testimony will focus on funding for the state's tobacco prevention and treatment program. The biennial budget proposal includes a reduction in funding of $5 million per year for the state tobacco control program when compared to FY21 funding. In FY21, the state tobacco control program was funded at $13.9 million, which was reduced to $13.8 million due to a $100,000 reduction included in the governor's COVID-related curtailment order. The breakdown of the $13 million is detailed in my written testimony. We're testifying in opposition to the more than 30% reduction in tobacco control funding. We recognize that COVID-19 has had a significant impact on the state's economy. However, cancer does not stop in a global pandemic. Delays in cancer screenings and any cuts to cancer prevention efforts will only lead to increases in cancer cases and deaths. This year in Maine, more than 10,000 people will hear the words, "You have cancer," and more than 3,000 Mainers will lose their lives to this life-changing disease, likely continuing the trend of cancer being the #1 killer of Maine people. Tobacco use remains the leading preventable risk factor for cancer and one of the leading causes of cancer disparities. In Maine, more than 1 in 5 cancer cases and nearly 1 in 3 cancer deaths are related to smoking. Nationally, Maine has the 6th highest rate of smoking-related cancer deaths and the 11th highest rate of smoking-related, Maine has the 6th highest rate of smoking-related cancer cases and the 11th highest rate of smoking-related cancer deaths in the nation. In Maine, nearly 1 in 5 adults smoke cigarettes, the highest rate in the Northeast. More than 1 in 15 Maine high school students smoke cigarettes, with a high of 1 in 8 in Washington County. In recent years, overall youth tobacco use has skyrocketed, largely driven by the youth e-cigarette use epidemic. 1 in 2 Maine high school students and 1 in 6 middle school students have used e-cigarettes. Nearly 30% of high school students are current users of e-cigarettes, nearly doubling from 15% in 2017. In Piscataquis County, high school e-cigarette use quadrupled, and it nearly tripled in Oxford County during that same 2-year period. Studies have found that e-cigarette use increases the risk of youth and young adults using cigarettes. As you know, one of the most important decisions of the legislature is establishing the state's budget priorities. And one of the most impactful decisions you can make to provide all Mainers with the opportunity to live a healthy life is adequate funding for tobacco control. The US CDC recommends that Maine spend $15.9 million per year to fund the state tobacco control program. In FY21, Maine brought in over $180 million in tobacco-related revenue. Funding the tobacco program at the recommended level of $15.9 million per year would be less than 10% of what the state brings in tobacco-related revenue and less than 1/3 of what the tobacco industry is estimated to spend in Maine marketing their highly addictive and deadly products. Comprehensive tobacco control programs are wise investments, returning much more in healthcare cost savings, greater workforce productivity, and most importantly, countless years of memories with loved ones. Comprehensive tobacco control programs establish tobacco-free policies and social norms, promote tobacco cessation, and support those trying to quit, prevent initiation of tobacco use among prospective new users, including youth, and reduce tobacco-related health disparities. Moreover, people who smoke or used to smoke are at increased risk for severe illness from COVID-19. Many tobacco-related diseases like cancer also put people at increased risk for severe COVID-19 illness. While the state has made progress with recently increased tobacco control funding levels, including educating parents and children about the harms of e-cigarettes and modernizing treatment resources, more work is needed. It is concerning to reduce program funding when recent efforts have started gaining traction and seen promising results, especially at a time of a pandemic that has higher risks for tobacco use and tobacco-related health conditions. While Maine is facing unprecedented public health challenges, it is critical that programs to prevent kids from starting to use tobacco and help adults quit are preserved. It is imperative that policymakers take action to protect the health of Mainers by funding the state tobacco prevention and treatment program at the US CDC recommended level of $15.9 million per year in the biennial budget. Thank you, and I'd be happy to answer any questions.
Thank you so much, Ms. Schneider. Are there any questions from the committee members? Seeing none, we appreciate you waiting and your time. Thank you for your testimony.
Thank you.
I'd next like to invite Kathy Kilrain Del Rio. Hope I did that all correctly. And I've just promoted her. Is Kilrain Del Rio? Let's see. Please let us know when you're here. Ah, wonderful.
Hello, thank you.
Welcome.
Good morning, Senator Breen, Senator Claxton, Representative Peirce, Representative Meyer, and members of the Appropriations and Health and Human Services Committees. My name is Kathy Kilrain Del Rio. I'm with Maine Equal Justice, a nonprofit legal aid provider working to increase economic security, opportunity, and equity for people in Maine. I'm testifying neither for nor against LD 221 to ask you to strengthen this biennial budget by making stronger investments to address the longstanding issues of poverty, hunger, housing, health, and income insecurity, all of which have been exacerbated by COVID-19. And I won't read all of my testimony. Our organization works directly with low-income people to help them navigate systems that can help them meet the basic needs of themselves and their families. We also work together to identify solutions to poverty that can help move low-income people from crisis to security. As you might imagine, this past year has seen the need for our legal aid grow and highlighted the challenges faced by low-income people for many Mainers who hadn't previously experienced financial insecurity. To give you a better sense of the challenges facing many low-income Mainers, my testimony says I included an attachment, but I had a hard time doing that, so I think you're getting that by email with some more details about poverty here in Maine. But a few highlights to keep in mind. 1 in 8 adults and 1 in 5 children are unable to get enough food each day. Nearly 60% of extremely low-income households pay more than 50% of their income for rent. The implementation of Medicaid expansion has been a critical safety net for more than 70,000 people in our state. However, nearly 1 in 12 Mainers still lack health coverage, including many of our families, friends, and neighbors who are immigrants with equally low incomes. Even as healthcare professionals struggle to reduce unnecessary hospitalization to preserve resources and limit COVID exposure, hundreds of low-income Mainers with untreated dental pain and infection have no choice but to turn to the emergency room for care, since Maine is one of only 10 states providing only emergency dental services in its Medicaid program. For Mainers of color, especially those who are Black or Indigenous, the challenges are even worse. For example, the poverty rates for Black or Indigenous children in Maine are 46% and 44% respectively, while it's 15% for white children. Black, Indigenous, and people of color are more likely to be unemployed due to the pandemic, with Black workers more likely to experience longer periods of unemployment than white workers. At the same time, workers of color are less likely than white workers to receive unemployment benefits for which they qualify. This data highlights why we urge you to look for opportunities to ensure this budget responds to the needs of low-income Mainers. For that reason, we are grateful to see a change to the Maine Care program that aligns our state recovery program to the minimum federal Medicaid requirements, which only apply to services related to long-term care. This critical change will make it easier for Mainers ages 55 to 64 to enroll in Maine Care without fear that basic care or care for conditions like cancer, diabetes, heart disease, or even COVID will leave them without a house or family property to leave their families when they die. But there's so much more to do. The word unprecedented has been used on almost a daily basis since March 17th of last year. However, I use it again today because low-income Mainers are facing an unprecedented intersection of crises that they cannot weather without your help. Sweeping unallocated funds from basic needs programs like SNAP, Maine Care, Aspire, TANF, and General Assistance that have always carried over to meet the need in future years eliminates needed flexibility when technology or simple things like rulemakings require additional funds. Investing in housing supports, healthcare, the unemployment insurance system, and public health infrastructure for communities of color will result in greater financial security and improved health for thousands of Mainers over time. These investments not only help meet the immediate needs of those struggling the most, they support our local and state economies where low-income people spend their money on rent, childcare, and groceries, and where they get their healthcare from local providers. Please remember that behind each of the statistics I've shared with you today, there are faces of your neighbors, your friends, and maybe even your family who are wading through a flood of loss, uncertainty, and trauma. For their sake and for the economic security of us all, this budget needs to direct more resources to those struggling the most, to look beyond COVID to begin to tackle the chronic, long-standing problems too many Mainers face, and begin to address the systemic inequities that are being worsened during these crises. Thank you, and I'm happy to answer any questions you may have.
Thank you so much for your testimony. Are there any questions of Ms. Kilrain Del Rio? Representative Hymanson.
Hi, that's a question for the work session. If we could have an accounting for the sweeping of the TANF, SNAP, and any of the other safety net programs, I'd appreciate that.
Thank you. Any other questions? Seeing none, thank you so much for your testimony. Appreciate you being here. I'd like now to ask Betsy Sweet to join us as a panelist. Hold on. And Ms. Sweet, welcome.
Thank you so much. And thank you all for your patience and your work. It's just amazing. So thank you very much. And so my name is Betsy Sweet, and Senator Breen, Representative Peirce, Senator Claxton, Representative Meyer, and the rest of the members of both the Appropriations and Health and Human Services Committees. Thank you so much. I am Betsy Sweet, and today I'm here on behalf of the Maine Coalition to End Domestic Violence and the Maine Coalition Against Sexual Assault, whom I represent. I'm not here today to represent either, I'm not here to speak either for or against something in the purchase social service line item. I'm here to talk about something that is not in the budget. As some of you remember, 2 years ago, this committee, along with the unanimous Health and Human Services Committee, recommended and passed $5 million invest in a state investment into services for domestic violence and sexual assault. Because the funding and state investment was so critical, it was the first investment that the state had made in these two services in 20 years, even though we know that the epidemic of domestic violence and sexual assault has increased. We hoped that this funding would be continued in this biennial budget, and it was not. The $5 million that were originally slated 2 years ago in the one-time appropriation could not have come as a more critical moment, because when COVID hit, these funds enabled our programs to quickly pivot and try and meet the needs of people in this, what we call the shadow pandemic, which we know, and I'm sure you've seen press articles about, which is the increase in domestic violence and the increased need for support for sexual assault survivors. That is what that money went for, and it did not go for the things that we originally asked it for expanded programming, for deepening programming, and for culturally related specific services. So as I said, domestic violence is one of the shadow pandemics as a result of COVID-19. Domestic violence resource centers across the state took action as stay-at-home orders went into place, realizing that, and if you understand domestic violence, that this was a really scary and difficult time for people who live in a situation where domestic violence is prevalent. One of the things that really struck me as I was working with many of these women and some men is that many of the outs that people have in terms of a way to get out of their situation, or temporarily or permanently, like going to pick up the kids from school or going to the grocery store or places to go to, to do things in the community, were eliminated. So they're stuck at home, unable to escape in ways that they have been able to escape before. We know that in this time, helpline call time increased by 22%. The safe and text and chat increased and received over 9,000 contacts during this period. 39% of the people needed legal assistance, and over 600 people found refuge in domestic violence resource centers. Of the survivors who reached out to the Domestic Violence Resource Center since March, 77% indicated that the pandemic had affected their safety, and 73% said they had seriously elevated safety concerns because of social distancing and COVID-19. Without the funding that you passed 2 years ago, we would not have been able to adapt to these situations. The same is true for reaching survivors of sexual assault, and all prevention services that we've done have gone out the window. And so we are asking you at this time to please put that $5 million back into the budget as a part of the baseline. These these issues, and when we expand them, they don't go away in 2 years. We wish we could solve them in 2 years, but they don't. And so we just wanted to mention this to you, and I wanted to make sure that you knew that there's be a bill coming from the majority leader in the House, Michelle Dunphy, also with this request. But these are desperately needed services for people who are not just facing COVID, not just facing all the stresses that all of us face, but the additional threat of violence and fearing the safety for themselves and for their children. So I thank you for your consideration about this, and please don't forget this as we go along. And as I said, there will be a bill. I also wanted to just change hats for a second. I also represent the Behavioral Health Community Collaborative, and I'll be speaking to you this afternoon about this. But I wanted to mention one thing, because there was some conversation, some wonderful conversation earlier with Mr. Mann from the department. I just want to say that one of the reasons, I quickly asked my coalition members if any of them had ever heard of the FEMA money that he talked about, that was provided for 75% and now 100% of their costs. Not one of them has heard of that, or certainly has applied for that. So maybe it's something that we should know about, but we certainly don't. And the second thing is that one of the other things that happened at the very beginning of the epidemic that made agencies reluctant to apply for this aid was that the department could not assure or reassure these organizations that 2 or 3 years from now, when they are audited, that they will not be required to pay all this money back. They don't have margins where they can pay money back, you know, in 2 years from now or 3 years from now. And we had a series of meetings with the department begging for clarification that this money would be grant money, and again, would not be included in any kind of audit 2 or 3 years from now in terms of having to pay it back. And that reassurance never came. So for these organizations that really live with a very, very narrow margin, that risk was something that they were very reluctant, and their boards, their volunteer boards, were really reluctant to take. So that's part of this funding problem that there has been. And the other thing is just the inadequacy of the money. $100,000 is awesome, but they were facing losses of many of them $1 and $2 million, $3 million because of the protective equipment they had to buy, the technology that they had to buy for their clients. So it's not as simple a solution. And as Mr. Mann did say, it's a different situation for every organization because of their size and the services they provide and their geography. So it's a very, very difficult time. And I would say that they are not being made whole in any kind of way.
Ms. Sweet, we have a couple other people to testify. So you're a little, that's okay.
I just wanted to add that clarification, and happy to talk about it more in the work session. Thank you.
I appreciate that. Yes. Representative Fay and then Representative Cardone.
Thank you, Madam Chair, and thank you, Ms. Sweet, for being here and talking about this really important issue of domestic violence. Has there been any changes in funding at the federal level for domestic violence and sexual assault programming?
Thank you, Representative Fay. Yes, the Violence Against Women Act funding has decreased, and the Victims of Crime Act money also has decreased. So we are facing shortages at the federal level on top of this loss of this money that was this one-time money. So we are feeling the pinch. They are feeling the pinch strongly on all sides.
Representative Cardone?
As a follow-up to that, are there any funds in the federal relief package for COVID-19 earmarked for domestic assault assistance?
Yes, thank you, Representative Cardone. Yes, there are some that have been earmarked. They are very limited in terms of the amount of money, and I believe that the domestic violence resource centers collectively received about $102,000. There was not money for sexual assault. So there has been a little bit of money, but certainly not adequate to the need. The other thing I think it's important to say is that for this state investment, we know that when the COVID is over, or we get back to some semblance of normality, that we are going to see an incredible uptick in our need for services because of the pent-up need and because of the long-term impact, both on children and on families and women and the men who are involved. So long after that money disappears, the need is going to continue.
Thank you
very much for your time.
Thank you so much for being here. Now I'd like to invite Toby McGrath to join us as a panelist. Mr. McGrath, are you here yet? Ah, there we are. Welcome.
Hey, thank you very much. Co-chairs Claxton, Purse, Meyer, and members of the committees. My name is Toby McGrath. I am with Drummond Woodsum, and I'm here on behalf of the American Heart Association. Allison Perrin-Drag was going to testify, but unfortunately she had a conflict, so I'm here in her stead. She's the Director of Government Relations for the American Heart Association, and her testimony has been submitted. I won't take much of your time. I know you've had a long day and it's going to be longer, but I'm going to echo what Hillary Schneider said regarding regarding the reduction in funding of $5 million per year in each year of the biennium for the state tobacco and control program. Basically, we line up with what Hillary was saying, and we recognize the challenges of focusing on anything other than immediate threat during the global pandemic. We understand that. However, delaying other core public health work like tobacco prevention and treatment is one that will cost the state in terms of lives and dollars. We must do everything in our power to keep our communities healthy and safe during these times, which means building strong public health infrastructure, including comprehensive tobacco control measures. We look forward to meeting with the committees and working with the committees on this. I will give you all back some minutes of your life today.
Thank you. Are there any questions for Mr. McGrath? Seeing none, I appreciate you waiting and coming to testify. Thank you.
Thank you.
And our last person today will be Alan Coble-Lewis. Oh, he's here for the afternoon. He's ahead of schedule signing up. So seeing no more.
I'll see you this afternoon.
Look forward to it. Thank you. So seeing no more public testimony for this part of the Health and Human Services budget, I think that we will adjourn to 1 o'clock, giving people some time to stretch and maybe get a little bit of lunch. So we'll be at this same Zoom at 1 o'clock. And until then, please mute yourself and put yourself on no video for the time being. Thanks so much.
Good afternoon, folks. Mr. Mann, I hope you got something to eat. Got a break? Good. This is the time when if we were in the State House, the committee would be scrambling back from the cafeteria and trickling back into their seats. So if you are continuing to eat your noontime sustenance, please continue. We all need it. I just want to welcome folks back. I'm State Senator Kathy Breen, Senate Chair of Appropriations. Representative Peirce is going to not be chairing this. I'll be chairing this section. And we are going to continue with our presentation of the governor's biennial budget proposal with Mr. Mann from the Department of Health and Human Services. And we are back on track with our original schedule. So this afternoon, we will be covering children's services, developmental disabilities, substance use disorder, and adult mental health. Before we begin, are there any questions from any of our committee members or from the department before we proceed? If there are, just bring your cursor down to the bottom of your screen and push the raise hand function. Okay, I'm not seeing any. So Mr. Mann, thank you for your pacing today and giving people some time to flip back and forth between sections. I know all of us really appreciate it and hope we can do that again this afternoon. So the floor is yours.
Great, thank you. I will start from the top. Senator Breen, Representative Peirce, Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Appropriations and Financial Affairs, and members of the Joint Standing Committee on Health and Human Services. My name is Benjamin Mann. I'm the Deputy Commissioner of the Department of Health and Human Services, or DHHS. I'm here today to speak in support of LD 221, the Governor's biennial budget proposal for state fiscal years 2022 and 2023. As Governor Mills said, at a time when Maine people are hurting, when small businesses are struggling to keep their doors open, when the ranks of the unemployed have swelled, and when we are fighting a deadly virus all around us, we are proposing balanced budgets as required by the Constitution that continue efficiencies, good fiscal management, and curtailments to cover projected revenue shortfalls for all 3 fiscal years. They focus on combating the COVID-19 pandemic by continuing to rebuild the state's public health infrastructure, protecting essential health care, education, and life-saving services. They do not change Maine tax rates, and they maintain the Budget Stabilization Fund. With a future made unpredictable due to the ongoing pandemic, these budgets make good on the promise of government, which is to protect and support the well-being of our people and institutions. Governor Mills' DHHS budget proposal for the fiscal years 2022 and 2023 biennium continue policy efforts initiated at the outset of her administration, rebuilding critical parts of state government, such as services for Maine's most vulnerable residents and public health infrastructure, and strengthening healthcare to better serve and protect Maine families. Considering the acute and unprecedented demand on Maine's health and human services infrastructure, these investments continue to be timely, important, and responsible. Amid the difficult fiscal environment of the COVID-19 pandemic, the biennial budget balances targeted increases in necessary spending while reducing expenditures through efficiencies and maximizing federal funding, while avoiding layoffs and preserving vital services. We can now turn to the initiatives. Just to manage your expectations, this is the longest portion of the 3 sessions. It's roughly equivalent to the first 2 combined.
Thank you for letting us know.
So starting with children's services, the first program on page A216 is child care services. This program supports a child care subsidy program by providing subsidies for qualifying families and supports training for child care providers. This program has 1 initiative. The first initiative on page 216 provides allocation to align funding with available resources. This initiative increases allocation in the federal block grant fund, all other, by $7,911,473,000 in state fiscal years 2022 and 2023. That was 7.9 million. The next program is on page A217, is child support. This program provides both direct and indirect expenditures for the development of policy and the administration of child support enforcement and recovery under the Title 4D section of the Social Security Act. This program has two initiatives. The first initiative is on page A217 and it reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $2,435 in state fiscal year 22 and 23. The next initiative on page A217 adjusts funding to align with existing resources. This initiative increases allocation in other special revenue funds, all other, by $5.2 million in state fiscal year 2022 and 2023. The next program on page A239 is the Early Childhood Consultation Program. This program establishes and implements an early childhood consultation program. This program has no initiatives. The next program on A243 is Head Start. This program funds the purchase of Head Start services in the federally designated Head Start programs across the state. This program has no initiatives. The next initiative is on the next page, A244, and it's the Homeless Youth Program. This program provides preliminary assessments, safety plans, and other services to homeless youth and their family and legal guardians. This program has no initiatives. The next program on page 245 is the 4E Foster Care Adoption Assistance. This program funds eligible services for children in the care or custody of the state who are eligible under the federal Title 4E program, while permanent plans are being made through family rehabilitation and reunification, adoption, preparation for independent adulthood, or other means, and to the children adopted from the foster care program with adoption assistance. This program has 4 initiatives. The first initiative is on page 245 and provides allocation to align funding with available resources. This initiative increases allocation in federal expenditures fund, all other, by $10,803,295 in fiscal years 22 and 23. The next initiative on the same page reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $4,500 for state fiscal year 22 and 23. The next initiative on page 245 provides funding for the development of a new comprehensive child welfare information system. This initiative provides general fund all other funding of $971,696 in state fiscal year 2022 and increases allocation of federal expenditures all other fund by $994,055 in state fiscal year 2022. The final initiative in this section is on page 246. And it provides funding for the ongoing maintenance and operational costs of the new comprehensive child welfare information system. This initiative provides general fund all other funding of $1,313,633 in state fiscal year 2022 and $1,921,486 in state fiscal year 2023, and increases allocation of the federal expenditures all other by $1,343,860 in state fiscal year 22 and $1,965,700 in 23. The next program is a few pages up on page 254. It's the Maine Children's Cancer Research Fund. The program provides grants and other funding. The budget narrative is missing on this, but I'll let you know what it does. The program provides grants and other funding this program provides grants and other funding to support children's cancer research provided by research facilities in Maine that operate children's cancer programs. Funding for this program may be received through income tax checkoff, grants, gifts, bequests, and donations. This program has no initiatives. The next program is on the next page, A255, it's Maine Children's Growth Council. The Maine Children's Growth Council, as established by Public Law 2007, Chapter 683, was created to develop, maintain, and evaluate a plan for sustainable social and financial investment in healthy development of the state's young children and families. This program has one initiative. The initiative on page A255 eliminates funding in the Maine Children's Growth Council program per Public Law 2019, Chapter 450. This initiative reduces general fund all other by $25,000 in state fiscal year 2022 and 2023. The next initiative is on page A264. It's medical care payments to providers. We've seen this account before several times. This funds Medicaid services administered by the Office of Maine Care Services. The program has 29 initiatives and is found in all three sessions of the budget hearings for the department. The initiative on page A267 provides funding to increase rates related to Maine Care Benefits Manual, Chapter 3, Section 97, Appendix D, Principles of Reimbursement for child care facilities due to a planned rate study and to meet the requirements of the Families First Prevention Services Act. This initiative provides general fund all other funding of $815,178 in state fiscal year 2022 and $813,371 in state fiscal year 2023, and increases allocation and federal expenditures fund all other by $6,729,064 in 22 and $6,286,923 in 23. The next program is on A727 and is Mental Health Services Child Medicaid. This program provides services to children from birth through their 20th year for mental illness, mental retardation, autism, developmental disabilities, emotional and behavioral health needs, and includes home and community-based children's behavioral health services, targeted case management, behavioral health homes, children's outpatient and residential services. This program has two initiatives. The first initiative is on the same page, 272, and adjusts funding as a result of the increase in federal Medicaid, federal medical assistance percentage, FMAP, for the federal fiscal years 2021, 22, and 23. And this initiative reduces general fund all other funding by $120,196 in state fiscal year 22 and $200,326 in state fiscal year 2023. Second initiative on the same page, 272, provides funding to increase rates related to Maine Care Benefits Manual, Chapter 3, Section 97, Appendix D, Principles of Reimbursement for Child Care Facilities due to a planned rate study and to meet the requirements of the Families First Prevention Services Act. This initiative provides general fund all other funding of $2,729,075 in state fiscal year 22 and $2,723,023 in state fiscal year 2023. The next program is on the next page, A273, and it's Mental Health Services Children. This program provides services to children from birth through their 20th year. These services are for the families with children with mental illness, mental retardation, autism, developmental disabilities, emotional and behavioral health needs, and includes supportive services to families such as respite services, crisis services, family supports, and homeless youth programs. This program has three initiatives. The first initiative is on page A273 and reduces funding by recognizing one-time savings achieved by delaying contracts for children's home and community-based treatment and rehabilitative and community support services. This initiative reduces general fund all other funding by $200,000 in state fiscal year 22 and 23. The next initiative on the same page, A273, provides funding to increase rates related to the Maine Care Benefits Manual, Chapter 3, Section 97, Appendix D, Principles of Reimbursement for Child Care Facilities, due to a planned rate study and to meet the requirements of the Families First Prevention Services Act. This initiative provides general fund all other funding of $1,122,000 in state fiscal years 22 and 23. The next initiative on the same page reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic and based on prior year expenditures. The initiative reduces general fund all other funding by $14,873 in state fiscal year 22 and 23. The next program on page A291 is Office of Child and Family Services, the central account. This program is primarily responsible for the development and delivery and oversight of all programs under the office's responsibility, including child protective and children's services, children's behavioral health services, and prevention and early intervention services. This program has 3 initiatives. The first initiative on page 291 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $5,950 in 22 and 23. The next initiative on the same page provides funding for the approved reorganization of one Office Specialist 1 position to an Office Specialist 2 position. This initiative provides general fund personal services of $4,419 in state fiscal year 2022 and $4,671 in state fiscal year 2023, and increases allocation in other special revenue funds personal services by $1,715 in state fiscal year 22 and $1,812 in state fiscal year 2023, and other special revenue funds all other by $39 in 22 and $42 in state fiscal year 23. The next initiative, also on the same page, A291, provides funding for approved reclassification of one Social Services Program Specialist 1 position to a Social Services Program Specialist 2 position, retroactive to September 2019. This initiative provides general fund personal services of $18,275 in state fiscal year 22 and $9,555 in state fiscal year 23, and increases allocation in other special revenue funds personal services by $7,107 in state fiscal year 22, and $3,716 in state fiscal year 2023, and other special revenue funds all other by $164 in state fiscal year 2022 and $86 in 23. The next program on page 293, 2 pages ahead, is the Office of Child and Family Services, the district account. This program manages, supervises, and delivers direct services to families and youth who are reported to be abused, neglected, or in the care and custody of the state in order to strengthen family functioning by providing intensive home-based services while assuring child safety. This program has 3 initiatives. The first initiative on the same page, 293, establishes 15 child protective services caseworker positions effective January 1, 2022, funded 79% general fund, 21% other special revenue funds within the Office of Child and Family Services district program to implement the new Families First Prevention Services Act. Funding will be realized by reallocating funding for community intervention services. This initiative provides general fund personal services funding of $571,800 in state fiscal year 22 and $1,189,335 in state fiscal year 23, and general fund all other funding of $37,648 in state fiscal year 22, $75,495 in state fiscal year 23, and increases allocation in other special revenue funds personal services by $151,995 in 22 and $316,095 in state fiscal year 2023, and other special revenue funds all other by $13,735 in fiscal 22 and $27,749 in fiscal year 23. The next initiative on page 293 reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $217,231 in state fiscal years 22 and 23. The next initiative on the same page, 293, adjusts funding to align with existing resources. This initiative increases allocation in other special revenue funds, all other, by $409,204 in state fiscal years 22 and 23. We'll skip ahead to page 310. The next program on this page is Special Children's Services. This program supports the salary and fringe benefits for staff who work with healthcare providers to assure coordinated specialty medical treatment for children who are chronically ill or of handicapping medical conditions which require complex medical treatment and continuity of care. This program has no initiatives. The next program is on page A312, State-Funded Foster Care Adoption Assistance. This program funds the needs of children who are in the care or custody of the state while permanent plans are being made through family rehabilitation, reunification, adoption, preparation for independent adulthood, or by other means. And to children, funding is also provided to children adopted from the foster care program with adoption assistance. The program has 5 initiatives. The first initiative on page 312 establishes 15 Child Protective Services caseworker positions effective January 1, 2022. Fund 79% general fund and 21% other special revenue funds within the Office of Child and Family Services district program to implement the Families First Prevention Services Act. Funding will be realized by reallocating funding for community intervention services. This initiative reduces general fund all other funding by $1,031,149 in 22 and $2,062,279, $97 in state fiscal year 23. The next initiative on the same page reduces funding for software implementation for results-oriented management reporting. This initiative reduces general fund all other funding by $80,804 in state fiscal years 22 and 23, and federal expenditures all other by $2,998 in 22 and 23 as well. The next initiative on page 312 provides funding for a new intensive outpatient program for high acuity main care members to address the behavioral health system. The initiative provides general fund all other funding of $128,450 in state fiscal years 22 and 23. The next initiative on the next page, A313, reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $3,645 in state fiscal years 22 and 23. The next initiative on page 313 adjusts funding to align with existing resources. This initiative increases allocation and other funds all other by $414,840. That concludes the initiatives in this section. There's one piece of language that is related to it.
Pardon me, Mr. Mann, you just cut out on that last initiative, that last line before you finish. Would you mind repeating that before you move on to the language?
Certainly.
Thanks.
The final initiative in the state-funded foster care adoption assistance program, which is on page A313, adjust funding to align with existing resources. The initiative increases allocation in the other special revenue funds, all other, by $414,840 in state fiscal years 22 and 23. We'll turn to language. I'll let you flip over to the language.
Sorry, Mr. Mann, I apologize. It looks like Representative Madigan has a question. Is that right?
I do, but Mr. Mann can go through this. He's just doing the language and finishing up this section. Right?
Yes.
So I can wait till after he's done talking about the language.
Okay, thank you.
Yeah.
One sentence, if we're on the language sentence or a part of the budget, the next submitted language is on page 41 and 42L, part YY. This part authorizes the Department of Health and Human Services to transfer appropriations within the Office of Child and Family Services related to the cost of administering the child welfare programs.
Okay, thank you. Representative Madigan.
Yes, thank you, Senator Breen. Thank you for being here today, Mr. Mann. I have a question about the initiative with the 15 new caseworkers by reallocating funds for other community service programs. My understanding is that is regarding ending the contracts for the alternative response programs, which deal with low risk perhaps child protective cases. There's more than 15 people working in those programs statewide, and I guess I would like to know more, and I think other people in the department besides you probably need to give us more information about how you plan to cover all that work, because 15 new caseworkers doesn't equal out to the amount of work, the amount of people that are currently working in those programs now.
Sure. We worked closely with Dr. Landry and his team on this. The 15 caseworkers was the request put forward to insource that contract, which you are correct is the ARP, the Alternative Response Program, for the low risk child protective work that goes on, which we do feel like is inherently governmental work and should be insourced with these caseworker positions. But we can provide more information around the alignment of the resources between what's contract and what's being proposed via state lines.
Sure, and I just want to add in that one thing that would be helpful for me is to have information about where those ARP programs are located, what geographical areas they're covering, as the state, parts of the state, and then where these 15 caseworkers were going to go. I'm concerned. I don't want any areas to be underserved for these services.
Certainly.
Thank you.
The next section is developmental disabilities.
Oh, sorry, Mr. Mann. There's a few more questions from legislators on this section before we move on to developmental disabilities, which is a little bit of a departure from what I was planning. I'm going to take these 4 questions, and then I'm going to ask folks to hold off until we finish. Thank you. Representative Craven.
Thank you, Madam Chair. Yes, I apologize. I thought that this was a time that we could, but I wanted to piggyback on Representative Madigan's concern as well. Not only do I feel a bit dismayed about this change, but have been getting a lot of feedback from constituents as well who are very worried and would like some clarification on about the initiative and about how the department expects for 15 caseworkers to be able to take on the work of many, many more workers. Thank you.
Representative Cardone.
Thank you. My question goes to the initiative on the top of A246, the provision for funding for ongoing maintenance and operation of the new comprehensive child welfare information system. Could you provide to us, you don't have to explain it now, but at some point, could you provide to us an explanation of what that information system is, what it does and how it works, and specifically what this money is going toward?
Certainly.
Thank you.
Okay, we're going to move on. And part of my moving on is there's 11 people from the public who are waiting to testify. So I just want to make sure we're moving along at a good clip so those folks don't have to wait too long. So the next section we're going to cover is developmental disabilities, and then substance use disorder, and mental health, and then brain injury. Go ahead, Mr. Mann. Thank you.
Great, thank you. Developmental disabilities is the next section. It's on page A220. And that account is Crisis Outreach Program. The goal of the crisis system is to provide assistance to individuals, families, guardians, providers in order to maximize individuals' opportunities to remain in their homes and communities before, during, and after crisis incidents. Excuse me. This program has 4 initiatives. The first initiative is on page A220 and transfers and reallocates 4 mental health worker 3 positions from 100% general fund in the Developmental Services Community Program to 52.4% general fund and 47.6% other special revenue funds in the Crisis Outreach Program, and adjusts funding for related all other costs. The initiative provides general fund personal services funding of $166,601 in state fiscal year 22 and $171,946 in state fiscal year 2023. General fund all other funds of $13,319 in 22 and 23, and increases allocation in other special revenue funds personnel services by $151,344 in state fiscal year 22 and $156,203 in state fiscal year 23, and other special revenue funds all other funding by $12,280 in 22 and $12,308 in 23. The next initiative on page A220 transfers and reallocates 1 human services caseworker position from 52.4% general fund and 47.6% other special revenue funds in the Crisis Outreach Program to 71% general fund within the Developmental Services Community Program, 15.2% general fund, and 13.8% general other special revenue funds within the Crisis Outreach Program, and transfers funding for related all other costs. This initiative reduces general fund personal services funding by $21,347 in state fiscal year 22 and $22,239 in state fiscal year 23, and general fund all other funding by $2,363 in fiscal 22 and 23, and reduces allocation in other special revenue funds personal services by $19,396 in state fiscal year 22, and by $20,207 in state fiscal year 23, and other special revenue funds all other by $2,644 in state fiscal year 22, and $2,662 in state fiscal year 23. The next initiative is on the next page, A221, provides funding for the proposed reclassification of 47 mental health worker 3 positions to community integration worker positions, and provides funding related to state cap charges. This initiative provides general fund personal services funding of $649,197 in state fiscal year 22 and $181,589 in state fiscal year 23, and increases allocation in other special revenue funds personal services by $589,718 in state fiscal year 22 and $164,971 in state fiscal year 23, and other special revenue funds all other by $16,481 in 22, $7,295 in state fiscal year 23. The final initiative in this section is, or this program is on page 221 as well, and reduces funding on a one-time basis for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $4,090 in 22 and 23. The next program on page A226 is Developmental Services Community. 5 pages on. This program provides essential services and supports to adults with intellectual disabilities or autism, including family support, respite, professional services, and other client needs. This program has 9 initiatives. The first initiative is on the same page and reduces funding by recognizing one-time savings achieved by implementing a new programmatic management practices for emergency transitional housing. This initiative reduces general fund all other funding by $215,000 in state fiscal years 22 and 23. The next initiative on page 226 transfers and reallocates 4 mental health worker positions from 100% general fund in the Developmental Services Community Program to 52.4% general fund and 47.6% other special revenue funds in the Crisis Outreach Program, and adjusts funding for related all other costs. This initiative reduces general fund personal services funding by $317,945 in state fiscal year 22 and $328,149 in state fiscal year 23, and reduces general fund all other by $25,416 in 22 and 23. The next initiative on page 226 reallocates 3 caseworker positions, 2 human services caseworker supervisor positions, 6 human services caseworker positions, and 1 regional supervisor position from 100% general fund in the developmental services community program to various splits between the general fund and the developmental services community program and federal expenditures fund in the Office of Main Care Services program to align positions with duties and adjust all other. The initiative reduces general fund personal services funding by $294,012 in state fiscal year 22 and $298,066 in state fiscal year 23, reduces all other funding by $19,602 in state fiscal years 22 and 23. The next initiative on page 226 provides funding to contract with a provider to implement and provide technical support for the use of a standardized developmental disability needs assessment. This initiative provides general fund all other funding of $825,000 in state fiscal year 22 and 23. The next initiative on page 227 transfers and reallocates 1 human services caseworker position from 52.4% general fund to 47.6% other special revenue funds, the crisis outreach program to 71% general fund within the developmental services community program, 15.2% general fund, and 13.8% other special revenue funds within the crisis outreach program, and transfers funding for related all other costs. This initiative provides general fund personal services funding of $40,743 in state fiscal year 22, $42,446 in state fiscal year 23, provides general fund all other funding of $10,886 in state fiscal year 22 and 23. The next initiative on page 227 transfers funding for an advocacy contract from the Developmental Services Community Program Office of Advocacy BDS program and the Brain Injury Program General Fund to the Office of Main Care Services Program Federal Expenditures Fund. This initiative reduces general fund all other funding by $45,191 in state fiscal year 22 and 23. The next initiative on page 227 reduces funding one time in the Developmental Services Community Program due to general efficiencies. This initiative reduces general fund all other funding by $200,000 in state fiscal year 22-23. The next initiative on page 227 reduces funding one time for employee mileage reimbursement by 15% due to decrease in travel during COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $37,890 state fiscal years 22 and 23. The next initiative on page A227 transfers one part-time social services program specialist 1 position from 100% general fund in the brain injury program to 100% general fund in the developmental services community program. This initiative provides general fund personal services funding of $44,091 in state fiscal year 22, $46,107 in state fiscal year 23. It provides general fund all other of $6,354 in 22 and 23. Next program is on the next page, A228, and it's Developmental Services Waiver Main Care Account. This program provides community-based services as an alternative to intensive care, intellectual disabilities, institutional services, including home supports, day supports, work supports, and an array of professional and clinical supports. This program has 3 initiatives. The first initiative on page 228 adjusts funding as a result of the increase in the federal in the FMAP for federal fiscal years 21, 22, and 23. This initiative reduces general fund all other by $529,766 in 22 and $882,943 in state fiscal year 2023. The next initiative on the same page, A228, provides funding to increase rates for services under the Main Care Benefit Manual, Chapter 3, Section 21 allowances for home and community benefits for members with intellectual disabilities or autism spectrum disorder, and Section 29, allowances for support services for adults with intellectual disabilities or autism spectrum disorder. This initiative provides general fund all other funding of $7,975,378 in fiscal year 22 and $7,954,167 in state fiscal year 23. The next initiative on page 228 increases funding in the Medicaid Services Developmental Services Program and decreases funding in the Developmental Services Waiver Main Care Program, the Developmental Services Waiver Supports Program, and the Medicaid Waiver for Other Related Conditions Program, the Traumatic Brain Injury SEED, and the Medicaid Waiver for Brain Injury Residential and Community Supports Program to consolidate the 6 waiver programs into one program as part of the consolidation of main care related programs from 13 appropriations to 4 appropriations. This initiative reduces general fund all other funding by $132,400,807 in state fiscal year 22 and 23. The next program on page A229 is Developmental Services Waiver Supports. This program provides support services to assist individuals with intellectual disabilities or autism living in the community. This program has 5 initiatives. First initiative is on page A229 and adjusts funding as a result of the increase in FMAP for federal fiscal years 21, 22, and 23. This initiative reduces general fund all other funding by $110,237 in state fiscal year 22, $183,727 in state fiscal year 23. The next initiative on the same page provides funding for individuals with intellectual disabilities to receive services pursuant to the Main Care Benefits Manual, Chapter 2, Section 29, support services for adults with intellectual disabilities or autism spectrum disorder, thus promoting greater independence, employment, and community engagement. This initiative provides general fund all other funding of $1,366,275 in state fiscal year 22 and $4,701,186 in state fiscal year 23. The next initiative on page A229 provides funding to increase rates for services under the Main Care Benefits Manual, Chapter 3, Section 21, allowances for home and community benefits for members with intellectual disabilities or autism spectrum disorder, and Section 29, allowances for community for support services for adults with intellectual disabilities or autism spectrum disorder. This initiative provides general fund all other funding of $1,811,799 state fiscal year 22 and $1,806,980 in state fiscal year 23. The next initiative on the same page increases funding in the Medicaid Services Developmental Services Program and decreases funding in the Developmental Services Waiver Main Care Program, Developmental Services Waiver Supports Program, the Medicaid Waiver for Other Related Conditions Program, the Traumatic Brain Injury SEED Program, the Medicaid Waiver for Brain Injury Residential and Community Supports Program to consolidate the 6 waiver programs into one program as part of the consolidation of main care related programs from 13 accounts or appropriations to 4. This initiative reduces general fund all other funding by $32,143,655 state fiscal years 22 and 23. The final initiative in this account is on page 230. Increases funding in the nursing facilities program and decreases funding in the residential treatment facilities assessment program, the Medicaid Services Developmental Services Program, and the Developmental Services Waiver Supports Program to consolidate the 4 programs into one program as part of the consolidation of main care related programs and accounts. This initiative reduces the allocation in other special revenue funds, all other, by $105,000 in 22 and 23. The next program, we'll skip ahead 30 pages to page 260, is the Medicaid Services Developmental Services account. The first initiative is on page A260 and adjusts funding as a result of the increase in the FMAP for federal fiscal years 21, 22, and 23. This initiative reduces general fund all other funding by $97,844 in state fiscal year 22, $163,075 in state fiscal year 23. The next initiative is also on the same page and provides funding for individuals with intellectual disabilities to receive services pursuant to the Main Care Benefits Manual, Chapter 2, Section 29, support services for adults with intellectual disabilities or autism spectrum disorder, thus promoting greater independence, employment, and community engagement. This initiative increases allocation in other special revenue funds, all other, by $273,118 in state fiscal year 22, $940,237 in state fiscal year 23. The next initiative on 260, the same page, provides funding to increase rates for services under the Main Care Benefits Manual, Chapter 3, Section 21, allowances for home and community benefits for members with intellectual disabilities or autism spectrum disorder, and Section 29, allowances for support services for adults with intellectual disabilities or autism spectrum disorder. This initiative increases allocation in other special revenue funds, all other, by $1,952,229 in state fiscal years 22 and 23. The next initiative on the same page adjusts funding in the Medicaid dedicated tax accounts and the corresponding general fund accounts to bring the baseline resources in line with the December 2020 Revenue Forecasting Committee recommendations. This initiative provides general fund all other funding of $4,232,214 state fiscal years 22 and 23, and reduces general other special revenue funds by the same amount in the same years. The next initiative on page 261 increases funding in the Medicaid Services Developmental Services Program and decreases funding in the Developmental Services Waiver Main Care Program, the Developmental Services Waiver Supports Program, the Medicaid Waiver for Other Related Conditions Program, the Traumatic Brain Injury SEED Program, and the Medicaid Waiver for Brain Injury Residential and Community Supports Program to consolidate the 6 waiver programs into one program as part of the consolidation of main care related programs from 13 to 4. The initiative provides general fund all other funding of $175,535,445 in state fiscal years 22 and 23. The next initiative on page 261 increases funding in the nursing facilities program and decreases funding in the residential treatment facilities assessment program, the Medicaid Services Developmental Services Program, the Developmental Services Waiver Supports Program to consolidate the 4 programs into one program as part of the consolidation of main care related programs and accounts. This initiative reduces the allocation of other special revenue funds, all other, by $57,000 in 22 and 23. The next initiative on 261 increases funding in the Medical Care Payments to Providers Program and decreases funding in the Mental Health Services Community Medicaid Program, Office of Substance Abuse and Mental Health Services Medicaid SEED, and the Medicaid Services Developmental Services Program to consolidate the 4 programs into one program as part of the consolidation of the main care related programs and accounts. This initiative reduces allocation in other special revenue funds, all other, by $750,000 in state fiscal year 22 and 23. The next initiative on the same page increases funding in the Mental Health Services Community Medicaid Program and decreases funding in the Medicaid Services Developmental Services Program to consolidate 2 accounts into one as part of the consolidation of main care related programs and accounts. This initiative increases allocation of other special revenue funds, all other, by $3,941,883 in 22 and 23. We're going to move up to page 264, the Medical Care Payments to Providers account. First initiative on page 265 provides funding for individuals with intellectual disabilities to receive services pursuant to Main Care Benefits Manual, Chapter 2, Section 29, support services for adults with intellectual disabilities or autism spectrum disorder, thus promoting greater independence, employment, community engagement. This initiative increases allocation in federal expenditures fund, all other, by $2,912,549 in fiscal year 22. $10,029,197 in state fiscal year 23. The next initiative on on page 268 provides funding to increase rates for services under the Main Care Benefits Manual, Chapter 3, Section 21, allowances for home and community benefits for members with intellectual disabilities or autism spectrum disorder, and Section 29, allowances for support services for adults with intellectual disabilities or autism spectrum disorder. This initiative increases allocation. The federal expenditures fund all other by $20,297,750 in state fiscal year 2022, and $20,823,780 in state fiscal year 23. Next program is back 5 pages on page 263 as a Medicaid waiver for other related conditions account. This home and community-based waiver provides a comprehensive array of services to adults with cerebral palsy, epilepsy, and other related conditions. This program has 2 initiatives. The first initiative on page A263 adjusts funding as a result of the increase in the FMAP for federal fiscal years 2021, 2022, and 2023. This initiative reduces general fund all other funding by $11,517 in state fiscal year 22 and $19,195 in state fiscal year 2023. The second initiative on the same page increases funding in the Medicaid Services Developmental Services Program and decreases funding in the Developmental Services Waiver Main Care Program, Developmental Services Waiver Supports Program, the Medicaid Waiver for Other Related Conditions Program, the Traumatic Brain Injury SEED Program, and the Medicaid Waiver for Brain Injury Residential and Community Services Program to consolidate the 6 waiver programs into 1 program as part of the consolidation of main care related programs from 13 appropriations to 4 appropriations. The initiative reduces general fund all other funding by $3,474,273 in fiscal years 22 and 23. Next program on page 308 is the Residential Treatment Facilities Assessment. I'll give you a second to flip over to that. This program assesses a tax on the residential treatment providers for individuals with developmental disabilities. This program has 2 initiatives. The first initiative on page A308 adjusts funding in the Medicaid dedicated tax accounts and the corresponding general fund accounts to bring baseline resources in line with the December 2020 Revenue Forecasting Committee recommendations. This initiative increases allocation in the other special revenue funds, all other funding by $251,115 in state fiscal year 22 and 23. The next initiative on page 308 increases funding in the Nursing Facilities Program, decreases funding in the Residential Treatment Facilities Assessment Program, the Medicaid Services Developmental Services Program, and the Developmental Services Waiver Supports Program to consolidate 4 programs into 1 program as part of the consolidation of main care related programs and accounts. The initiative reduces allocation in other special revenue funds, all other, by $1,865,000 in fiscal year 22 and 23. We are going to move on to substance use disorder and mental health service accounts. That starts on page 215. The next program on page A215 is Bridging Rental Assistance Program. Bridging Rental Assistance Program, or BRAP, is a transitional housing voucher program designed to assist persons with mental illness for up to 24 months or until they are awarded a Section 8 housing voucher or alternative housing placement. Program participants pay 51%, which is what the language in the budget says, although we have made a policy change and is now 40% of their income for rent. This program has no initiatives. Next initiative on page A219 is the Consent Decree Program, a legal requirement to fund mental health services community programs for individuals not eligible for main care in order to conform to the Bates versus DHHS Consent Decree. The community mental health services include community integration, assertive community treatment, daily living supports, medication management, and wellness recovery and action plan services. The account allows for some funding to be used for short-term residential services with the intent to move individuals into community setting more quickly. This program has no initiatives. The next program on page 231 is the disproportionate share Dorothea Dix Psychiatric Center. Dorothea Dix Psychiatric Center, DDPC, is one of two inpatient public psychiatric hospitals under the Office of Adult Mental Health Services of the Department of Health and Human Services, and serves 2/3 of the state's geographic area that provides services for people with severe mental illness. DDPC is part of the comprehensive mental health system of services in northern and eastern Maine, which includes community mental health centers, private psychiatric and community hospitals, and private providers. This program has 4 initiatives. The first initiative on page 231 establishes 1 psychiatric nurse practitioner position, a little over 36% general fund in the disproportionate share DDPC program, and a little over nearly 64% other special revenue funds in Dorothea Dix Psychiatric Center program to assist the psychiatrists and physicians and to avoid higher locum tenens contracts. This initiative also provides funding for related all other costs and transfers all other to personal services to cover the cost of the position. The initiative provides general fund personal services funding of $84,759 in state fiscal year 22 and $88,674 in state fiscal year 23, and reduces general fund all other by the same amount in those fiscal years. The next initiative on page 231 adjusts funding for positions in the Riverview and Dorothea Dix Psychiatric Centers as a result of the increase in the FMAP. The blended rate is 63.92% federal expenditures and 36.08 general fund in the federal fiscal year 2022, and 64% general fund and 64% federal expenditures fund and 36% general fund in federal fiscal year 23. These initiatives reduce general fund personal services funding by $255,630 in fiscal year 22 and $279,792 in fiscal 23. The next initiative on page A231 continues 1 limited period public service manager 3 position funded at 36.08% general fund in fiscal 2021-22 and 36% in fiscal 23 in the disproportionate share DDPC program, and 63.92% other special revenue in fiscal year 22, and 64% in 23 in the DDPC program, and provides funding for related all other costs. This position was continued by financial order 001058F1, and it transfers all other costs to personnel services funding of $60,000 to transfers all other to personal services to fund the position. The position will end on June 17th, 2023. The initiative provides general fund personal services funding of $60,090 in fiscal 22, $59,974 in fiscal 23, and reduces allocation by the same amounts in those same fiscal years. The initiative on page 231 reduces funding one time for employee mileage reimbursement of 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $1,599 in state fiscal year 22 and 23. The next program on page 232 is the disproportionate share Riverview Psychiatric Center. The Riverview Psychiatric Center is one of 2 inpatient public psychiatric hospitals under the Department of Health and Human Services, and in collaboration with the community, is a center for best practice treatment, education, research for individuals with serious persistent mental illness. The hospital is licensed by HHS and is accredited by the Joint Commission on Accreditation of Healthcare Organizations. This program has 2 initiatives. The first initiative is on page 232 and adjusts funding for positions in the Riverview and DDPC centers as a result of the increase in FMAP. The blended FMAP is 63.92% federal and 36.08 general fund in fiscal 22, and an even 64% federal and 36% general fund in fiscal year 23. This initiative reduces general fund personal services funding by $420,894 in 22 and $456,368 in fiscal 23. Next initiative on the same page reduces funding one time for employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $2,541 in state fiscal years 22 and 23. A couple pages ahead is the, on page 235 is Dorothea Dix Psychiatric Center program. Dorothea Dix Psychiatric Center, DDPC, is one of 2 inpatient public psychiatric hospitals under the Maine State Department of Health and Human Services. DDPC is part of the comprehensive mental health system of services, primarily in the northern and eastern regions of Maine, but also services patients statewide. The hospital is governed under the laws established by the Maine legislature to provide care and treatment for people with severe and persistent mental illness. This program has 6 initiatives. First is on page 235 and establishes 1 psychiatric nurse practitioner position, funded a little more than 36% general fund in the disproportionate share Dorothea Dix program, and a little less than 64% other special revenue funds in the Dorothea Dix Psychiatric Center program to assist the psychiatrists and physicians and to avoid higher locum tenens contracts. This initiative also provides funding for related all other costs and transfers all other to personal services to cover the cost of the position. This initiative provides all other to personal services to cover the cost of the position. This initiative provides other special revenue funds, personal services, funding of $150,164, state fiscal year 2022, $157,641 in state fiscal year 23, and reduces allocation to other special revenue funds, all other, by $150,164 in 22 and $157,641 in 23. The next initiative on page 235 adjusts funding for the positions in the Riverview and Dorothea Dix Psychiatric Centers as a result of the increase in FMAP. The blended rate is 63.92% federal and 36.08 general fund in fiscal year 22, and 64% federal, 36% general fund in fiscal year 23. This initiative increases allocation and other special revenue funds, personal services by $256,919 in 22 and $281,081 in state fiscal year 2023, and other special revenue funds by $8,221 in state fiscal year 22 and $8,995 in state fiscal year 23. The next initiative on page 235 provides allocation to align resources. This initiative increases allocation and other special revenue funds, all other, by $500,520 in fiscals 22 and 23. The next initiative on page 235 provides funding in the integrated care management system at DDPC. This initiative provides general fund all other funding of $306,374 in state fiscal years 22 and 23. Next initiative on page A236 continues 1 limited period public service manager 3 position, funded 36.08% general fund in fiscal year 22 and 36% in fiscal 23 in the disproportionate share DDPC program, and 63.92% other special revenue in fiscal 22 and 64% in fiscal year 23 in the DDPC program, and provides funding for related all other costs. This position was continued by financial order 001058F1. It transfers all other to personal services to fund the position. The position will end on June 17th, 2023. The initiative increases allocation in other special revenue funds, personal services by $106,833.22 and $106,998.23. Reduces allocation in other special revenue funds, all other, by $106,833 in state fiscal year 22 and $106,998 in state fiscal year 23. The next initiative on page 236 reduces funding one time for the employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic based on prior expenditures. This initiative reduces general fund all other funding by $776 in state fiscal year 22 and 23. The next program on page 238 is a driver education and evaluation program, sometimes called DEEP. This program provides services to adults and teens involved in alcohol and drug-related motor vehicle incidents. This program has one initiative. The initiative is the employee mileage reimbursement reduction by 15% due to travel decrease during COVID-19 pandemic and based on prior year expenditures. The initiative reduces general fund dollars funding by $815 in state fiscal year 22 and 23. Next program on page 241 is forensic services. The goal of the state forensic service is to provide high quality, impartial, psychological and psychiatric evaluations and expert testimony to the court at a reasonable cost. State forensic service conducts court-related evaluations only in criminal cases. This includes pre-adjudicatory services of competence to proceed and criminal responsibility, evaluations of juvenile defendants, and pre-sentence evaluations. State Forensic Service also provides education and consultation to ensure that services provided must meet national standards of the application of psychological and psychiatric data to psycho-legal questions. This program has one initiative. And that initiative on page 241 reduces one-time the employee mileage reimbursement by 15% due to a decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $325 in the upcoming biennium. The next program on AA 275 is Mental Health Services Community. This program provides direct and contracted services to adults with mental health disorders. Services include community support, residential, medication management, outpatient treatment, crisis, peer organizations, vocational, and other services to meet client needs. This program has 10 initiatives. The first initiative is on page 275 and establishes one public service manager 3 position funded 50% general fund in the Mental Health Services Community Program and 50% general fund out of the Office of Substance Abuse and Mental Health Services Program to serve as Deputy Director of Operations. This initiative provides general fund personal services of $86,622 in state fiscal year 22 and $87,220 in state fiscal year 23, and all other funding of $3,177 in 22 and 23. The next initiative on page 275 as well provides funding to continue the Crisis Center in order to meet the requirements of the consent decree, which is intended to provide crisis services in Cumberland County. This initiative provides general fund all other funding of $250,000 in state fiscal years 22 and 23. The next initiative on page 276 reduces funding in the Mental Health Services Community Program by recognizing contract savings and program efficiencies. This initiative reduces general fund all other funding by $1.73 million in state fiscal year 22 and 23. The next initiative on page 276 establishes one public service executive 3 position, 1 social service program manager position, and 8 intensive case manager positions funded 100% general fund in the Mental Health Services Community Program to coordinate services related to forensic individuals across the state. Also, this initiative also provides funding related to all other costs. This initiative provides general fund personal services funding of $960,716 in state fiscal year 22 and $1,006,606 in state fiscal year 23. General fund all other funding of $76,248 in 22 and 23. Next initiative on the same page provides funding to increase an agreement with Disability Rights Maine to expand advocacy services for community-based mental health services. This initiative provides general fund all other of $183,909 in state fiscal year 22 and 23. The next initiative on the same page provides allocation to align with available resources. This initiative increases allocation in the federal block grant fund all other by $1,815,253 in state fiscal year 22 and $1,810,709 in state fiscal year 23. The next initiative on the same page continues one limited period Public Service Manager 3 position to serve as Deputy Director of Strategic Planning, previously established by a financial order to manage the grant, contract, administrative, and finance teams and communications, and reduces all other to fund the position. This initiative provides general fund personal services funding of $173,241 in state fiscal year 22 and $173,233 in state fiscal year 23, and it reduces general fund by the same amounts in 22 and 23. The next initiative on page 276 continues one limited period position public service one limited period Public Service Manager 3 position in the Mental Health Services Community Program General Fund to serve as Deputy Director of Research and Evaluation. It transfers all other funding to personal services to fund the position. This position was previously established by a limited period position by financial order and will end on June 17th, 2023. This initiative provides general fund personal services funding of $173,241 in fiscal 22. $173,233 in state fiscal year 23. It reduces all other funding by the same amounts in the same fiscal years. The next initiative on page 277 reduces funding on a one-time basis for employee mileage reimbursement due to a 15% decrease in travel during the COVID pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $10,273,000 in state fiscal year 22 and 23. The next initiative provides funding for the approved reclassification of one behavioral health program coordinator position to a social services manager 1 position retroactive February 2019. This initiative provides general fund personal services funding of $24,932,000 in state fiscal year 22 and $16,363 in state fiscal year 23. We will stay on the next page for the Mental Health Services Community Medicaid account. This program provides direct and contracted services to adults with mental health disorders. This program has 6 initiatives. The first initiative is on page 278 and adjusts funding as a result of the increase in the FMAP for federal fiscal years 21, 22, and 23. This initiative reduces general fund all other funding by $157,896 in state fiscal year 22 and $263,159 in state fiscal year 23. The next initiative on the same page provides funding for a new intensive outpatient program for high acuity Maine Care members to address the gap in Maine's behavioral health service system. This initiative increases allocation in other special revenue funds, all other, by $410,235 in 22 and 23. The next initiative on page 278 adjusts funding in the Medicaid dedicated tax accounts and the corresponding general fund accounts to bring baseline resources in line with the December 2020 Revenue Forecasting Committee recommendations. This initiative provides general fund all other funding of $540,637 in fiscal years 22 and 23 and reduces all other special revenue by the same amount in the biennium. The next initiative on page 278 increases funding in the medical care payments to providers program and decreases funding in the low-cost drugs to Maine elderly program, mental health services community Medicaid program, the Office Substance Abuse and Mental Health Services Medicaid Seed Program to consolidate the 4 Medicaid assistance programs into one program as part of the consolidation of main care related programs from 13 to 4. This initiative reduces general fund all other funding by $40,660,075 in state fiscal years 22 and 23. On the next page, the next initiative increases funding in the medical care payments to providers program and decreases funding in the mental health services community Medicaid program, Office of Substance Abuse and Mental Health Services Medicaid Seed, and the Medicaid Services Developmental Services Program to consolidate the 4 programs into one program as part of the consolidation main care related programs and accounts. This initiative decreases allocation of other special revenue funds, all other, by $3,030,000 in the biennial. Well, it actually decreases it by that amount in 22 and then 23. The next initiative on page A279 as well increases funding in the Mental Health Services Community Medicaid Program and decreases funding in the Medicaid Services Developmental Services Program to consolidate 2 accounts into one as part of the main care consolidation proposal. This initiative decreases allocation in other special revenue funds, all other, by $3,941,833 in state fiscal years 22 and 23. The next program on page 298 is the Office of Substance Abuse and Mental Health Services Medicaid Seed. This program contracts with treatment services providers and develops and delivers substance use disorder services to persons in the correctional system and oversees treatment programs. This program has 4 initiatives. The first initiative on page 298 adjusts funding as a result of the increase in the FMAP for federal fiscal years 21, 22, and 23. This initiative reduces general fund all other funding by $25,816 in state fiscal year 22 and $43,028 in state fiscal year 23, reduces allocation in the Fund for Healthy Maine, all other, by $4,329 state fiscal year 22 and $7,216 in fiscal 23. The next initiative on the same page provides funding for a new intensive outpatient program for high acuity main care members to address the gap in Maine's behavioral health system. The initiative provides general fund all other funding of $534,729 in state fiscal year 22 and $533,307 in state fiscal year 23. The next initiative on page 298 increases funding in the medical care payment to providers account and decreases funding in the low-cost drugs to Maine's elderly program, the Mental Health Services Community Medicaid Program, the Office of Substance Abuse and Mental Health Services Medicaid Seed Program to consolidate the 4 Medicaid assistance programs into one program as part of the consolidation of main care related programs, 13 appropriations to 4. This initiative reduces general fund all other funding by $5,681,926 in state fiscal years 22 and 23. The next initiative on page 298, nope, we're on 299, increases funding in the medical care payment to providers program and decreases funding in the mental health services program, community Medicaid program, the Office of Substance Abuse and Mental Health Services Medicaid Seed, and the Medicaid Services Developmental Services Program to consolidate 4 programs into one as part of the consolidation of main care related programs and accounts. This initiative decreases the allocation in other special revenue, all other, by $800,000 in 22 and 23. The next program is on page 300. It's the Office of Substance Abuse and Mental Health Services. This program contracts with treatment services providers and develops and delivers substance use disorder services to persons in the correctional system and oversees treatment programs. This program has 8 initiatives. First initiative is on page 300 and establishes 1 Public Service Manager 3 position funded 50% general fund in the Mental Health Services Community Program and 50% general fund in the Office of Substance Abuse and Mental Health Services Program to serve as Deputy Director of Operations. This initiative provides general fund personal services funding of $86,619, 22, and $87,216 in fiscal 23, and general fund all other related costs. The next initiative on page A300 provides one-time funding to establish the overdose prevention through intensive outreach, naloxone, and safety program. We refer to this as options sometimes, to raise awareness around drug overdose risks and promote the new opioid use disorder and substance use disorder treatment locator. This initiative provides allocation in Fund for Healthy Maine, all other, of $1 million in state fiscal year 22 and 23. The next initiative on page 301 transfers one Public Service Manager 3 from the Office of Substance Abuse and Mental Health Services Program to the Maine Center for Disease Control and Prevention Program within the same fund, and transfers funding for all other costs. This initiative reduces general fund personal services funding by $153,912 in state fiscal year 22 and $155,169 in 23, and reduces general fund all other by $6,354 in state fiscal years 22 and 23. The next initiative on page 301 establishes one epidemiologist position to strengthen internal epidemiology expertise to assist with tobacco and substance use initiatives and provide funding for related all other costs. It also transfers all other to personal services to partially fund the position. This initiative increases allocation in federal block grant fund personal services by $94,239 in state fiscal year 22 and $98,918 in state fiscal year 2023, and reduces federal block grant fund by all other by $81,748 in state fiscal year 22 and $81,640 in state fiscal year 23. The next initiative on the same page provides allocation to align with available resources. This initiative increases the allocation in the federal block grant fund by all other by $162,081 in 22 and $151,044 in state fiscal year 23. The next initiative provides allocation to align, which is also on page 301, provides allocation to align with available resources. This initiative increases allocation in the all other federal account by $6,564,196 in 22 and $6,559,016 in state fiscal year 2023. Next initiative, also on the same page, continues one limited period management analyst 2 position previously continued by a financial order to serve as the opioid response project manager to oversee and coordinate opioid related projects and provides funding for related all other costs. This position will end on June 17, 2023. This initiative increases allocation in the federal block grant fund personal services by $89,479 in state fiscal 22, $93,892 in state fiscal 23. Federal block grant fund all other by $8,560 in 22 and $8,661 in fiscal 2023. The final initiative in this section is on page 301 as well, and reduces funding due to the mileage reimbursement decrease due to the pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $1,573 in state fiscal year 22 and 23. The next program is on the next page, A302, and it's the Opioid Use Disorder Prevention and Treatment Fund. This program has no initiatives. The next program on page A309 is the Riverview Psychiatric Center. Riverview Psychiatric Center is one of 2 inpatient public psychiatric hospitals under the Department of Health and Human Services, and in collaboration with the community, is a center for best practice, treatment, education, and research for individuals with serious, persistent mental illness. The hospital is licensed by HHS and accredited by the Joint Commission on Accreditation of Healthcare Organizations. This program has 4 initiatives. The first initiative is on page 309 and adjusts funding for positions in the Riverview and DDPC centers as a result of the increase in the FMAP. The blended FMAP rate is 63.92% federal and 36.08 general fund in fiscal 22 and 64% federal, 36% general fund in fiscal 23. This initiative increases allocation in all other special revenue funds, personal services by $420,000, 894 in state fiscal 22, and $456,368 in state fiscal year 23. And other special revenue, all other funds by $13,469 in 22 and $14,604 in state fiscal 23. Second initiative in the Riverview account is on page 309 and provides allocation to align with available resources. This initiative increases the allocation in all other by $1,425,600 in 22 and 23. The third initiative is also on page 309 and provides funding for the integrated care management system at Riverview Psychiatric Center. This initiative provides general fund all other of $306,374 in fiscal 22 and 23. The next initiative is the familiar employee mileage reimbursement reduction due to the pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $112 in 22 and 23. The next initiative is on it's from the program Medical Care Payments to Providers, and you can find that on page 264. Although the first initiative is going to be on 266. So page Medical Care Payments to Providers, which is the main care account, starts on 264, but this first initiative can be found on 266, reduces the Institute for Mental Disease outpatient reimbursement to 100% of costs. This initiative reduces general fund all other funding by $340,298 in state fiscal year 22 and 23, reduces allocation in the federal all other account by $671,405 in state fiscal year 22 and 23. The next initiative on page 266 as well eliminates exceptions for psychiatric units rate, eliminates exceptions for psychiatric units rates per discharge. This initiative reduces general fund all other funding by $711,456 in state fiscal year 22 and 23, reduces allocation in federal expenditures all other by $1,843,551 in state fiscal year 22 and 23. The next initiative on page 268 provides funding for a new intensive outpatient program for high acuity Maine care members to address the gap in Maine's behavioral health system. This initiative provides general fund all other funding of $410,893 in state fiscal year 22 and $410,237 in state fiscal year 23, and increases allocation in the federal expenditures all other by $5,352,867 in 22 and $5,354,945 in state fiscal year 23. The next initiative on page 269 adjusts funding as a result of maximizing the FMAP by incorporating the primary care case management, primary care health homes, and the primary care provider incentive payments into population-based payments that are directly tied to performance on quality, utilization, and cost measures. This initiative reduces general fund all other funding by $59,595 in state fiscal year 22 and $53,456 in state fiscal year 23, and increases allocation in federal expenditure fund all other by $59,000 by the same amounts in the fiscal year. That is the end of the initiatives related to that section. We'll turn to page 40 in the language section. I haven't been on mute this whole time, right?
Oh, I'm so sorry. You're going to have to start over. I apologize.
On the language section of the budget, the next submitted piece of language is on 40L, Part UU. This part authorizes the Department of Health and Human Services to transfer by financial order available personal services balances in the disproportionate share DDPC Center, the disproportionate share Riverview Psychiatric Center program, the Riverview Psychiatric Center program, and the Dorothea Dix Psychiatric Center program in order to provide flexibility in the payment of operational expenses. The next submitted piece of language is also on the same page. It's part VV. This part renames the Office of Substance Abuse and Mental Health Services within the Department of Health and Human Services to the Office of Behavioral Health. We will move back over to the budget, part A, and to the brain injury section, which is the final section of my testimony. That's on page 214. The next program on page 214 is brain injury. This program provides supports and services to persons with brain injuries, related conditions, pre-admission screening, resident review qualifications, and geropsychiatric qualifications. This program has 3 initiatives. First initiative on page 214 transfers funding for an advocacy contract from Developmental Services Community Program, Office of Advocacy, BDS program, and the Brain Injury Program General Fund to the Office of Main Care Services Program Federal Expenditures Fund. This initiative reduces general fund all other funding by $24,722,000 in state fiscal year 22 and 23. The next initiative on page 214 reduces one-time mileage reimbursement by 15% due to the decrease in travel during the COVID-19 pandemic and based on prior year expenditures. This initiative reduces general fund all other funding by $899 in state fiscal year 22 and 23. The next initiative on page 214 as well transfers 1 part-time social services program specialist, 1 position from 100% general fund in the brain injury program to 100% general fund in the developmental services community program. This initiative reduces general fund personal services funding by $44,091 in state fiscal year 22 and $46,107 in state fiscal year 23, and general fund all other funding by $6,354 in state fiscal year 22 and 23. The next program is over on page 262, is the Medicaid waiver for brain injury residential community supports. Neurobehavioral services and brain injury services assist, educate, and rehabilitate persons with acquired brain injuries to attain and sustain the highest function and self-sufficiency using home-based and community-based treatments, services, and resources to the greatest extent possible. This program has 2 initiatives. First initiative is on page 262 and adjusts funding as a result of the increase in FMAP for federal fiscal years 21, 22, and 23. This initiative reduces general fund all other funding by $24,508 state fiscal year 22 and $40,848 in state fiscal year 23. Next initiative on page 262 as well increases funding in the Medicaid Services Developmental Services Program and decreases funding in the Developmental Services Waiver Main Care Program, Developmental Services Waiver Supports Program, Medicaid Waiver for Other Related Conditions Program, the Traumatic Brain Injury SEED, and the Medicaid Waiver for Brain Injury Residential and Community Supports Program to consolidate the 6 waiver programs into 1 program as part of the consolidation of main care related programs from 13 to 4. The initiative reduces general fund all other funding by $7,393,448 in state fiscal year 22 and 23. The next program is on page 315, and it's the Traumatic Brain Injury SEED program. This program provides a variety of supports and services to individuals with brain injury. The program has 2 initiatives. The first initiative on page 315 adjusts funding as a result of the increase in the FMAP for 21, 22, and 23. This initiative reduces general fund all other funding by $409 in 22 and $681 in fiscal 23. Next initiative on page 315 increases funding in the Medicaid Services Developmental Services Program and decreases funding in the Developmental Services Waiver Main Care Program, Developmental Services Waiver Supports Program, Medicaid Waiver and for Other Related Conditions Program Traumatic Brain Injury SEED program and the Medicaid waiver for brain injury residential and community supports program to consolidate the 6 waiver programs into one program as part of the consolidation of main care related programs from 13 to 4. This initiative reduces general fund all other funding by $123,262 in state fiscal year 22 and 23. It might be a good time to just mention if you accept the main care consolidation initiative, all of the FMAP, instead of spreading those FMAP changes across 13 accounts, it would be spread across many fewer, which would provide more of a forest view instead of the trees view, as was mentioned yesterday. But that concludes my testimony, and thank you for the opportunity to present the governance budget proposal for the Department of Health and Human Services.
Thank you, Mr. Mann. That was quite a marathon. So I imagine my colleagues have some questions, and we have 13 people for public testimony. Would you, Mr. Mann, like to take a break before we start with questions? Should we take 10 minutes so you can do whatever you might need to do before we start with questions?
5 or 10 minutes would be appreciated.
Okay. It is on my watch or my clock, it's 2:38. How about we come back in about 10 minutes, maybe 10 minutes to 4? So that would be, no, 10 minutes to 3. So that would be 2:50. Okay, thank you, everyone. Hi, everyone. I think we'll just give Mr. Mann a minute or two to get back. And if you want to, I see 2 people in the queue for questions. If anyone else has questions, if you wouldn't mind, go bring your cursor down to the bottom of the Zoom box and you'll see the raise hand section and you can put your hand up electronically. Looks like Mr. Mann is back. Are you ready to take some questions from the folks on the committee?
Certainly.
Great, thank you. So I have Representative Fay, Representative Limelin, and Representative Javner in the queue.
Thank you,
Go
Madam
ahead,
Chair.
Representative Fay.
Thank you. Mr. Mann, that was quite a feat of vocal, I don't even know what to say. That was just pretty amazing. I, who have been known to talk a lot, could not talk for that long. So kudos. So I have 2 questions. And the first one is there's a number, and I think somebody already asked this maybe earlier. There's a number of positions which are limited and termed, and not for now, but maybe for the work session, can we get maybe a more consolidated list of all of those positions? And maybe if there's a particular reason why, it sounds like they were limited originally. So, but if there's more information about that, I'd appreciate that. And then the other question I had was about, I noticed in a couple of the initiatives, there were some anticipatory funding increases for planned rate studies. And I think we touched on this yesterday as well, but I'd really love to know what the schedule is for rate studies for all of the main care sections, or the ones that there has been a planned study for, and what that timeline looks like. Those are my questions.
Sure. Just to address a couple of them now, and we can get into more detail during the work sessions, obviously. Just generally, if a position was established as limited period, we tended to continue it as limited period. Limited period positions have all of the state line benefits and they look and feel like state lines, except for the period of time that they're authorized for, and they can be extended. So we opted for that approach generally. Related to rate studies, I know we needed to, Michelle, Director Probert, can come, and I know she is eager to update this, both committees on the rate system evaluation, which we've done a couple of releases for in terms of the benchmarking study, and the interim report is public and available on our website, and I'm sure you're hearing about parts of it. So we're happy to talk to you all about that rate system evaluation, which would be included as part of that, the prioritization study that you heard me mention was for the kids residential piece, $4.5 million general fund, which is we are requesting, and that was sort of for anything that was planned previously. We tried to continue that, and that is tied to a larger initiative for as part of the Families First Prevention Services Act to upgrade the kids residential to qualified residential treatment programs, which would incur more costs, which is why we are proposing additional higher rates pursuant to the rate study.
Next is Representative Lemelin, and I apologize if I'm saying that improperly, and then Javner, and then Craven.
No, ma'am, you pronounced it properly. Thank you. I have 3 quick questions. One, my concern is with the mileage reduction. Why is it only 15%? I would have thought that it'd be a little bit higher.
Um, 15% is a fairly sizable cut to realize immediately. We put that forward in the supplemental as well. We don't know what, COVID is here to some extent going going forward. We felt like the 15% was a fairly reasonable number to go forward. I believe, if I'm not mistaken, it totals to $433,000 in 22 and 23. If you add up all the different reductions across the appropriations. And a lot of our work continues. Our child welfare caseworkers are doing their investigations and have been for some time. They are a large, they receive that reimbursement in part. So I think we felt like 15% was the right size to.
And on page 261, you indicated that it says that there's increased funding to main care, but decreasing funding to the waiver programs. It does not say how much it's decreasing to the waiver programs. Do you have that amount?
I'm sorry, can you tell me which initiative on 261?
The very first one at the top of the page there is increasing funding to Medicaid services, where it's 175 million total.
Yep. So that's a fairly straightforward one, because I read dozens of initiatives for the main care consolidation proposal that we have, and those are all net neutral costs. There's no impact to providers or the services themselves. We are moving money from one account into a different account and consolidating the other accounts to provide administrative efficiency and other benefits. So that that's moving $175 million in, and that 175 is just dispersed in other accounts in other appropriations. So it's net. There's no savings involved with it. There's no cost to the state. It is an administrative proposal that we have based on just consolidating the main care accounts.
Okay, I understand that, but it says that it decreases funding in the developmental services waiver.
Yeah, so
that's actually decreasing funding.
No, so the initiative on page 261, that's increasing if you add up the accounts from the waiver programs that are listed in the initiative, they will total 175, and you'll find those totals in those appropriations in different parts of the budget. So the reason this, this is the waiver program that we're proposing to consolidate all of the other waiver programs into, which is why there's an increase here. There's a corresponding decrease in the exact same amounts in the other waiver programs.
Okay, and this is it leads to my last question. Could you explain just a little bit about the main care consolidation, 6 waiver programs into 1 and 13 total programs into 4 programs in the Medicaid system?
Happy to. I just got into it a little bit, but we are, there's, like I said, that there's no impact to any payments being made or services being delivered. The general fund, there's 13 general fund accounts, and there's also a commensurate amount on the other special revenue tax accounts related to the service provider tax. We are proposing to consolidate those into fewer accounts. I think when if you have $100 and you needed to keep your $100 in 13 different accounts, we need to create a cushion, or we need a reserve amount to prevent emergency supplemental requests and other, cycle crashes on being unable to provide funding when we pay providers, usually on Wednesdays of every week if they're weekly billers. So we have to reserve a certain amount of money. We can reserve less money if we consolidate accounts which is why we're proposing that consolidation from 13 to 4. You can also, I mentioned at the end of my testimony that there's a lot of, the FMAP changes, which happen every single year, are spread across all of those accounts. And I think it would be simpler and more transparent if we just consolidated the general fund accounts to align with the federal accounts. There's only 4 federal accounts as well. and we can for those efficiency, and we propose $3 million worth of savings across that due to the consolidation.
Okay, thank you very much.
I think I would just note that I believe OFPR is going to brief you all on the consolidation as well as part of other FMAP, fundamental aspects of FMAP as well.
Next is Representative Javner, and then Craven, and then Senator Claxton.
Thank you, Madam Chair. Again, thank you, Deputy Commissioner Mann. So my questions, again, are going to be just information that I would like provided for the work session. Do not feel obligated to answer them right now. On A273, there's a term that's used, delaying contracts. I think I've seen it a couple different places throughout the budget. I just like to know really what that means, because it's a savings. And then on A308, on the first initiative, what exactly is this and what are the funds going to be used for? And then A215, how and why was the percentage changed from 51% to 40% for the BRAT program? Was this done by rulemaking? I'd just like to know the history behind that. A276, I would like a copy of that financial order that is referenced that established the positions. And then in A277, there was a retroactive piece to 2019 for a position. I think it was like around $24,000. I'd like to know why is that being retroactive. And then A278 on the second initiative, what is this new program that is referenced? And then in A298 is the funding piece, I think, for it. So thank you.
All set, Mr. Mann?
Yeah, I didn't catch all of that. We can follow up, but just we did change the BAP program from 51% of income to 40% by rulemaking. And that went into effect last year. By any measure of the sense, 51% of income being paid towards rent is certainly and unquestionably rent burdened. And we made that change. I think there's information online that we can, and I can provide further information in the work session. The financial orders, we can pull that. That's all publicly available as well on the DAF's website. We can pull that financial order for you. And generally, whenever you see retroactive, retroactive funding being provided, that's not always, but generally is a employee-led FJA for a reclassification of their position. And I didn't catch I imagine that's what the initiative that you were asking about was related to.
Representative Javner, also, if you don't mind, just on that BRAT program, the mental health working group that came out with recommendations last year, this addresses one of those, because there are a lot of landlords who just won't sign a lease for somebody who is supposed to be giving 51% of their income to housing. So one of the recommendations was to change that ratio so that folks who receive BRAP have a lower ratio of their income so that they could actually get on leases, and that landlords would have a little bit more confidence that they could pay their rent. Just a little background. So Representative Craven, then Senator Claxton, and then Representative Stover.
Thank you, Madam Chair. Thank you, Mr. Mann. I've never seen this before, but on page 298, the substance use disorder line, it said, it talks about overseas treatments. I wondered what that was.
What overseas treatment means? That overseas is a verb there, not a noun. I don't. I mean, the mental health substance abuse that account, they monitor and provide treatment programs to those with serious and persistent.
I was thinking of going abroad.
I think Representative Craven has a little bit of cabin fever that she's sharing with us. Senator Claxton.
Thank you, Madam Chair. When we combine these accounts, do we then make the formerly independent accounts compete against each other for dollars? Are they still kept as separate cost lines underneath the combined account?
I wouldn't think about it in those terms. There's no competing for resources, whether or not a service or a program is in the same appropriation as another service. We have contractual obligations. We have rates that are set by our state plan with CMS or also in rule and or state law or requirements. Some rates are pegged to Medicare. So we have there's a variety of ways that providers are assured some certainty over what the rates that they will receive are. And the consolidation won't interfere with that. We would just be combining funds into larger accounts. For example, the 0147 account, the payment to providers, the main care account has in excess of $500 million today. And that funds the majority of programs across main care.
Okay, thank you.
Representative Stover.
Thank you, Madam Chair. I had one question. See if I can find my place here. Thank you. On page 276, and it was the first initiative at the top of the page that says reduce funding in mental health services community program by recognizing contract savings and program efficiencies. And for the work session, if we could get into exactly how many contracts, what those services actually are for that 1.7 million. Senator Breen mentioned this morning some of her concerns. I work for a couple of nonprofits and do work with people living with mental illness. And I'm just curious where those savings could come from, because we're seeing a lot of people with very high acuity exacerbated by COVID. So if we could talk more about what that is in the work session, I would really appreciate it. Thank you.
Certainly. Just for now, the overwhelming piece, about 1.5 million of that 1.7 is related to contracts that have been in place for several years related to PMIEs. We pay for medical services, obviously, for PMIEs. And then also we have room and board contracts. These are separate supplemental contracts on top of those that not all providers have. There's only a select few of providers that have these contracts. We're proposing to eliminate those based on, we've had trouble in the past to determine exactly what the funds are going towards. And there are separate, we have our, these services are provided through either medical services or the room and board contracts, which should capture the costs that are being incurred by the providers.
Thank you. So based on that, there wouldn't be a reduction in any service under this initiative?
We were proposing to eliminate the contracts that are in place. Again, we've had trouble to determine, we've done some due diligence over trying to make sure that we have a strong understanding of what they're going for. We've had trouble ascertaining that. So it would be a reduction of that amount that are going to providers that are running PMIEs right now. But again, the PMIEs have a slightly different rate structure. They're budget-based as opposed to rate-based or cost-settled. So if they have allowable medical services or room and board services, those are the two, that's how we reimburse, obviously primarily through medical services. So if they're related to that, then they would be able to submit a request to increase their budget through those means, but they would have to fall under the the eligible activities and uses for that. That's, you know, just a basic principle of our reimbursement.
So this would be a reduction, not an elimination. It says reduce.
We are proposing to eliminate the contracts that are currently in place.
Reducing the funding. Okay. Thank you. If there's more information we can have at the work session, I appreciate that.
I have a couple of questions, but I just want to defer to my colleagues if there's anybody else who has questions for Mr. Mann. Okay, I have a couple of specifics. One is that I'm not familiar with the term Medicaid seed. Oh, I see Representative Hymanson. One second. What is Medicaid seed? What does that mean? Is that like a, it's a new term for me.
Yeah, I can follow up with more information as well. The Medicaid seed is providing, those accounts are very small in terms of dollar funding. And I think it's generally, some of the accounts are related to mental health services, and they fund the programs related to that. And I think it's just an anachronism from how the accounts were originally created and for the purpose. And there's certain eligibility determinations on the use of the funds, but they're, my recollection serving right, those they are they're small accounts overall.
Okay, if you could get us that definition, or you know what that means for the work session, that would be great. Also, in the governor's press release about the biennial budget, she mentioned a total of $7.5 million in new funding for mental health. And so I'm wondering if you could tally that for us, because I'm having a, you know, there's a lot of initiatives, maybe they're in different, you know, funding streams, different little places in the budget. If you could get back to us with where exactly that 7.5 million is, that would be great.
Yep, if I think I have that list. That is the new main care IOP, the intensive outpatient, which would serve as a, you know, there's a gap in our continuum of care for mental health and SUD services right now, and would serve as a bridge between residential services and in community services. There's the crisis center funding. There's the forensic team proposal for the 8 ICMs and the clinical supervisor and the frontline supervisor. And then there's also the options outreach and education program, which is more on the SUD side, but is that mental health and SUD went together for the $7.5 million. I believe those 4 programs should total a $7.5 million over the biennium.
Okay, and I'd love to know where the IOPs are going to be, what, you know, geographically. And then lastly, I think, you know, what I'm hearing and what I feel about, and I'm just listening to people over the last couple of days, this consolidation of accounts, I feel confused about whether it's sort of an accounting change that is a way for you to manage the accounting stuff that obviously is enormous in the department, and you're trying to sync it up with some existing federal accounts. If it's kind of a spread, for lack of a better word, a spreadsheet exercise, you know, that would, or whether if there's something more substantive going on, and you know, because in a way it sounds like you're saving money, and if it's just a spreadsheet thing, then you wouldn't be saving money. So I think I'm trying to wrap my head around it, and that's kind of the gist of it for me, is whether it's something that's just how you manage numbers, or if there's actually programmatic changes, or you know, more substantive changes going on. So
yeah,
when you get us that would be helpful.
Yeah, just to stay on that topic for a second, I like the framing of a spreadsheet thing. I think it is that.
Of course you do. You're a finance guy.
Guilty. However, the main care account, there's considerable volatility in it due to enrollment gains, due to utilization changes, due to rate changes. We have different FMAPs applying for different programs and managing that across all of the accounts. Some providers bill weekly, some bill monthly, some bill quarterly. The administrative requirements to make sure that those cycles, so those cycles, when I say cycle, I mean those payments, whether on whatever frequency they're happening on, to make sure that we don't run a deficit in a certain week when main care resources are pushed out on a weekly or monthly basis is a lot. We typically have, we transfer money between accounts occasionally when we run when there might be a cycle crash, so we don't have to come and ask for supplemental appropriations. So I think that this is a spreadsheet thing to try to reduce the volatility in the programs, because some of this is created from the appropriations. We have a certain amount appropriated in an account, and that's how much we have to use. And if there's a little volatility on it, we're going to over encumber what that account has. We literally cannot pay providers for that week, or they're going to have to go without payments. So consolidating the accounts will allow us to have more flexibility and pay the providers what they need to on the frequency that they are getting. I have spoken, you've probably heard me say before, we try to at the end of the year or at the end of the quarters have at least 1 to 2 cycle payments overall in the main care accounts as a cushion, so that we know that we can pay providers what they need. A cycle is something between $17 and $19 million a week. If we consolidate the accounts, we will need less money in reserve, because there'll be more money in each account by definition. So that's where the $3 million savings from. So there's no rate changes. There's no reduction in what we are paying providers, and there will be no impact to the services being delivered due to the consolidation proposal. I think I think OFPR will offer some background for you all as well. I think this has been a long-standing desire of the department to do this for other reasons as well, like I mentioned, to align to the federal side, so that there's just some simplicity in the system. I think we are trying to create a simpler process so it's a little more transparent. Like I said at the end of the testimony, a lot of those FMAPs, one program might hit against 4 different main care accounts, which is why you hear me repeat the same language over and over again. Those accounts could be consolidated, and then there would be one initiative with the full amount instead of initiative with 37% of the funding in Z217 and 42% of the funding in another account over there. I'm happy, and we'll put together that crosswalk and go over it, which I think will help explain things as well.
Thank you very much.
It will likely be a spreadsheet.
Awesome. Molly Bogart, you turned your camera on. Is there something were you going to do like a legislative whisper thing and try to answer that question, or no?
No, just taking my notes and here if you need me.
All right, thank you. Representative Hymanson.
Thanks. I'm going to be brief because I do want to hear the public hearing part of this. But the Families First funds, when are they expected to land on our door? I know there's a lot of preparation that we have to do before they come.
Yep. That is a new law to, just for background, to prevent kids from coming into care, to do work on the front end so that we can support families and so that kids don't come in under the care or custody of the department. I think we just submitted our plan to the feds, and there's still some other requirements that we need to go through to meet that. I don't have it. I can get the numbers on the timeline for it. I don't have it off the top, but things are progressing. And the law, I believe, was passed in late 2018. I'm not sure if any states are currently fully implemented yet.
Yeah, okay, just a broad view of that. The reclassification of the 47 mental health workers, what's the effect of the reclassification?
As I mentioned to Representative Javner, that was an employee-led classification. Our HR went through the whole HR process. You can see the numbers. So there's a retroactive piece and an ongoing piece. They were upgraded to a certain degree, and you can see the numbers in there on an ongoing basis.
Okay, thanks. The standardized developmental disability needs assessment. So that was a difficult issue a few years ago, and ultimately that needs assessment was pulled, and it cost a lot of money, and there was a lot of heartache around it. So I wonder how this was chosen, and maybe this is too much of a policy issue, but I'll give HHS committee a heads up to explore that.
The department continues to feel strongly about it. The needs assessment is intended to ensure fairness and equity across the waiver providers and for adults with intellectual and developmental disabilities. This would create a third-party conflict-free assessment to determine the right level of care for these individuals. Currently, no needs assessment is conducted for folks on 21 or 29. Some might be receiving too much in services and some might be receiving too little. So we would, moving forward with that, third-party conflict-free assessment would help to right-size that. And I think this was a prerequisite on some of the larger reform efforts that are interested going forward, like the lifespan waiver program, which has interested parties in the department and providers as well.
Yeah, no, I realize that. I'm just saying that the needs assessment tool, is a difficult choice, and I think that needs to be explored carefully before we step into another one that has problems the same way. So there's history there. I'm just bringing that up. So the rate increases for Section 21, do those go to salaries only, or is that for the service provider?
We don't deter. This has come up from time to time. We don't determine salaries or wages for employees. We just pay the rate and make assumptions around it. That increase for 21 and 29, which is $32 million annually, all funds, around just under 10 million general fund. That approximately half is to increase the minimum wage requirements. So in that way, we are making sure that providers are fully made whole for minimum wage increases that have happened recently. And the other half is we increased the rates for community supports in last year's supplemental for 18 and 20, and this increases the community supports for 21 and 29.
All right, thank you for that. And what does this do to the current wait list of 21 and 29?
The current wait list would be unaffected by the rate changes. We have a separate initiative included in the budget that adds 30 slots to the 29 program per month over the biennium, which would reduce the wait list or allow us to keep up with it at least. But the rate increases would just be higher payments to providers.
Yeah, no, I was talking specifically about the wait list, a different question. So 30 slots per year for 29?
30 slots per month. Yep.
And that would keep up with the wait list?
It would keep up with the wait list in the biennium. Yes,
Okay. And I think that's all I had. Thank
we
you.
would.
Thanks.
All set, Representative Hymanson? Thanks. All right, so we have 15 folks who are waiting to give testimony, 15. I want to say thank you to all those folks who are waiting. I know this is a new format. It's really challenging. And on the one hand, you don't have to sit in the appropriations room all day. On the other hand, you do have to sit on Zoom all day, and we really appreciate your patience. My co-chair, Representative Peirce, has volunteered to man the, or woman, the 3-minute clock and be the bad cop. So I'm going to take her up on that offer. So I'm going to do what we've done in the past. And if some of you who are here to testify are not familiar with it, I'm going to move you from attendee over to panelist so we can hear your testimony and you can take questions, and then we'll have you back over to attendee status. And of course, anything that you've written and submitted to our clerk, we will certainly have on record as well. Any questions from any committee members before we hear from members of the public? Okay, great. So I'm going to just start at the top of my list. I have Alan Cobo-Lewis, Betsy Sweet, and Cullen Ryan. So Alan, I will move you over, promote you to panelist. I'm doing that right now. And hopefully you will pop up.
Madam Chair?
Yes.
I might give everyone a 15-second warning, so to speak.
Okay. Hi, Mr. Cobo-Lewis.
Hi, Madam Chair.
Good to see you.
Pleasure to see you as well.
So did you hear we're going to do the 3 minutes? Representative Peirce will give you a little 15-second love tap.
Yes, I did hear that.
All right, thank you. The floor is yours.
Okay, thank you. Madam Chairwoman, Mr. Chairman, distinguished members of the committees, my name is Alan Cobo-Lewis. I live in Orono. I'm the parent of 2 young adult children, one of whom has autism and significant need for support. I'm testifying neither for nor against the initiative on page A229 of the bill to appropriate 1.4 million in fiscal 22 and 4.7 in 23. This is for the 30 people per month. And the reason I'm neither for nor against is that it would not eliminate the wait list. It would simply tread water. So I'd like more money in that initiative. Section 29 is a last resort for people who may wait years upon years for comprehensive services and supports under Section 21 comprehensive waiver. That's why Maine eliminated the 29 waitlist in mid-2015 as a crucial part to settle a class action lawsuit. You can see that in the first graph of my testimony. 3.5 years later, the waitlist was back, climbed by a person a day, 30 people a month, until it was eventually topping off at 391 people, near the level that triggered the lawsuit. You did appropriate money last year to partially address the wait list, which is why it's now to 234 people. The 30 people a month would continue to partially address it to keep it from growing, but it would not eliminate it. It's unconscionable to have any wait list for Section 29. That's why we didn't have one for 3.5 years. You seemed on the verge of eliminating it last year, but all bills got jettisoned during the pandemic. Meanwhile, the waitlist for Section 21 stands at an all-time high of 1,874 people. That would keep growing under the proposed budget. So would the waitlist for Section 18 brain injury and Section 20 for people on other related conditions. That would also be that's also at an all-time high. 98 people could the smaller waiver. For people whose needs are typically met in a group home setting, Section 29 has an annual per person expenditure cap that would not pay for that. That's why you need to fund 21 as well. Waitlist cannot be explained by the state of the economy or the state of the budget. If you compare the first graph of my testimony to the second graph of my testimony, which is unemployment rates, you will find no correlation between those 2 graphs. Unemployment was high, waitlist grew. Unemployment was low, waitlist grew over a period of more than a decade, with the exception of a couple of significant actions, one for the class action and one the action that you took last year, and a couple of smaller scale ones. The waitlists have been allowed to fester and grow regardless of the state of the budget. Please appropriate enough money to eliminate the waitlist and keep them eliminated. I'm also testifying for the initiatives to raise the reimbursement rates for providers in order to raise wages. Because you have to solve wait lists and the workforce crisis both. Thanks to Representative Hymanson for raising that issue. I also want to note that while you have a tough job, you may be getting some help. In addition to the FMAP increase that you've already heard about, Congress is currently considering a 7.35% increase in FMAP specifically targeted at home and community-based services. I would suggest that if that money comes through, that at that amount or a similar amount, that amount's currently in the House bill, that money not be redirected toward other priorities, but be used to address wait lists and workforce crisis. And I'm happy that you might have.
Thank you, Mr. Cobo-Lewis. Any questions from any committee members? If you would raise your hand, that would electronically, that would be great. Representative Hymanson.
Hi, yeah, we had a really good breakdown of the Section 21 wait list. How many people were on it? You know, the 1, 2, and 3. You know, I forget the names now. But if we could have that again brought up to date, I'd appreciate that. It was also how many people had other services who were
right.
registered for 21 and were getting 29 services or 20 services, but still were on the 21 wait list, just so we can see what the real meat of the Section 21 wait list is. If the department could put that together again, I'd appreciate that.
And I can ballpark it for you while we wait for the department to give you, for work session, the updated numbers, but it's roughly 2,000 people who are on one or more wait lists, and about 1/3 of that 2,000 are getting nothing while they're on those wait lists. But I'm sure the department has updated numbers. That number's from a few months ago.
Great, thank you.
So, Mr. Cobo-Lewis, when you talk about that wait list, are you talking specifically about Section 21, 29?
Well, yeah, I mean, the four of them. The wait list that I think is the most crucial to address is the 29 wait list. 21's the big waiver. And as Representative Hymanson notes, that's a prioritized waiver. So people in priority 1 are no longer on a wait list. That was the other part of the settlement of the Aldrich lawsuit. People in priority 2 or priority 3 are still on a wait list, and they can be there for years and years. So that's the 1874 people. Is about 1/3 of that of those 1874 on priority 2, which is really a pretty significant level of need. And about 2/3 are on priority 3, which just means like they like to start their lives already. And some number of those people are getting Section 29, which partially meets their needs while they're on that 21 wait list. That's 29 is a first come first served wait list. So that's the one that it was clearly a policy of the state not to have a 29 wait list at all, so that people would not be completely high and dry while waiting for their needs to be really met. And then the other waivers for brain injury and other related conditions are smaller numbers of people. I'll confess that I'm less familiar with the details of how those operate, but those wait lists also exist, and you can clearly see that that one of the two of them is also growing. So now 98 people is a bit bigger than it was a couple of years ago.
Thank you. Any other questions for Mr. Cobo-Lewis? Okay, thank you.
I think Representative Hymanson maybe had one question.
Representative Hymanson.
Thanks. How about people, service providers in 29? What are you seeing, hearing?
I'm sorry. Could you elaborate the question?
Sure. The service provider, the DSPs for Section 29, people who actually show up and come to the house. What's happening as you see it?
Yeah, well, I mean, there's a workforce crisis. That's why I'm testifying on both initiatives, because the wages are not keeping up with what the market requires, and there was a workforce crisis before the pandemic. During the pandemic, it's even worse. So I think for all the waiver services, not all approved hours are being provided to a number of people on those services.
Thanks
And-
for reiterating that. I think we just need to hear that again. Thank you.
And I think that regarding the rates, frequently the legislature has acted to raise rates. I'm not sure if frequently is the right word. The legislature has at times acted to raise rates, and sometimes has chosen just to raise the rates, trusting that they'll go through to wages, and has at other times enacted language into the budget initiative saying it shall go to wages. I think that's a decision of the legislature, which direction to go on that.
Okay, thank you, Mr. Koval-Lewis. I'm going to move you now back over to attendee.
Thank you. I'm glad this worked.
Thank you. And just for the sake of new committee members, I'm sure you're going to hear from other members of the public. There's a lot of wait lists for a lot of services across Maine Care. So hang on, you're going to hear more about wait lists. I have no doubt. So the next person we have is Betsy Sweet, and then we'll have Cullen Ryan. So hang on, I'm going to move you over to a panelist, and you'll hear, hopefully you will appear before us magically. There, all right.
Hi, thank you very much. And chairs and members of the committees, thank you for your indulgence. I'm now speaking again on a different issue this time. And you will hear about wait lists, and you will hear about the worker crisis. I'm Betsy Sweet. I'm representing the Behavioral Health Community Collaborative, 7 large community-based nonprofit agencies who provide mental health and substance use disorder services in Maine. And the issue that you just heard about and the new initiatives that you heard in mental health is awesome, great. But it's being built on a crumbling foundation. A lot of the wait lists that we have are because we cannot hire staff to fill the programs, to meet the programs, because we do not pay enough money. And we are no longer competing with DD, between an elderly and DD. We are competing with Walmart and McDonald's. That's where our people are having to go to get a better rate. So this workforce issue is very serious, and it has created huge wait lists. And what happens in this budget, and we want the IDD people to get their wages, that's really important, but it is really a Sophie's choice, because you are going to hear from older Americans who need help. You are going to hear from mental health. You're going to hear from nursing homes. You're going to hear from childcare. And what happens is when you raise one rate for one group of people, the workers follow where the money goes. It's happened before. It will happen again. And then we have larger wait lists in another place. So we really have to look at this comprehensively, and we would appreciate that. And if you look at the interim rate study thing that they're doing, they said about community mental health, well, we're going to have to study it some more. I want to tell you that we cannot wait. We have so many vacancies in terms of our workforce, we cannot wait. I also want to talk for just a minute about the alternative response and the Families First program, which Representative Madigan brought up and Representative Craven. And while we are very excited about the Families First program, this transition from ARP to Families First is fraught with no transition plan. As Representative Madigan said, they're going from 30 current caseworkers to 15 in-house. The department didn't say that they have already 15 caseworker positions that are empty, that they currently cannot fill. So I don't know where we think we're going to get another 15. But once the staff members who are currently serving in the ARP, which again is to provide help for people who are in potentially abusive situations, the minute they hear the program is going to end, they are going to leave. And the department is not going to be ready to provide these other services until January of 2021, as we understand it. So that is a huge problem. At the same time, we have a wait list in home and community treatment, again, for families with children with behavioral needs who are keeping their children at home. The current wait list today is 483 families. 224 of those families have been waiting over 3 months, and 90 of those families have been waiting for over 180 days. And the transfer from ARP to Families First has resulted in a $600,000 savings, which is completely I don't understand how. And that $600,000 in this budget has been returned to the general fund. To me, when we have children and families waiting, when we have people waiting on wait lists, when we have workers that we cannot hire, to take this money from this program, from this department, the OCFS department, and to give it back to the general fund is very wrongheaded in our view. And we desperately need those funds to help families that are trying to make it and keep their kids in the least restrictive setting and the least expensive setting. And so we urge you to really look at this issue. We will work with you to try and come up with solutions. We are trying to do it every single day, but as it stands, this does not address the real issues in mental health. And we have heard for months that the most important.
Excuse me. Yep, your time is passed. So
behavioral health is an underlying for education, hospitals, jails, everywhere. So we need your help. Thank you.
Thank you very much. I appreciate it. Next, we're going to have, oh, sorry. Do you have anyone have any questions for Ms. Sweet? Before we, Representative Madigan.
Thank you, Senator Breen. Thank you for being here today, Betsy. Betsy, do you know where the ARP programs, what the areas they cover are?
Well, currently they're statewide, but they're operated out of Bangor, Lewiston, and Ellsworth.
Thank you.
But they cover statewide.
Right. I mean, so those 30 ARP workers do a lot of traveling.
They do a lot of traveling, yes. Yes. And some of them live in other parts of the state and are just managed by people in those areas.
Okay, thanks.
Also, Betsy, we heard from the department that they are trying to fill known gaps in the care continuum and that they're rolling out or starting up some intensive outpatient programs, which are really important between hospitalization and sort of outpatient, that in between. And I'm wondering if, how that's going and what you're hearing from providers and consumers around that addition to the service continuum.
Thank you, Senator Breen. It is a very important addition to the continuum. And here's the problem. We cannot hire workers to fill it. The same thing with the crisis center that they're funding. We don't have, it's not reimbursed at a rate that is adequate to attract workers into the system. And so we are continuing to have this problem. And unfortunately, people going into this field are recognizing it. We just heard that at the University of New England, between their bachelor's of social work and their master's of social work programs, less than 10% of those graduates plan to stay in Maine because they can get elsewhere. So we're going to have an even more severe worker shortage. And so no matter how great these programs are in their design, which we agree with and we want them to work, we're not going to be able to hire the people.
Okay, thank you. Any other questions for Ms. Sweet? All right, thank you so much.
Thank you very much for your time.
Yeah. Next we have Colin Ryan, and after that, Dr. Campbell. So let me move, I forgot, Colin, I've got to let you in. So here we go. You should be appearing magically. There he is.
Great.
Welcome.
Thank you. Thank you, Senator Breen and Representative Pierce, Senator Claxton, Representative Meyer, and members of the committee. I've been just awed by the time and energy you guys put into all of this, and it's a pleasure watching you guys think this through. My name is Colin Ryan. I'm a chair. I am a parent of a 24-year-old son with intellectual and developmental disabilities. I also chair the Maine Coalition for Housing and Quality Services. It's a grassroots effort that has some 4,000 mostly parents, but there's advocates, relatives, and other concerned folks, everyone really all around people with intellectual and developmental disabilities. I also serve as chair of the Maine Developmental Services Oversight and Advisory Board. Been on that since its inception. I'm testifying on behalf of the coalition for the parts of the budget that support addressing the wait lists, as talked about, and also for direct support professional rate increases. I can tell you as a parent, the biggest concern is what happens when I die. And we know that we're going to die before our children, but It's a really scary prospect to think about how this would work. And fortunately, as a society, we decided long ago that care for this population should be a state obligation. And so this budget contains really how that will happen. And I want to thank the department. DHHS has been working with us to improve and streamline services for the IDDD community, and listening to feedback and trying to make this work. And also the legislature has been working to fund these wait lists, and all of this effort is huge and should be applauded. But there's a lot more to go. There are hundreds of people on the Section 29 wait list. Alan described that, 1,800 people on the Section 21 wait list. And the additional funding is welcome, but we still are going to need to address this wait list. And these budget initiatives are crucial to making this happen, because then we can have essential support services so people can live full, happy, healthy lives within their communities. But agencies need to have staffing to do this, which is what Betsy Sweet just described. The current budget includes funding to increase the 21 and 29 rates for direct service providers. And that is good. But it will be, we're going to need a lot of work to address the shortage. DSPs, these are the people that work with my son and others. They're the very nexus of the system of care. And these folks need to be paid enough so that they can be hired and retained and really see themselves as professionals, because they're the ones that are going to carry the ball. We've learned that when we do all of this right and someone has the support and services they need, no more and no less, we see human beings launch and achieve their greatest potential. See people like my son shine, and we see them participate and make a meaningful difference in the community, making all of us better. And we know that doing what's right is optimal. And if it's optimal, the cost will be as least as it possibly can. When a person's successful in the community, when a parent is successful in a job, they need the least amount of support from DHHS. And when sons and daughters launch, their parents, who are often in the pinnacle of their careers, are able to work and contribute fully to the economy. Without support for their sons and daughters, parents are often forced to quit their jobs and careers and play the role of caregivers once again. Something that's not good for the parents, but really not good for the adult children, who revert to increased neediness and see their hard-earned independent skills really atrophy. And I've watched this during the pandemic. If we don't do it right, we'll see our sons and daughters languish and launch into crisis, and we'll see our loved ones lose skills they've worked hard to develop growing up with special education, where they learn exactly how to be part of a community with the right amount of support. We'll see them falter, and we will see them fail. And their small needs become very large needs, and we'll pay for that. So I believe that helping everyone reach their full potential is the way to go. I hope you'll invest in helping people with intellectual and developmental disabilities have access to and receive the services they need by supporting the aforementioned biennial budget initiatives. Thank you very much for the opportunity to comment.
Thank you, Mr. Ryan. It looks like we have a question from Representative Corey.
No, I just wanted to thank Mr. Ryan for being such a well-spoken advocate for his son.
Thank you very much.
Any other questions for Mr. Ryan while we have him? All right. Thank you very much.
Thank you very much.
Thanks for your patience this afternoon. Okay, so next we have Dr. John Campbell, and then Dylan McKenney, and then Heather Marden. Yes, so Dr. Campbell, let me move you over to the panelists. You should be popping in soon.
Madam Chair, I see him on the second page, but there we go.
Sorry, folks. Muted and camera off. You all can hear me?
Dr. Campbell used to live in my district, and then he ditched us and moved to Penobscot County. So it's nice to see you again.
Same here, Senator Breen. Thank you. Senator Breen, Representative Purse, Senator Claxton, Representative Meyer, and members of the Joint Standing Committees on Appropriations and Financial Affairs and Health and Human Services. My name's Dr. John Campbell, and I'm the Chief Medical Officer for Northern Light Acadia Hospital. I'm here today to speak in opposition to one item in the governor's biennial budget that proposes a significant main care payment reduction for our outpatient services provided by Acadia Hospital. For reference, the item that I'm speaking to is on page A266. The budget reduces Institute for Mental Disease outpatient reimbursement to 100% of costs. There are only two hospitals in Maine impacted by this cut. One is Acadia Hospital and the other is Spring Harbor Hospital. The budget estimates the impact to total $1 million, but the actual impact to Acadia Hospital is a main care cut of $1.9 million per year. Today, outpatient services represent about 31% of our total healthcare business at Acadia, and we provide over 120,000 outpatient encounters per year to approximately 12,200 patients. Our outpatient services are growing at alarming rates, and since the first quarter of 2020, we've experienced a 24% increase in pediatric med management and a 22% increase in adult psychotherapy and med management services. And further, we have over 2,000 adults and 500 children on our wait lists to access our outpatient services. The mental health delivery system in Maine is currently skewed towards overuse of emergency departments and inpatient care because of underinvestment in outpatient care due to low reimbursements. So citizens whose mental illness could otherwise be stabilized as outpatients and at a lower acuity instead deteriorate to high acuity and present to the emergency departments where they become stuck awaiting hospitalization. And this has disrupted emergency medical care statewide, and it's added avoidable costs. And these will only be exacerbated if there are further cuts for outpatient services at a time when the remedy calls for increased investment by all stakeholders, beginning with the state. Many years ago, the state of Maine recognized that many patients accessing Acadia Hospital outpatient services simply wouldn't have the financial means to pay their bill or their co-payments or their deductibles. And in previously developing a reimbursement rate for outpatient services, the state sized the payment to account for the higher levels of uncompensated care. And it was necessary then, it's even more necessary now to maintain the higher reimbursement rate, given the fact that we've experienced a 43% increase in uncompensated care from 2019 to 2020. You may ask why our uncompensated care increased at the same time Maine Care expanded. We're asking ourselves the same question. We're baffled, but we work very hard to help individuals obtain coverage. So I'd like to thank you for the opportunity to express our opposition to the budget proposal that impacts Acadia Hospital.
Thank you, Dr. Campbell. Any questions from the committee members for Dr. Campbell? I have one, Dr. Campbell. If you could estimate, if this cut happens or this reduction happens, what the potential cost would be, because acuity will go up, and is there any sort of formula or prediction you can make with any accuracy?
It's hard to predict with accuracy, but things are different since the pandemic. There's much more active mental illness, stress-related disorders, and people with chronic psychiatric conditions. They're just exacerbated by the sum total of all the stressors. So the system, which was already stretched and not working well, is now in a worse position. Many more people are stuck. And, it's hard to staff outpatient clinics. It's difficult and challenging work, as has been spoken of previously. So the system is under a lot of duress right now, and it's hard to quantify that on a dollar basis.
Okay, thank you.
You're welcome, Senator Breen.
Any questions for Dr. Campbell before we let him go? Okay.
Oh,
thank you.
Senator, I think I see Representative Hymanson and Senator Baldacci with their hands up.
Oh, thank you. Okay. I didn't catch that. Thank you, Madam Co-Chair. Let me go back. Oh, yes. several. Okay. I was on the wrong page. So Representative Hymanson, Senator Baldacci, and then Representative Javner.
Thank you. I wanted to try to get you to dig a little bit more on the uncompensated care and why that's still high. I know you said that there was no easy answer to that, but what do you think the answer to that is? Because we did work hard on that Medicaid expansion, and we're hoping that would take care of things, not increase it.
You did, and it's paradoxical, and we don't understand it. I can get that answer for you. I can speak with our finance team and try to get some more detail about it, but it's confusing.
Yeah. Well, if you have an understanding or something along the way, if you could get that to us, that would be great. Just so we understand who that population is. If you can't, that's okay too, but I'm curious.
Oh, I'll find something.
All right, thank you.
Hopefully it's helpful.
Okay, thanks.
Senator Baldacci.
Thank you, Madam Chair. Dr. Campbell, I want to, first of all, thank you for your leadership at Acadia. I had spoken previously with Lisa McPherson about this cut, and I wanted to know from you what this would involve in terms of layoffs. I'm assuming that staff would have to be laid off. And then the other issue is it might be helpful in terms of resources in Eastern Northern Maine. It might be helpful for the committee to know that Acadia is pretty much, with Dorothea Dix, all that there is for significant resources. But if you could let us know what kind of layoffs this might cause and how that's going to impact treatment, that might be helpful to us as well.
And we haven't quantified that yet because we're still, we've just recently received the numbers and calculated what the cut would be. But ambulatory care is largely subsidized by other psychiatric services. And as you know, it's very tight margins in mental health for all of the services. It would certainly limit our ability to grow necessary programs. It would, with probably wait lists expanding. And the chain reaction is that when there's not adequate access to ambulatory care, and I mean prompt and timely, people get sicker and go to the emergency department. And every person we see in the emergency department that we end up having to admit to one of the psychiatric units in the state will tell a story of deterioration happening over a period of weeks, and just an inability to do anything about it, to get into an appointment or to get a follow-up. So that's, it's upstream is where the problem is. It isn't that there's not enough inpatient beds in the state right now. It's that we can't we're very good at taking very unstable people and stabilizing them, but the system can't maintain the stabilization. And that's because that's where the outpatient care comes into it.
Thank you very much, Doctor. I appreciate your time.
You're very welcome.
Representative Javner.
Thank you, Madam Chair. Thank you, Dr. Campbell, for being with us this afternoon. And I appreciate greatly you bringing this to our attention. I think all of us through the pandemic have seen, especially an uptick in our young people, the stress that has been occurring across many different layers of our lives, and especially their lives. Do you have a specific percentage number or an aggregate number of an increase that Acadia has been seeing during this past year now?
Historically, if we look at the emergency department as the safety net and really as the tip of probably a larger iceberg, for years, emergency department psychiatric volumes remain stable because the population is essentially stable. And over the past year, we've had a 50% increase in our telepsychiatry services. We provide telepsychiatry to 17 emergency rooms located around the state. And never in my career have I seen really a change in what's otherwise a very stable stable utilization of the emergency department for psychiatry. So it's very dramatic what's happened in the past year. Normally, we'll have approximately 15 patients in our partner and member org emergency departments waiting for admission. We're now routinely over 30 and many times up to 40, which is astounding numbers.
Wow, 50% increase. And that's really, I mean, to be honest, right, there are probably many, many more out there that aren't even being captured.
The majority of people with mental illness don't receive a diagnosis and don't receive treatment. And the majority of those that do actually don't receive an evidence-based effective treatment.
Thank you very much.
You're welcome.
Okay, any more questions for Dr. Campbell? Okay, thank you very much for joining us today.
Thank you all for your leadership. Thank you, Senator Breen. Good to see you again.
Thank you, you too. So now we're gonna go to, let me check my list. Dylan McKenney, I'm gonna move, and then after Dylan McKenney, Heather Martin and Jeff Austin. Hang on, Dylan, I'm gonna move you over. Hopefully, oh, all right. There's Mr. McKenney.
Hi.
Thank you for joining us. Thanks for your patience.
Thank you. Senators Breen and Claxton, Representatives Pierce and Meyer, and members of the Appropriations and Health and Human Services Committees. My name is Dr. Dylan McKenney. I'm a child and adolescent psychiatrist at St. Mary's Regional Medical Center, and I'm here today to express opposition to one item in the biennial budget. So I'm representing St. Mary's, a nonprofit 233-bed community hospital in Lewiston. The hospital provides a variety of inpatient services, including inpatient psychiatric care. As medical director for the pediatric behavioral unit at St. Mary's, my staff and I treat about 500 to 600 children and teens per year in our program. Last year, we treated kids from 200 different municipalities. Over 60% of these kids are Medicare recipients. And virtually all of them were admitted from emergency departments located throughout the state. So we're a statewide public service. St. Mary's receives an enhanced rate for this service, a rate which has not changed since it was implemented. And it was implemented well before I started working at St. Mary's in 2014. So on page A266 is a proposal to cut our current reimbursement for inpatient psychiatric services by 30%. This cut would mean an estimated loss of about $1.5 million for my unit alone. And St. Mary's simply does not have the resources to absorb a cut like that. If this cut was to go through, St. Mary's would likely be forced to eliminate my program. I'm not sure how we could possibly manage to continue to provide the care that we do. And that means that the 500 to 600 kids we treat per year would need to find care somewhere else, or in many cases, simply go without. Last week, some of you heard testimony on LD 118 in an act directing DHS to gather information about the problem of children stuck in emergency departments awaiting care. And I've been listening in for a while now and heard some of the testimony pertaining to the wait for services throughout the system. If we lose psychiatric inpatient beds for children, we're going to see this problem exacerbated tremendously. And so this is a horror of, waiting in emergency departments for children and their families who are in crisis for the next level of care. And, waiting at sort of the hardest time in their lives to receive stabilization treatment. It's a horror that families have been going through for quite some time and would be worsened. It has gotten, at this point, really out of control. I think I've seen cases where kids are stuck in the emergency department in various places in the state for weeks at a time. And so, we simply can't sustain a loss throughout the system to these inpatient services. Anyway, looking at the problem of mental health treatment for children, suicide was on the rise among Maine kids before the pandemic. Now it's like nothing I ever imagined that I would see. But we are able in the hospital to stabilize kids and treat their depression, teach them to handle emotions in safe and healthy ways, and we have good outcomes. And I'm proud to say that actually in the 7 years that I've been providing these services at St. Mary's, I'm not aware of one patient who, after receiving our care, has gone on to end their life by suicide. So I think what I'm saying is that I can personally assure you that the money spent on this enhanced rate is well spent. I've attached a couple of profiles of patients that I'm currently treating, just to give you an example of what our typical patients are like. They're compelling stories. I'd be happy to share them with you personally if I have time, but please read them if you can. Hopefully you have a copy of that.
So, Dr. McKinney, I think our 3-minute timer has rung, and I really appreciate you being here. I can tell you, and a lot of people in the legislature already know this, but my family is one of those families that's had a kid waiting in the ER for an absurdly long and painful time. So I really appreciate you bringing those individual stories forth. I see Representative Hymanson has her hand up, and if there are any other folks, please do your electronic hand, and there's Representative Craven. So thank you, Dr. McKinney, for taking a few questions. Representative Hymanson.
Thank you, and thank you for being here. I'm curious about the outpatient fidelity-based programs that the Families First funding, federal funding is going to help us support, because we've really, and I've heard about them as a way to keep kids who are at risk for being taken out of their homes, but often with severe or some mental health diagnosis and a family that's not supportive or doesn't know how to be supportive. So those programs, what do you see? What's your feeling about them? If the hope is if we support those because they're expensive and need a staff behind them and need to maintain the fidelity of the program, that kids won't have to be admitted to an acute care facility. What do you think?
Well, honestly, I'm not prepared to comment on those programs. I think that there are lots of issues. I've been listening into this discussion long enough to, hear the complexity of what, the various problems that you all have been discussing. I think there are certainly some important workforce issues that need to be addressed. That's really throughout the system. And implementing a program like this, those issues are key. I think there's a lot of excitement among my colleagues and in our professional organization in the state about Families First and about what programmatic changes that will bring. But I want to just point out that, you know, the one line item that I discussed is an enhanced rate for DRG payment to psychiatric units. And it affects primarily just my unit here at St. Mary's and the inpatient unit at Northern Maine Medical Center that treat children. So, you know, those two units are the only ones that would be affected by that one item.
Thanks for bringing us back to your message. That's all.
Representative Craven?
Thank you, Madam Chair. Thank you, Dr. McKinney. St. Mary's is located in my district, and so I'm well aware of the great work that you do over there. And certainly, it would be a great loss to the entire state of Maine if it was lost. And so I just wanted to thank you for coming and presenting to us.
My pleasure. Thank you.
Representative Madigan.
Thank you, Senator Breen. Thank you for being here, Dr. McKinney. I have a couple questions. One is, your unit is an inpatient unit?
Yes.
Okay, so you and the inpatient unit at Northern Maine would increased services, increased programs like those approved by the Families First federal legislation that we hope to bring more of here. Would that lead to discharges happening faster? You know, you wouldn't have to wait to refer. I'm just looking for kind of, I know you're concerned about the rate you get, but certainly the availability of community services would help your unit enormously.
Yes, and that's an excellent point. I think the point here is that when we talk about the mental health system, we have to recognize that all parts are connected. And so when we decompress need in one segment of the system, we see effects throughout the system. Yeah, absolutely. And frankly, you know, we would be seeing lower numbers in inpatient units for admissions, especially I think for young children, with some of those home and community-based services being more robust and more targeted in terms of what actual treatments they deliver to families. Yeah, thank you. That's a great point.
Thank you.
I have one last question, Dr. McKinney. And you might not know the answer to this because obviously you have a very focused program and section of the budget. But are there initiatives in the budget that you think will reduce acuity for children and will produce a corresponding decrease in demand in your services that are for higher acuity kids? Is there something going on in the budget proposal that would address the upstream services?
Again, I think one of the most important things we can do for the long-term mental health of children in Maine is to really invest in longitudinal programs like, you know, wraparound services and other kinds of support. You know, my population is younger, so there's some discussion about Section 29 services. The kids that I work with are receiving Section 28 services frequently, and you know, the availability of those services is low. Section 65 services we rely on very heavily when it comes to hospital discharge and prevention of rehospitalization. And so, you know, oftentimes discharges from psychiatric units are held up by implementation of those home-based services. More often those services are simply not available. That, you know, I don't know how familiar the committees are with what those services entail, but there are a variety of actual programs that families can receive at home to stabilize problematic behaviors or to stabilize an acute mental illness. I think outcomes are generally better when children are stabilized at home versus in residential treatment programs. Psychiatric hospitalization, the service that we provide at St. Mary's, is acute care and short-term care. But it is an important piece of the overall picture. And I've tried to illustrate that in some of those case examples about how a child can really be in a bad overall state in their life, in the custody of child welfare because of a parent's addiction problem, and then in a period of extended destabilization because of the loss of their parent to this illness, and then relying on various parts of the systems to try to stabilize. So I think I think all of these measures that target supporting families and being healthier or functioning better to raise their children over the long haul, improve the mental health of our population, and especially those at highest risk of mental illness.
Okay, thank you.
Yeah, thank you.
All right, thank you for coming, and thank you for your patience. And we're going to move on now to Heather Martin, and then Jeff Austin, and Katie Fulham Harris. So I will move Heather Martin over. And I see her name, and there she is.
Oh, good afternoon, Senator Breen and Senator Claxton and Representatives Pierce, Peirce, and Meyer, members of the Appropriation and Financial Affairs and Health and Human Services Committee. And I want to say hello to Representative Fay. I'm from Raymond, so you're my representative. Good to see you. My name is Heather Martin, and I'm representing the Maine Association for the Education of Young Children. We call ourselves Maine AYC for short. We promote high-quality early learning for all children birth through 8 by connecting practice, policy, and research. We advance a diverse, dynamic early childhood profession and support all who care for, educate, and work on behalf of young children and families. We're testifying neither for nor against the governor's budget, but we appreciate the leadership in submitting a budget that does not make major changes during these difficult times, specifically around the areas of funding for Head Start, child care services, early childhood consultation programming, and the Office of Child and Family Services. Across Maine, these services and programs have been a vital resource for children and families prior to the pandemic and exacerbated by the pandemic. These services support some of our state's most under-resourced children and strengthen their early development opportunities. Research does show us that 90% of a child's brain is typically developed by the age of 5. However, our most significant investments tend to come when they enter public school. Research also demonstrates that early learning experiences are a major contributor to future outcomes for children. At the onset of the pandemic, childcare programs across the state were deemed essential, and programs quickly made decisions about their capacity to be able to support children for fields that carried out essential functions of our communities. Yet some of these programs were not able to bear the burden of the financial losses they took and permanently closed. Yet some programs are still struggling in their day-to-day operations to stay afloat. As a state moving forward, I hope we can all take a real hard look at our systems of childcare as the vital functions of our economy that they have proved to be. No childcare provider should have been faced with the everyday decision of whether their program could continue to keep their doors open. When childcare is not available, it hurts children, families, and our economy. Economists project that for every dollar we invest in strengthening early learning opportunities, we can see a return on our investment anywhere between $7 and $12. We do look forward to a continued commitment to invest in our youngest children in Maine, and we support more significant funding for early learning programs and future state investment opportunities. We must invest in the long-term health, economic health in Maine, and starting with our youngest citizens is a way to capitalize on that investment. Thank you all for hearing me today, and if you have any questions.
Thank you, Ms. Martin. We appreciate your patience and your testimony. Any questions for Ms. Martin?
Okay, I don't
Thank you.
see any. Let me just make sure I'm doing this. Okay, I'm getting a thumbs up from my co-chair, so. All
Thank
right,
you.
thank you very much. We're going to move on now to Jeff Austin, and then Katie Fulham Harris, and then Maggie Hoffman. So let me move Mr. Austin over to the panel.
Good
Hi
evening.
there.
Can you hear me?
We can. Thank you for your patience.
Senators Breen and Claxton, Representatives Pierce and Meyer. My name is Jeff Austin. I'm here on behalf of the Maine Hospital Association to speak in opposition to two items. I thought that I might be going before my hospital colleagues and I would introduce the topics to you, but each topic has already been introduced by Drs. Campbell and McKinney. I will skip my opening statement, which you've actually heard twice this year, and my summary of financial losses by hospitals, which you have heard twice this year, and move right to the cuts and provide just a little bit of context. So the two cuts are each on page A266. The first cut to the IMDs is the second initiative on 266. And the cuts to the community hospitals that Dr. McKinney talked about is the last initiative on 266. So there are two state psychiatric hospitals, Riverview and Dorothea Dix. There are two private psychiatric hospitals, Spring Harbor in Westbrook and Acadia in Bangor. The first cut impacts those two private psychiatric hospitals and their outpatient services. And you heard from Dr. Campbell about that. And I believe my colleague Katie coming after me will speak to this impact on Spring Harbor. The bulk of the impact is on Acadia, but Spring Harbor is also affected. The second cut are to two psychiatric units in community hospitals. So there are 33 sort of regular hospitals where we all go. 7 of those hospitals in Maine are licensed dually to provide inpatient psychiatric services. So this service is not available in every hospital. There are only 7 in Maine where it is provided. You've already heard from St. Mary's, which is one of those hospitals, and I believe you will also be hearing from Northern Maine. St. Mary's and Northern Maine get an enhanced rate. There's a flat rate for everybody else that's in the Maine Care Manual. Those two hospitals have received enhanced rates. Those two units, though, St. Mary's and Northern Maine, are the only two community hospitals with inpatient psychiatric units that treat children. Spring Harbor and Acadia, the two IMDs, also provide the service, but of the 7 community hospitals, these are the only 2 that treat children. The impact of the cuts directly is concentrated on 4 hospitals from these 2 cuts. But as I think you are all aware, the need for these services is statewide. And so this impacts all of your constituencies and all of your communities. Patients with mental health needs, particularly adolescent children, can get stuck in a hospital anywhere in Maine. The relief valve sometimes, frequently, is Northern Maine or St. Mary's or the 2 IMDs. So while the cuts are concentrated on the bottom lines for 4 hospitals, the impact of the cuts on the real world will be felt across this state. You're hearing a lot of need from a lot of very worthy providers in the community. We support community providers. We would love to see spending on inpatient psychiatric services go down as a result of better community services and the ability to keep people out of the hospital.
Mr. Austin, you're at your time, so if you might want to summarize. Thank you.
Our one request, as you listen to all these worthy folks, is to remember maybe the Hippocratic Oath, which doesn't apply to you, but we would encourage you to consider it, which is first do no harm. We're not asking for more money. We're simply asking not to be cut. And we would appreciate your consideration. I'd be happy to take any questions.
Thank you, Mr. Austin. Representative Hymanson has a question.
Yeah, can you go over, maybe this was held and it went over my head. why was the enhanced rate started and when did it start?
The St. Mary's rate that Dr. McKinney spoke to, I believe was in about 10 years ago. And your former colleague, Representative Rotundo, ushered it through, I think, while she was chairman of the committee. The Northern Maine story, I will let Northern Maine tell that story. It's a bit of a longer, tortured story that Representative Martin, I believe, knows very well. And so they can, the CEO of Northern Maine is going to testify, and he will take you through the course of that enhanced rate.
Okay. Okay. So the 10 years ago one, why was that put in? You know,
Well, so there's a flat rate per discharge. It hasn't changed. My understanding is all of the hospitals that provide the service that don't get the enhanced rate lose money. So there are 5 community hospitals with inpatient psych units. It's very disproportionate Medicaid. In normal hospital world, Medicaid is around 15 to 20% of your workload, and therefore 15 to 20% of your revenue. In the psychiatric world, Medicaid is a much bigger percentage of your pay. It's 50, 60, 70%. And so those units, 4 of them are in Maine Health, and Katie can speak to how the 4 hospitals that she represents survive. The 5th is Maine General. And I spoke to Maine General prior to this hearing about how do you make a go of it without an enhanced rate for your psychiatric unit? And he said they don't. They hemorrhage money, but they take savings, those pockets of profit in other services, and use it to keep this unit going because it's a community service and part of their nonprofit mission. But it's a money loser at the base rate. And I believe Katie could explain a similar impact on the 4 hospitals in her system. And so if I could really violate a rule and talk about an issue from yesterday, 340B is a little pocket of money. It's the kind of thing that gets used to make sure these kind of units can stay afloat. So this is kind of a double whammy, you know, to both cut and then say, oh yeah, that one program where you do okay on, we're going to pop that too. And so Katie can expand more, and Peter Soroy from Northern Maine will explain the history of their enhanced rate. And John Martin can explain it to you if he misses something.
Thank you. Mr. Austin, I'm going to ask you a more global question about mental health reimbursement rates and insurance coverage and the like. For many, many years, you know, people maxed out on what their insurance providers would cover for mental health treatment. And then we've had mental health parity, you know, first in Maine was a leader, and now we have it nationally. Has that made a difference in terms of covering, you know, systemically in terms of how mental health care gets covered and paid for?
It's beyond my capability to answer that, but I would answer it this way. I believe it has helped greatly, but there was another current going on in the commercial insurance market at the same time that parity was introduced, and that's high deductibility. So the out-of-pocket costs that were imposed on the commercially insured went up greatly. So it looked good on paper, but in reality, it was just knocking down a deductible. And if you have a $5,000 deductible, an average family dealing with mental illness, it's going to be hard to find the money if you're paying out of pocket. So that undercurrent that was across the entire insurance market was happening at the same time that parity was going on. So I think it undercut it a little bit.
Okay, thank you. Any other questions for Mr. Austin? All right, thank you very much.
Thank you.
Next, we're going to hear from Katie Fulham Harris, then Maggie Hoffman, and then Mallory Shaughnessy. So hang on, Ms. Fulham Harris, I will move you over to panelist.
Hello, are you able to see me today? I understand that you were not able to see me
We
yesterday,
can
which
hear
is,
you, but we can't see you.
you can't see me, and I am,
I'm going to ask you to start your video. I just did
there we
that.
go. Got it. Okay.
Yes.
I apologize. So,
Good
so thank you, Senator Breen, Senator Claxton, Representative Meyer, and Representative Peirce. I'm Katie Fulham Harris from Maine Health. And I really appreciate the opportunity to speak today. You have heard from a number of individuals, clinicians were fantastic. So I'm really going to focus on a few key points from Maine Health's perspective. As part of our vision of working together so our communities are the healthiest in America, Maine Health provides a wide range of behavioral health services throughout our entire footprint. And these range from inpatient hospital-based services that you just heard about to community-based ambulatory services and integrated behavioral health clinicians in all of our primary care practices. And I've provided several pages of written testimony. I'm not going to go through all of those, but the pieces I would like to focus on are really related to, first, the challenge in this budget related to a lack of enhancement for the community-based services that exist. You've heard bits and pieces of that today, and I guess the piece I'd like to note is that while we recognize that the state is facing a significant challenge with the budget, and we also recognize the department's effort to create a more rational framework for Maine Care rates, by its own admission, the Maine Care rate review will not be implemented, or new rates will not be implemented for at least 2 more years. So at that point, it's going to have been 13 years since many of the behavioral health rates were increased. And I actually looked up the CPI last night, and it's increased by 20% over a 10-year period. So there's just no way that these rates are sustainable. And given the number of services that have recently closed, we're really foreseeing even greater problems in the future. You've heard from previous speakers, including Mr. Austin, about the 2 specific reductions that I am here to testify in opposition to. The reduction to our IMDs that you heard from Dr. Campbell actually impacts our state-of-the-art Center for Autism Services at Spring Harbor Hospital. And these are services that are not otherwise available in Maine for kids who have severe autism. And we've actually invested as a system a great deal in expanding the capacity of that program to meet the needs of children and families, and to have this rate being challenged is really problematic for us. The second cut that you just heard about related to the enhanced inpatient beds. There is a high demand for inpatient care right now, in part because of the failure to support the community system, but we're providing inpatient behavioral health care and we lose money on those services. And in fact, we recently opened a state-of-the-art 2 units in Sanford in the old Goodall Hospital. We repurposed those units, and we are losing money on each Maine Care client from the start. We had legislation before you last session. It was sitting on the table when you adjourned. We have another bill in this session. We have agreement from the department that those services are underfunded, but we're really challenged right now.
Ms. Harris,
yes.
Time is over, so if you might summarize.
Yeah, I will. I guess the piece I'd like to I want to, on a positive note, I'd like to thank the department for recognizing community-based intensive outpatient services. That is incredibly important, and we appreciate that. And I also just want to note that the department, through contracts and now through these 2 cuts, is trying to standardize rates for certain specialized services that really require enhanced rates. They can't just be funded through Medicaid and by Medicaid rates. And we're seeing this as a policy issue that the department is promoting, and we have significant concerns with it. So with that, I will wrap up and thank you and be happy to try to answer any questions.
Thank you very much, Ms. Fulham Harris. Any questions for Ms. Fulham Harris on her testimony? Not seeing any.
Okay. All right.
Thank you very
Thank you.
much for your patience.
Thank you.
Okay, next we have Maggie Hoffman, then Mallory Shaughnessy, then Pamela Day. So let me move Ms. Hoffman over. There she is. Thank you for your patience and thank you for joining us.
Thank you so much. I am testifying neither for nor against the initiative on page A229 of LD 221. And I want to thank the chairs and distinguished members of both HHS and the appropriations committees to give me the opportunity to talk today. My son, Jake, has lived with developmental, medical, and mental health disabilities since his premature birth 33 years ago. Last year, I shared part of my family's story with some of you to explain how devastating it has been to have my son eligible for home and community-based services, yet be languishing on the wait list. Since that time, Jake received an offer for Section 29 services. It was difficult to find a provider agency willing to commit to serving my son's needs, as staff recruitment was extraordinarily challenging pre-COVID. Within 3 months of receiving Section 29 funding, the pandemic shut down our ability to recruit staff or have staff in our home in a consistently safe way. So I became his only caregiver, or actually continued being his only caregiver. This year, a majority of Mainers began to experience the life my family has been living for more than 3 decades. With schools closed and a dearth of childcare options and remote learning necessitating parental oversight, Mainers were unable to get to work even virtually. The sting of losing income has been terrifying. The separation of nuclear families from potential grandparent assistance caused by fears of spreading life-threatening illness has produced the same result many families of children and adult children with developmental disabilities always experience: the inability to receive any relief or respite. That has been our family's experience over the 2.5 years that we've been Mainers. Let me tell you about how my son has been experiencing the isolation brought on by first the wait list and then the inability to attract staff because of low wages and not enough supervision. Jake's isolation has produced both significant regression in his skills, including self-care and communication. He has drifted into a serious depression and has fallen into a perseverative negative feedback loop. That means he keeps talking about deeply distressing experiences from his earlier years, unable to let those memories go or create mental space for anything positive. Jake does not see a future for himself. Many of us are less hopeful this year, but have the ability to reach out through smartphones and Zoom social opportunities. Jake and many young adults like him are unable to make those connections and suffer at a higher rate than their neurotypical neighbors. I urge you to eliminate the Section 29 waitlist immediately, and please consider increasing the reimbursement rate for provider agencies and the hourly wages paid to direct support workers. Maine needs to invest in what I call the care economy, as caring for people with intellectual and developmental disabilities should be valued as the essential work that it is. Thank you for the work that you do, and thank you for this opportunity to speak with you today.
Thank you very much, Ms. Hoffman. We appreciate you making yourself available and certainly with the challenges that you have and for your patience. Any questions for Ms. Hoffman from any committee members? Not seeing any. So thank you again for joining us. I'm now going to move on to Mallory Shaughnessy, then Pamela Day, and we have about four more people after Pamela Day. So I'm going to move Mallory over to the panelists section. And then after Pamela, we have Peter Siros, Shadia, the rest of the name is cut off, I apologize, Sean Yardley, and Steve Wade. So Mallory.
Hello, good afternoon, late afternoon now. Senators Breen and Claxton, Representatives Peirce and Meyer, and members of the Joint Standing Committees. My name is Mallory Shaughnessy, and I serve as the Executive Director for the Alliance for Addiction and Mental Health Services. Thank you very much for the opportunity to testify today in support of some initiatives in the governor's proposed budget and to share some concerns about things that are missing. And thank you for working a very long day. The Alliance is the statewide association representing the majority of Maine's community-based mental health and substance use treatment provider agencies, otherwise known as the Behavioral Health Safety Net. And I'm very thankful that others from many other parts of our continuum of care have already pointed out to you the need to invest in these services and in this safety net. We do all work together, and we know how these pieces all fit together. All of these services that my members provide are designed to keep our communities safe and ensure that adults and children and their families are getting the appropriate services in the community and are not escalating into crisis or into our emergency departments or into involvement with our corrections systems or finding themselves unhoused. All of our communities are safer and better served by assuring that some of our most vulnerable community members are able to live and thrive in their communities. We support the proposed budget initiatives with curtailments that do not cut direct services. We also make note that the budget does add resources for some new initiatives to fill gaps that have been identified in the system. We applaud this intent to build out our system of care. We need these services in our continuum. However, as you've heard from others, this budget does not add resources to our current workforce and community programs that eliminate the wait lists and wait times for some of our most basic behavioral health services that are at risk of further reduction or closure. We've seen many closures over the last year or two. And we need more resources to better adhere to the evidence-based service models. We have serious concerns that what we're building on is a system that doesn't have a stable foundation. I think somebody else referenced that earlier. Without more investment in this frontline direct care workers and foundational services, we fear that these additional services may falter as well. When the pandemic first hit, as you've heard, there were some short-term rate increases to cover hazard pay, increased costs, et cetera, April, May, and June of 2020. And yet here we are in February of 2021, and the pandemic continues. Workers are in most cases still getting hazard or heroes pay. There are continuing costs for supplies, cleaning, quarantining, and overtime. As you've been hearing, the pandemic is increasing anxiety and depression. Alcohol, substance use are on the rise. Overdose numbers are up again, unfortunately, and suicides are increasing. We are seeing increased referrals, and our actual wait lists are growing and growing. Referral times are going farther and farther out to get an appointment. And yet still no additional rate enhancements, no additional investments in the system to get the staff to do this work. If you have the outbreak, you can actually get the enhancement short term, but it's sort of like letting closing the barn door when the horse is already gone. Some assistance has come from the federal government, but not all agencies were eligible. Some assistance was offered by the state. Not all agencies were eligible. There's a mix of services that people provide. Some services have been able to sustain others. As you were hearing from Jeff Austin, there's some balance that happens, but many times it doesn't happen, and they're left through the big holes. There were federal loans through the PPP, which you've all been hearing about, but to the nonprofits, some of them are now being required to pay hundreds of thousands of dollars back to the state in their audits because they're only looking at the one quarter and not the sustained costs throughout the year. This is going to have severe impacts. There are several legislative initiatives this session before you to invest now in our behavioral health direct care workforce and in these foundational services. We are asking you to please review these carefully. Please support shoring up these foundations of our safety net. We're also asking for support of the temporary rate increases in the supplemental budget that have been included in amendments from the HHS committee.
Ms. Shaughnessy,
yes.
Your time is over, so if you might summarize.
I'm done. The pandemic isn't over. The safety net needs help. I'd be happy to supply more, more details or additional information. And I thank you for your time and consideration.
Thank you, Ms. Shaughnessy. We appreciate it. If you could get us, if it's easy for you, the number of your members who received some sort of financial help, federal help, or state, as a percentage of, of your member organizations, that would be helpful. And it looks like Senator Claxton has a question.
And before we go there, just to let you know, I can get you the percentages, but do you also want how much help they got and how much percentage of the losses they have that help? Because that's been
No,
a
you
big
don't
part
have
of
to
it.
be that detailed.
Okay, great.
Thank you. Senator Claxton.
I thought it'd be good to have a list of the places that have closed, had to contract in the current circumstances.
Okay.
Thank you.
Any other questions for Ms. Shaughnessy? Okay.
Thank you all.
Thank you, and thank you for hanging in there. So next, we have Pamela Day, then Peter Siros, and then Shadia Abdullahi, and then Sean Yardley, and then Steve Wade. So I'm going to have Pamela Day move into the panelist position.
Okay.
There she is.
Here I am. Thank you. Thanks for having me. My name is Pamela Day. I chair the board of the Maine Children's Alliance, a statewide advocacy and research organization. We are concerned with the welfare of children and families in Maine. I'm here in particular to talk about the some issues related to the Office of Children and Family Services budget. We are pleased to see how much has been done over the last 2 years to improve the office, improve child welfare response to families. It's been excellent. We are concerned, however, about a couple of issues that we wanted to bring to your attention. In regard to the Families First Preventive Services Act, we think there's been really good work done, but in the proposed plan, as we've been able to review the slides, we do not see a clear connection between the services that will be offered through Families First and more preventive services. And in particular, we call your attention to the fact that Families First funding, as you may know, is limited only to those families when those children who have been substantiated for abuse and neglect. Many of the services that we think are needed and are currently offered in the state also are made available to families before they reach the door of Child Protective Services. We're concerned, that brings me to the concern we have about the elimination of the Alternative Response Program. We see this as an unnecessary shift from the community to the Public Child Welfare Agency. I worked in child welfare nationally, and I'm very familiar with alternative response as a concept and a program, and it was never intended to only respond to children who were abused and neglected. In fact, the intent is to be available to families before the stigma of child protection comes into play. So this poses the question for us: what is the state's vision of prevention and early intervention? We think it's that the Public Child Welfare Agency plays a strong and important leadership role. They may not fund all those services, but that they need to create and operationalize a vision of preventive services as well as services responding to families who are further down the line. In particular, we urge the committee, let me get to that, to build on the Families First planning effort, to develop a vision for prevention and intervention services, including those services for families where substantiation has not yet occurred, that the committee reconsider efforts to pull funds from alternative response programs before before OCFS does a gap analysis, which they indicated in their plan they will be doing but have not yet done. Reject the proposal to divert $600,000 from the child welfare system back to the state in the form of savings. That those dollars could and should be used during this time of huge impact on families with children. Those dollars could be reallocated to bolstering CPS, ensuring that workers are well-trained and supported and supervised, as well as ensuring that there are manageable caseloads, which to our mind is still a question. We know this is tough work for the department, the Office of Children and Family Services. We laud their efforts, but we're not done yet, and we don't support the bifurcation of intervention and prevention. Prevention needs to be part of the picture.
Ms. Day, your time is up if you want to summarize.
So thank you for your time and consideration. I'm happy to answer questions.
Thank you very much, Ms. Day. Appreciate you being here and appreciate your patience. Any questions from the committees for Ms. Day? Not seeing any. Okay, thank you so much.
You're welcome.
And I just wanted to announce I made a brief error. We have one more person, Laura Cortez from Maxby is on the list. So after we have Peter Siros, Shadia Abdullah Hai, and then Sean Yardley, Steve Wade, and then Laura Cortez. And I am going to have to sign off because I have a 5 o'clock commitment that I cannot change. Representative Peirce is going to take over, and Senator Bailey is standing by to help you with the clock as people are speaking. Senator Bailey will help you with the timer and managing that.
Thank you, Senator Bailey. I just moved over Paul, can't remember who, Paul
Sirois, we'll see.
We'll see. Let's see where he pops up. Yay. My apologies for butchering your last name.
No problem. Good afternoon. Senators Breen and Claxton, Representatives Peirce and Meyer, and members of the Appropriations and Health and Human Services Committees. My name is Peter Sirois, and I am the CEO of Northern Maine Medical Center. I'm here today to express our opposition to one item in the biennial budget. Northern Maine Medical Center is a nonprofit community hospital in Fort Kent. For those of you who don't know, Fort Kent is on the northern tip of Maine, directly on the Canadian border. One of the services we offer is inpatient psychiatric care. Northern Maine Medical Center is only one of 7 community hospitals in Maine to offer inpatient psychiatric services. Along with St. Mary's, we are one of only 2 community hospitals to offer inpatient psychiatric care for kids. This is a very rare and valuable service. This unit treats roughly 230 people per year. 130 of them are adults and 100 of whom are kids. Northern Maine Medical Center gets an enhanced rate for the service. This rate has not changed in over a decade. The Northern Maine Medical Center psychiatric unit is the only unit north of Bangor, which is 3.5 hours away from Fort Kent and an hour away from Holton. Of the people we serve, 48% are from the Aroostook County. The rest are from elsewhere in Maine. Even though we are far away from the rest of Maine, the service is so desperately needed that we still get patients, particularly kids, from all over Maine. On page A266, there is a proposal to cut our current reimbursement rate for inpatient psychiatric services of over 50%. This cut would be a loss of $2.3 million per year for this service at Northern Maine Medical Center. If this cut were to go through, Northern Maine Medical Center would be forced to eliminate the program. Eliminating the program will not be good for the mental health shortage in the state and especially Aroostook County. The history of Northern Maine Medical Center's enhanced rate goes back to the mid-1980s. It predates my time as CEO. However, I believe Representative Martin was involved in each step along the way and can correct my mistakes if I make any. While the unit has a long history, there are two primary parts to that matter today. First, the state was experiencing significant pressure to find inpatient capacity in Northern Maine in the mid-80s. Other hospitals, for whatever reason, were not in a position to offer this service. So Northern Maine Medical Center, Representative Martin, DHHS, and others worked on a solution. Part of that solution involved providing Northern Maine Medical Center with an enhanced rate in order to expand our services, and we accepted the deal. The second part involves children. There used to be services for kids in Fort Fairfield. When the provider of those services closed in the late 90s, again, the state went looking for assistance in providing service in Northern Maine. As we were the only psychiatric unit in Northern Maine, it made sense for the state to work with us. Again, we negotiated an enhanced rate with the state and we accepted the deal. With that history, I think you can understand our frustration. Twice the state asked for help.
Mr. Ciro, if you could wrap up, please.
Sure. So twice we tried to help the state and twice we accepted a deal. At this point, lose $2.3 million for a small rural hospital in Northern Maine, it will not be sustainable. So with that, I'll take any questions.
Thank you, Mr. Ciro. Are there any questions by the committees? I don't see any. Thank you so much for your testimony, sharing the story of the rural hospital, and being patient while we got through our big list of people today. Appreciate it.
Thank you very much.
Thank you. Next up is Shandia, I believe, and I'll wait for you to share how you pronounce your last name.
Hi, everyone. So I do have my camera off just because I'm in class. I do see a familiar face. Hi, Kristen. So yeah. Hello,
welcome.
My name is Shadia Abdullahi, and I'm currently a direct support professional at John F. Murphy Homes in Auburn. So I'm really happy that you guys get to hear from a DSP. Outside of working for John F. Murphy Homes, I'm a full-time college student at Emmanuel College, and I do work in the community with vulnerable populations along with the New Manor community. Working at this job has been a wonderful experience that I'm so fortunate to have, and I get to work with fantastic people supported and know that I'm making their lives brighter and more independent every single day. As it's been brought up in this meeting and it's been brought up in the past, DSPs and IDD service workers across the state have been and are still currently being paid insufficient wages for the level of work that we're often required to do. We aren't simply assisting them in their daily lives, we're doing hospice care, CNA care, COVID and pandemic care, nursing and behavioral issue care. Being paid minimum wage for this is simply unfair, and it sends the message out that the state does not value our work and efforts in making the lives of one of the most vulnerable communities better. As a DSP, I'm providing this testimony to urge the AFA to support adequate and sufficient funding for disability services in the state of Maine. During this incredibly difficult time in health climate with the presence of the pandemic, many DSPs and IDD workers like myself were and are being paid minimum wage, and we are not given hazard pay. I'm so fortunate to be here providing testimony today because oftentimes we tend to think that issues are out of our reach or hands, and I got the opportunity to be the voice of many other people like myself. DSPs are the frontline workers that you hear about every single day in the news, that have to work 80 to 90 hours a week, that have to work 24 to 36 hour shifts, that have to be exposed to COVID and still have to come to work, coming into taking care of our residents in inches of snow and coming in with several medical emergencies. This is my call to action to the AFA. This is every single DSP and IDD service worker in the state of Maine's call to action upon the AFA to pass LD 221 in providing adequate and sufficient pay for service workers such as myself across the state of Maine. And along that would go along with the retention of the day program pay. Thank you all for listening, and I hope that my testimony is of value to you.
Thank you so much, Shadia. Are there any questions that any of the committee have? We appreciate you sharing not only your personal story, but more the global perspective as well.
Thank you.
I don't see anyone with their hand up. So thank you so much for being here today. We appreciate you sticking with us and sharing your testimony.
Of course, no problem. Thank you all as well.
Good luck in class.
Thank you.
Brave new world. So our next speaker will be Sean Hardley. And then we'll have Steve Wade and Laura Cortez. Mr. Hardley, welcome.
Yardley, please.
Yardley, excuse me.
That's quite all right. Senator Breen, Representative Pierce, and members of Appropriations, Senator Claxton, Representative Meyer, and members of Health and Human Services. My name is Sean Yardley, and I come before you today to urge you to restore the funding proposed cut to Alternative Response Program. I have a unique perspective. I've been working in the child welfare system for over 40 years, 17 years at DHS when it was called that, 2 years as a child protective worker, 8 years as a supervisor, and 7 years as the regional administrator in the Down East area, Penobscot County, and to the coast. I served 20 years on the board of the Maine Children's Alliance and taught for 26 years child welfare at the University of Maine School of Social Work. And I was with the department when the Alternative Response Program was developed. So I have a unique perspective. And now I am the CEO of Community Concepts, which is one of the 3 alternative response programs in the state of Maine. Beyond that, my recommendation comes from being a person with real life experience. My wife and I are the parents of 7 children, 3 of them who came to us from the foster care system. So I see every day the impact of the child welfare system in a very, very personal way. I'm proud to say they're all adults now, and my oldest adopted child just got her MSW in December. The Alternative Response Program, as I mentioned, was something that I experienced on the other side. In the mid-90s, it was created to address the significant child welfare referrals that were going unseen by the department due to insufficient staff. There was not an appetite to increase the size of the state workforce at the time politically, and so a decision was made to privatize the lower risk cases. At the time, we were having over 2,000 cases a year going unseen. And so we fast forward to now, and the proposal that is before you is to replace 30 private child welfare workers with 15 public child welfare workers, and to return $600,000 to the general fund. The idea to reduce the investment in children at this point in time. There's been no more of a critical time for families with the stress of COVID, remoteness, economic impact, all of those things. It just doesn't make sense and doesn't add up. We have over 1,000 cases that we currently serve in the Alternative Response Program across the state. And the idea of hiring 15 workers that wouldn't be able to come on until early next year because the positions have to be funded, then they can post them, they can hire, they can train. And so there's no plan for transition. And we've had several meetings with the department to talk about what the transition plan is. We've lost 3 of our staff that we likely won't be able to replace, because who's going to come to work for a program that is going to be ending in 9 months? It really is unfortunate. I think the department is trying to do something that's really appropriate, but there is no transition plan. I was against alternative response.
Mr. Yardley, if you could wrap up, please. Thank you.
Yes, I was against it at the time because I truly believe that should be integrated. But there has to be a plan to get back to that, because if not, there are going to be many, many cases that will go unseen, and children deserve better. Thank you.
Thank you so much for your testimony. Are there any questions by the committee? Seeing none, we certainly appreciate your patience and sharing all of the concerns that you have with aspects of the biennial budget. Thank you for being here, Mr. Yardley.
Thank you very much.
Have a good evening.
You too.
Next, I'd like to invite Steve Wade to join us. Should be coming over. Welcome. I see you're there. You're still muted, however.
Well, thank you very much, Representative Pierce and members of the committee. I'm Steve Wade. I'm the Executive Director of the Brain Injury Association here in Maine. It's a chapter of the Brain Injury Association of America. And we represent we're a Maine-based charity representing about 2,000 survivors of brain injury and family caregivers. So I'm just here to speak in support of the governor's budget in terms of all the different items that were mentioned for serving folks with brain injury. Again, we're in support of those things. I know earlier in the conversation today, the issue of the waiting list came up, specifically the brain injury waiting list for the brain injury waiver. It is much smaller than the other waiting lists. Last I heard it was around 90 individuals, and so much of that is affected because of the difficulty for providers to hire staff. I think that's an issue I think you're all well familiar with. It's certainly a challenging one. One of the things that the brain injury community is seeing that we anticipate more folks in the future needing services as a result of the overdose crisis. There's a strong intersection between surviving an overdose with anoxic or hypoxic brain injury as a result, and very much affects folks in treatment, particularly since the frontal lobes are most affected by the lack of oxygen to the brain, and you need an intact frontal lobe to fare well in treatment. The other issue, of course, is the coronavirus, and the cardiopulmonary effects of that can oftentimes result in different types of anoxic or hypoxic brain damage as well. So I think there's going to be more and more a need for the brain injury waiver in the future. One specific thing I wanted to mention on behalf of the brain injury community is 2 years ago, the legislature passed LD 297, which provided funding for neuro-resource facilitators and to help families navigate the system of care in the state, particularly those who are newly injured. That system is very fragmented for people with brain injury. There's really no home per se for folks with brain injury within the state service system. So I guess our request is, I think, a fairly simple one. Right now, those funds, those LD 297 funds are combined with a variety of other items in the budget under a specific line, and it'd be really helpful if those funds were more visible within the budget, possibly a line item in the future. Although I think what we're really looking for currently is to see if the LD 297 services could, again, just be more, could be specifically identified within the budget that the department has, rather than being combined with other things. And in terms of the brain injury community, that would be, I think, very meaningful moving forward in the future as we see, try to strengthen services and supports. So, and it would not cost any money. So anyway, but thank you very much. I appreciate your listening to our concerns, and again, appreciate all the good work that you do. So thank you, and happy to answer any questions.
Thank you, Mr. Wade. Appreciate you sharing that. Any questions by either committee of Mr. Wade? I do not see any. I appreciate you sharing your testimony and your patience in coming up.
Thank you very much.
Have a good evening. Next, our last person to give testimony is Laura Cortez. Hello. Thank you. Welcome.
Good evening. Thank you, Representative Peirce, Senator Claxton, Representative Meyer, members of the AFA and HHS committee. Thank you for the opportunity to come before you and to be last, apparently, today. Moreover, thanks for the hard work that you're doing. I know you have difficult decisions to make and certainly many more long days ahead of you. I'm Laura Cortez. I'm the Executive Director of the Maine Association for Community Service Providers. MAXB represents more than 70 organizations providing services and support to thousands of adolescents and adults with intellectual and developmental disabilities throughout our state. We are greatly encouraged by and support the provisions in the governor's budget to reduce the Section 29 waitlist and to raise reimbursement rates for Section 21 and Section 29 services for adults with IDD. Efforts to address our state's well-known funding and workforce shortage crisis are not new, but having the dollars dedicated to helping address it in the governor's budget is. So I offer my thanks on behalf of Maxby to Governor Mills, the department certainly as well as the staff, and the Office of Aging and Disability Services for their commitment in the budget to increase these rates to keep up with and reflect our state's minimum wage. Raising rates for IDD services will help ensure that provider organizations committed to quality care have the capacity to serve people coming off the wait list. The latter cannot be achieved without the former. As both are proposed in the budget, we support both provisions. I share concerns, however, expressed by others today that the dollars and rates of decrease of the Section 29 wait list assumed over the next 2 years may only serve to maintain the wait list at a current level. So more funding is needed to eliminate the wait list. Additionally, we're want to encourage support for funding to reduce the growing wait list for Section 21 as well. 1121 is the $11.21 an hour is the reimbursable wage component for IDD residential services. That's nearly $1 below the state's current minimum wage. As you certainly know, the pandemic has deeply compounded the pre-existing crisis. DSPs continue to leave for higher paying, less difficult, and now lower risk jobs. And recent estimates that we've shared with you is that our members suggest a loss of 1,600 frontline workers over the last 10 months. That's 16% of our workforce. The current rates neither support a competitive wage nor the hero or incentive pay this workforce deserves, nor are the current rates enough to further absorb ongoing pandemic costs, nor the rising costs of maintaining the medically necessary home and community-based programs for the thousands of Mainers who depend on them. Many of our members are the largest employer in their community. Together, we employ over 10,000 Mainers, including DSPs, clinical professionals, administrative services, contractors, and food services, and more. We thank the governor and the department for recognizing that the DSP workforce, predominantly represented by women, people of color, and new immigrants, deserve a much fairer wage. When we raise reimbursement rates, we're not only supporting this workforce and the people and families they serve, but we support our local economies as well. These long overdue rates, seeing these increased along with additional funds that we hope will be added to the supplemental budget to stabilize this workforce, together they set us on the right course to begin to repair and support Maine's fragile network of providers and the thousands of DSPs throughout the state who are dedicated to ensuring that individuals with disabilities have access to the care and support they need and deserve to thrive and live full lives in the community. We urge your support, and I certainly thank you for your time and consideration. I'm happy to answer any questions that you might have.
Thank you, Ms. Cortez. Appreciate you being here and sharing your testimony. Are there any questions by the committee? Seeing none, thank you so much for hanging in there and being our last public testimony for the day for this part of the budget. Appreciate it. So we've had a very long day, our two committees together. I'd like to thank Chairs Claxton and Meyer and all of the HHS committee members for spending our time together today. I think we heard a lot of great testimony, not only from the department, but also from the people that came to speak to us and then by the questions that you all asked. I know that your report back is due March 19th. We know that you have a lot of work in between now and then around this budget, but you are ably served by OFPR and OPLA, I know. So we look forward to having that conversation when you're coming back to share your thoughts and your decisions around this budget with us. I'd also like to thank the administration, Commissioner Lambrou, who joined us in the beginning of the day, and certainly another shout out to Deputy Commissioner Mann, who shepherded us through all of the many sections of this budget. And lastly, just a thanks to our staff, Mandy Shore and Maureen Dawson, for keeping us going today and alive on the IT, everyone who does that. We can't thank you enough. For the AFA committee members, we will be together again tomorrow morning at 10 a.m. We are moving on to the tax section of the biennial budget. The HHS section is done. Phew, we made it. And so we'll see you all tomorrow morning at 10 a.m. Chair Claxton, Chair Meyer, do you have any comments for your committee since we're all here still together, or are you good to go?
Thank you for your hospitality. I think we're all set for next week.
Excellent. Well, until tomorrow morning, fellow AFAers, we'll see you then. And thank you again, HHS. We enjoyed having you with us. Take care, and everyone have a good evening.